Hello.
Hello.
Hello, Balaji, are you able to hear me?
Yes, sir. Yes, sir. I am able to hear you.
Good morning, Shakuntala.
Good morning, sir.
Nice to see you, your pleasant, ever smiling and smart face. You bring energy to the auditorium.
Thank you, sir.
So in another couple of minutes, I will be starting a endoscopic septoplasty Madhu's technique and followed by cochlear implant.
Okay, sir.
Right.
Sir, Mike.
Nageshwar Rao,
Sir,
good morning.
sir. Good morning, sir.
Sir, very nice.
Yes, sir. Thank you, sir.
Right. I'll just going for scrubbing and I'll just show my
Sir.
simple septoplasty for even a beginner. He can easily do this, giving a straight midline septum.
Sir.
And Shankar Medicare is also there.
Sir.
Implant work is more.
Yes,
So by the time I'll finish off.
Yes. Excellent
Thank you.
arrangement, sir.
Thank you. Now we have arranged a second hall.
Yes, sir.
We got too many registration. If the hall is full,
Yes, sir.
another small VIP hall is there.
Yes, sir.
That is in the hospital in the first floor.
Yes, sir.
25 members can sit there.
Yes.
You get same audio, picture, audio, everything.
All the best, sir.
Thank
Thank you very much.
Thank you. Pardon. Ganesh, first case, start.
Good morning, everyone. Welcome to the 14th Entry to Entire Basics workshop in Madhumani Nursing Home. Now we have a warm-up session where sir will be demonstrating Madhu's technique of septoplasty. So this patient is Mr. Ram Subba Reddy. He is a 65-year-old male, has complaints of nasal obstruction and mouth breathing for the past 5 years. So his endoscopic examination shows a gross deviation to the left. Shows a gross deviation to the left and severe inferior turbinate hypertrophy. So sir will be doing an endoscopic septoplasty along with splints. The CT scan of the patient will be explained by the sir.
Good morning. You are? Okay. Last year. Right. Prakash has come. Prabhakar? Yes, welcome. Prabhakar is always an inspiration. చేసేసుకోండి మీరు చేసుకొని రెడీ చేసుకొని ఇన్ఫిల్ట్రేషన్కి లోపల నేను అయిపోగొట్టేస్తుంది. Ganesh, audio.
Now I request Dr. Shakuntala ma'am and Dr. to moderate the session.
Clean. Is my
I
voice?
also request Dr. B. Nageshwar Rao sir from Andhra Medical College to moderate the session. Thank you, ma'am. Thank you, sir.
Rohit,
Sir.
these moderators will continue the cochlear implant also.
Okay, sir. No.
Betadine. నా మాట వినిపిస్తూ ఉందా? Am I audible there?
Yes, sir.
Yes, sir.
So, this is the first case.
Sir has mic.
Exactly here's 8:35. So, 5 minutes, though delay. I am just betadine scrubbing of the face of the nose, for which we are planning Madhu's technique of endoscopic septoplasty with splints. These splints will give very good stability to keep the septum in the midline. You all know the septoplasty, whatever it may be, they are having deviated septum. After the surgery, it should be in the midline. Okay? In spite of you doing good surgery, post-operatively, they may touch and they may dislocate your made surgery. To prevent that,
Sir,
yeah.
what is the need of doing septoplasty in this elderly man? Is
Ah.
there
Shall I tell you?
Yes, sir.
It is really for the indication is for Madhumani workshop.
Yes, sir.
Because at this age, the main two functions of the nose are breathing and olfaction.
Yes, sir.
But he has come not that for a workshop. We have selected at a 65 years old man. All these years he is having septum deviation. But he has come with obstructive element, and we told that you are having a septal defective septum. He is a farmer coolie. So we also thought there are another cases, but even at this age of 65 years, we can operate under local anesthesia, and we have given Moffat's block endoscopy. I'll first show you my technique of infiltration. Okay, this is the secret of you are having avascular field and good this thing. One side. So I am taking a 0 degrees endoscope, applied suction, and this thing. Give me endoscopic picture, please. Light on. Are you able to see the endoscopic picture?
No.
Star Jima. And give me starch endoscope.
Now the picture is there, sir.
And
Many.
then I am just changing the endoscope. Yeah. Anything. So white balance, please. So we do white balance. Okay, right. Now you can see, give me syringe and a needle. Actually, to say frankly, this moustache or vibrie we can cut. See, there is a marked deflected septum almost touching the lateral wall of the nose on the left side. First I give infiltration onto the.
Sir, there is wobbling, sir. You please see that one. It's wobbling.
Okay. First infiltration is at the columnar and junction.
Sir, many delegates are coming, young doctors are coming now into the hall. What is the solution for infiltration? What is Moffatt solution? What is Moffatt?
I'll explain wonderfully well. Thank you
Yes.
for this thing.
Yes, sir.
See, there are 7 steps to do under local anesthesia in Madhu's technique. Number 1 step is proper counseling. Number 2 step is good pre-op preparation.
So what
That means giving an
pre-medication-
antibiotic steroid before surgery.
So what pre-medication did you use?
We have given prednisolone and levocetirizine montelukast, cefixime for 5 days before surgery for all our cases in Kaim. This gives some amount of any infective element, inflammation will come down. Third step is admission into the hospital. Night before surgery, we give atenolol 50 mg in spite of patient is having a normotensive. His blood pressure as per this is only 130. In spite we have yesterday given atenolol. So this I have given for septum. Suppose you want to do turbinate, first to go to the posterior half, just give 1 cc and give another 1 cc here. If you want to do FES, now your injection will go to the axilla 1, middle turbinate 2, posterior end of middle turbinate 3, and sphenoethmoidal recess 4. These 4 are usually sufficient and giving. I will pack the nose with a thermo wool. Are you able to see this structure? This is not a ribbon gauze. The ribbon gauze is always more traumatic for my experience. So usually I don't use a gauze piece. So orthopedics people will have a soft cotton roll, or this is called thermo wool. Now I am passing into the left nostril. Another, after packing, I'll just go to the CT scan and I'll explain my Moffat's block. By that time, 10 minutes, you will get a wonderful vasoconstriction. So this is a compressive 4% xylocaine, 10 cc with 3 ampoules of adrenaline. I repeat, 4% xylocaine with 3 ampoules of adrenaline are used for packing. Infiltration, it's called 888 solution.
Sorry, sir, I just want to interrupt. So 30
It's easy to remember. 888 means 8 cc of 2% xylocaine included. 8 cc of normal saline, 8 cc of xylocaine with 2000 adrenaline. You get commercial brands. Another 8 cc is normal saline. After that, 8 drops of 1 in 1000 adrenaline. So this is called my local nose surgeries infiltration solution, like 8 cc of 2% xylocaine with adrenaline, 8 cc of normal saline, and 8 cc or 8 drops of adrenaline. Now I have packed. Okay?
Sir, Madhu sir,
Now,
the adrenaline part you're repeating twice. You're saying 2% xylocaine with adrenaline, again 8 drops of adrenaline.
yes.
So no problem, sir, with that?
What happens, Shakuntala? Good question. 1 in 2 lakhs dilution of xylocaine, you have added 8 cc of normal saline. So it has become 1 in 4 lakhs.
Okay.
That is negligible.
Sir,
So,
and that for the packing, sir, can
packing
you just repeat?
3 ampoules of full 1 in 1000 adrenaline with 10 cc to 12 cc of 4% xylocaine.
Okay, thank you, sir.
So that is for this thing. Moffat's block, after explaining it's not much CT scan, focus on to the CT scan. Look at this. And Moffat's block, okay, by the time he comes, are you able to see the head of the patient?
No, sir.
I'll
The picture is
rendu
very
light
dark.
on cheyandi.
Picture is very dark and not clear.
Yeah, right. Light on cheyandi. Paina rendu on. Are you able to see the head of the patient here?
No, sir.
No, sir.
Now, okay.
Yes,
Okay.
now we can see.
So, what is Moffat's block? Moffat's solution you have to make 5 cc syringe. You first take half cc of 1 in 1000 adrenaline in a 5 cc. First you have to take adrenaline, not xylocaine. After half cc, you take 4% xylocaine, 4.5 cc. So
Yes, sir.
half cc adrenaline, 4.5 cc xylocaine. This becomes 5 cc of Moffatt solution. Once this 5 cc of Moffatt solution is there, we have to make the chin and external auditory canal into one vertical line. That means you have to bend the head or make the head to bend from the edge of the table or put 1 or 2 pillows so that it will be like this.
perfect
After
position.
bending, you bend the head 45 degrees onto the right side. Then you instill drop by drop along the lateral wall of the nose, so that majority of the sensory nerves, spinopalatine and anterior ethmoidal nerves, they get drenched, like when you are giving xylocaine block, spinal block, the spinal nerves get blocked at L2, L3 level like that. Same thing, we will keep it for 7 to 8 minutes. Repeat the same, turning the head to the opposite side. Your 2.5 cc is left over, that we will put here. So 15 minutes, the block is over. Only the superior labial nerve, columella part, will not get anesthesia. For that, when you are infiltrating, you give a small 1 cc at the base of the nasal spine. So this is the fourth step. And pre-medication, night before surgery, all patients get atenolol, rabiprazole, domperidone, and diazepam or Angsit, anything. All will be anxious. Let them sleep comfortably. 1 hour before surgery, we have given Fortwin, Phenergan, glycopyrrolate. On the table, we have given tranexamic acid and hydrocortisone, and IV started. Why all these things? Tranexamic acid is a wonderful hemostatic and tries to control capillary bleeding. By virtue, it has capacity to reduce 10 to 15 mm of blood pressure also. So that by atenolol and by tranexamic acid, whatever it be, a rhinologist will be comfortable if the blood pressure systolic is at the some 80 or 90. Okay? Now we will, with this Moffat's block, any doubt, I will come to Rafi in a pro viewer. This is the CT scan, this is the sagittal section. He has lot of, I think, dental fixtures. So see the septum, very grossly deviated. You can see almost 45 degrees bent, and there is a spur, and nasal spine is almost like a 90 degrees bent and coming down. So we have to break the septum from the cartilaginous and osseous perpendicular plate of ethmoid, remove the spine and spur and bring them and put splints and keep. No sinus surgery. There is not much turbinate of a 60 years old, and I do not want to go into the wasting time on all these things. This is ground lamella, posterior ethmoid, skull base, sphenoid, optic nerve. All these things are perfect. So now we will directly go to any doubt in CT scan. Otherwise, I will directly go to the surgical part.
So why don't you want to address the inturbinate hypertrophy?
Oh, okay. I'll show you. I don't want to do any turbinectomy because he is adjusting with this turbinate since 65 years. He is almost my age. So if there is obstruction, yes, to be on safe side, he has come all the way doing a turbinectomy for a couple of minutes, like infracture and again pressing back. That itself I'll give you, I'll show you that technique also.
Sir, good morning, sir, and Dr. Anil Kumar, sir.
Anil Kumar,
Sir.
good morning.
So, is this indication in 65-year-old patient, sir, septoplasty?
He is having nasal obstruction
Yes, sir.
and grossly septal deviation, and it's a beautiful case for demonstration.
So any
Light on.
advantage of endoscopic septoplasty versus open technique?
No, a bit louder, Shakuntala.
So any advantage of endoscopic septoplasty over the conventional technique?
A very good question. Majority of the people still, to balance with an endoscope and do this part of the anterior, they feel lot of difficulty. They usually take this thing, but we feel the maneuverability, approachability, availability, acceptability with the instrument, with the available space. If you start doing from tip of the nose, you will have more control, that's all. Blade. Now I will take the 15 number blade, switch off those lights too. So this is the main bulge, this is the skin, this is the mucocutaneous junction, okay? I am going to the mucocutaneous junction and giving a incision. Sometimes an L-shaped incision can also be given, go along the bony spur also if necessary. Now I think I have the feel of cutting the perichondrium. Now there are two elevators, one is Freer's, another is sharp elevator. This is a sharp elevator. So take a sharp elevator, my assistant is holding. I think I have already reached the flap. And take now Freer's. Once you are there, this just goes like a banana peel. Okay?
Yes.
And go at whatever level you want. Come down, come to the bony spur.
So you go towards the deviated side, sir?
First,
Elevation?
usually from the deviated side, and now this is the main crux is, this is the bent, like a 45 degrees of bent.
Yes, the spurs.
Okay? That you can see hardly very bent. Now I think I am happy. Now the bony osseous canal, everything. Now I'll go to the opposite side. So now here, first incision is here. So this is only by practice. You can do with a headlight, no issues at all. So now I am cutting the cartilage and coming down to that cartilage.
Sir, does the assistant have to hold the flap?
Yeah, assistant will hold the flap with a non-tooth forceps. My assistant is holding. Still I think I have not given authority. Yeah.
Sir, do we always have to do it on the convex side?
No, not necessary. But always it will be comfortable for the surgeon. And see now on the right side also I got the plane. Once I got the plane, this is the plane of perichondrium. Just keep it there with an endoscope and now take this and I will show you the elevation under vision.
The side of the incision is always from the left side because most of the surgeons are the right-handed surgeons.
Yes.
Nageswara Vijay, I am also
Yes, sir.
almost. Now are able to see my movement of my end?
Yes, sir.
Freer elevator, so go.
Yes, sir.
Everything is under vision.
Yes, sir.
So here will be the most bent and acutely 45 degrees bent septum, and here
Right-handed surgeons.
so I have gone to the most posterior part also.
Wonderful elevation, sir.
Yeah. And patient is nicely cooperating, the most important is.
Yes.
Okay, now I have done the job of elevating the flap and boson. Now I have to take the blade and dislocate, give me suction. Splints తీసుకోవాలి. So I would like to cut the septum seeing on the right side. Okay? And this is the exact
That is the spur.
junction.
Yes, sir.
This is the cartilage which is there, or you can come this side, palpate the bony cartilaginous junction. Okay, this is the bony I am coming down, cutting.
You're
Coming.
dividing the maxillary crest, sir. The cartilaginous crest.
Yeah, almost maxillary crest spur cartilage, Kuntala. So this is bony cartilaginous junction, but you should not go very high. It may cause some supratip depression. See, almost I have kept 2 centimeters intact. Now this whole septum, this is the bent of the septum, has to go away. Here this mucosal tears, everybody is worried. Why mucosa? Don't think deliberately also you can cause any mucosal tear that is not going to harm you in any way. Don't take it that unless you don't give a, without any tear, you are a super surgeon. Everything will set right because we are not, give me, now I have, after removing, there is still part of the septum.
The inferior part of the cartilage.
Inferior part of the septum, especially the bony. And this is actually almost going up to the bony cartilaginous junction. Give me. Now, after that, I had to make more inferior tunnel. Okay? Give me freer salivator. Once you have removed the space, now you see, here I have to make space to remove the curved, hard nasal spine. Okay? This is the most
So
which
now
we
you're
have
making
seen.
the inferior tunnel, sir.
Yeah,
You're
inferior
completing
tunnel.
the inferior
This is my hit point. I'll hit with my spine goose. Take a spine goose. This is a 2 mm spine, maxillary spine goose, and fix. Yes. See, with 2 strokes, this. But we are not actually traumatizing the spine. We are a bit posterior to the spine, nasal spine. And once you have done, you have to still see how much amount of deviation is there, that you will assess through the nasal passage. Here I am still separating the bone, and this is still appears to be a deviated bone. Give me. Yes. Now comes the final adjustment of this septum. How to bring to the normal midline. So this is the nasal cavity. So we have just made septal flaps and seen the cavity. Now if you go there, here there is deviation, here there is deviation. I think floor is some amount of deviation is still there.
Yes,
Or
sir.
this has to go, this has to be trimmed, and this has to go. So again, go from this side also. This side, it's okay, airway passage. If this comes to this midline, and our work is over. Now I am going back in between the flaps. Take a bone nibbler now.
So the bony cartilaginous junction separation, you won't take it up right up
No,
to the top.
I go with a very graded, because if you separate this Shakuntala with an freer salivator top to the between the lower alar cartilage, upper alar cartilage and septum, it will collapse.
Yes, the keystone
You will get
area.
a supra keystone area. You will get some amount of this is a bone marrow liquid, and see, I am just almost keeping this, and this is certainly easily can be removed to make it. If you feel that you want to keep, you can keep it. Coming to the floor, this bone,
I
not
think
necessary.
1 centimeter we should leave superiorly. Sir.
Keystone area. It's a must. Unless you are doing a rhinoplasty, I can make spreader grafts and all these things. Straight forceps. Okay? Now, the final part comes after this. See how much amount of space you got. But still there is some amount of material is there.
The spur is there, sir.
Yes. So I have removed this spur through the tear which we have made while doing a septoplasty. Need not worry, these tears will not harm, and when you pack with your Merocell, and these two edges will come and sit together, okay? This will not cause any...
tears are helpful, sir, to prevent the post-op septal hematoma.
Yes, but in nowadays with Merocells, the septal hematomas are very rare unless a big...
Yes.
See, I am pressing, and now are you able to see?
Yes, sir.
So
This approximation usually gets...
there is some spur left, I think.
And now, I am going to final part of my septoplasty. How you are going to make this most bent of anterior, this thing, okay? Now here go there, go to the dorsum, see the exact amount of deviation.
So posteriorly some spur is still left, I think.
So I take a blade, this is the junction, okay? Give me 15 number blade. Keeping a keystone, see the top still, I have not gone to the top. Almost here is 1 centimeter and another centimeter. So what I do is, go there, identify the junction. From here, I cut horizontally.
From posterior to anterior you're coming.
Yes,
Quadrilateral
posterior to
cartilage.
anteriorly. I think you are all understanding the concept of I am cutting the septum right. Now, with freer salvator,
I think here also you're leaving the dorsal
Yeah.
strut 1 centimeter. only.
this has almost come to the midline, but there is still bulge. I will give a intermediary cut on this bulge. Now, non-tooth forceps. Actually, this I do without endoscope.
So is that to break the memory of the cartilage?
Yes. Memory and some amount of space.
Straight itla. Improve better.
Okay? Got that window? Right.
sir.
Yes, sir.
Now,
So you're leaving the dorsal and the caudal strut.
yeah. Now, because of this anterior space, once I put a splint, this will come. There is still, I can sacrifice this projection. Because you see from the nasal cavity, you see this projection. Okay? So this projection will be again attended. Bone nebula. Take the splints. Just millimeter by millimeter.
So if it was a high DNS, then how would you address it without disturbing the keystone area?
This is high DNS, madam. This is one of the very high DNS.
So how
This is
far?
high DNS, but this part of the high DNS, if you want to attend this, it will collapse. It should not be attended. This is the main air space. This is nasal valve area. And when we keep the splints, I will show you. Keep the splints. Now my work is over. Last part, turbinectomy, I will show you. And this how I do, and how nice the septum will come into the midline. You will see the left side airway. I could not even see the inferior turbinate anterior end. Okay. Now my splints technique, this is splint. There are two splints. These are made by decibels. That's very easy to manipulate. Light, no paper. So I'll take a 30 Vicryl or anything, catgut, and you have to take back side of the hole, okay, and
Sir, can you show in closer manner, sir?
yeah. Are you able to see this thing?
It has holes in it.
Yeah. So this comes, the two holes will come anteriorly, 4 holes goes to the posteriorly. Now, so this it says.
Sir, you are kept in four holes, in near 4 holes.
Yes. It says, help me. Are you able to see? I have passed my needle there. I am not able to negotiate. Okay, now. So go there, pass, come to the opposite side and see whether the needle has come or not. Needle has not yet come. So that means it's somewhere in between the flaps. So take it out. I am changing the pattern of holding. Are you able to see?
So
With-
are you using 30 Vicryl?
Yes, madam. So now I am going there at the front of middle turbinate. I am pressing. Most probably it has to come, but because of lot of space, in such situations, what we have to do is, what's in there? Ah. My assistant says
See here
it
the
has to.
needle, the long axis of the needle should be in the long axis are parallel to the needle model, sir.
Yes,
Then only
now
can-
I have passed and now holding the needle and getting it outside, okay?
Yes, sir.
Now from here, again your tamasha starts. Like, take this needle. Again, this is the other side of the, okay, lighting chaala takkuva undi. Okay?
Yes, sir.
That side you have passed through the back hole first. So this side also I will pass through one hole, bring it outside, bring from the most anterior front part of the hole. This has come, okay?
Yes, sir.
And this goes into the right nostril. Take a non-tooth forceps, top light, you can see much better. I am taking a top forceps like this. Is it visible there? Overhead camera chupichaya.
Yes, sir, yes, sir.
Right. This is the septal flap. So I am taking an incision from the columella here. Sorry. Right. And you can take the edge of the septal flap. Now, the final through is the anterior most hole on the septal splint. Okay?
Yes,
Now,
sir.
this goes on to the left side. But here comes again tamasha. You should not think that I have passed the splints. You have to be careful that they are, if the fess is done, light this. If in septoplasty it's okay. I am between the middle turbinate and the septum. Okay? If you have done some fess, this has to be between the lateral wall of the nose and the middle turbinate. Okay? And again come this side. See? This side it has gone into the middle meatus. Not necessary. So come forward, take the middle turbinate out and pass it high and see that this, and you can cover what we were telling in the lower part. So your splint will come down to cover this area. Okay? There is a small piece of bone. The final result, you can see it will be very good. With this, take your needle holder. My assistant will hold the camera. He is holding both these splints in his forceps.
Can you show us the suture? The
Yes,
camera is,
madam.
the light is not visible.
Light is not there. Dark pictures.
My top light, Ima. Madam, is it clear?
Yes, sir, it's better now.
Yeah, but now see, my assistant is holding the suture. I am tying the knot, another knot. Okay?
Yes,
now
sir.
I think scissors, you can see the splint which is there in between this and this. Now I'll show you this brief step of turbinectomy. Light off and only endoscopic camera.
Sir, you don't suture the flap, sir?
What flap? I have sutured kada. Ayipindi.
He's opposed
See,
with
this
the
is the
splint,
flap
so
I have
there's no need.
sutured. See, on the left side nasal cavity, the tear is covered, everything is covered. This is the middle turbinate, this is the middle meatus, this is the posterior part, gone almost up to the posterior end of the septum, and here I have covered. The septum has come almost straight,
Yes.
and on to the right side, the dip is gone, and here middle turbinate. Now, what is this patient doesn't need turbinectomy? I am telling in fracture or inside fracture, I am feeling the tuck of the septum, turbinate. Then what you do, take this BP handle, press towards. See, there is good appreciation of space. What else you want? Because doing turbinectomy in these patients doesn't necessary. Here also, see, tuck. This turbinate got fractured at the shoulder. Again, press it back. Give
So
me
you-
10 centimeters merocell.
So you in fracture and then you down fracture it laterally.
Super, super, correct. See the amount, see when we started the surgery, I could not even see the anterior end of the inferior turbinate. Now, it's almost, this is the Blackesley 5 mm, 1 centimeter of space is there created. And see the septum, how nice in the center, and you can see the flap, no tear, all will cover. Now at 10 centimeters merocell, just put like this, goes there, take another merocell like this, and this thing, and I am sure if you, this is Madhu's technique of endoscopic septoplasty and using Teflon splints, 90% of patients in the first post-op, we will remove these splints on the 7th or 10th day only. Please take it into your mind. You should not remove these splints 2nd day or 4th day. Merocell you can remove after 36 hours or 48 hours, but splints should be kept more time because the memory, spring action, curvature phenomena all have to set down.
Excellent demonstration, sir.
Right, thank you, madam. I think
Excellent
you can.
demonstration, sir, with stable septum, remaining of the septum.
Yeah.
Again,
I think this is the bread and butter for any PG or a postgraduate.
Yes, sir.
If
There
you
will not
learn
be
this
any-
technique, and
there will
patients
not be
will
any
be
future
happy,
Seneca also.
nothing to worry. Sir, we will switch over now. It's 9:16. We started about, I think, 8:36. Half an hour because of explanation. Usually I will do within 20 minutes, 10 minutes because of explanation. Now we will go to the laminar OT. Dr. Shankar Medikeri, a beautiful 2 years old, 3 months cochlear implant.
Thank you, sir.
Thank
Any
you, sir.
doubts?
Sir.
Sir, for high DNS, is it necessary to address, sir?
Yes, yes. High DNS has to be addressed, but not compromising the supratip collapse. This is the bony wall. This is the cartilaginous wall. When you adugutunnara?
Yes, sir. Yes, sir.
Only high deviations need not to correct.
Adi anta,
unless
tippu
you
na
go to the
Are you able to see my
other
hands?
purpose.
No, sir. No.
Na vaipu tippu. Now, are you able to see now?
Yes, yes.
sir.
So this is the thing, that's bony canal, bony cartilage. This is cartilage and bony septum. When we separate, this is the roof of the nose, bony upper lateral cartilage, lower lateral cartilage. If you go straight up for higher deviation, this patient will develop a supratip itla depression vastundi, itla undakunda.
Yes.
So at least 1 centimeter at the keystone area. Keystone area means septum, upper lateral cartilage and nasal bone. That is keystone area.
Junction.
That should not be disturbed. In a septorhinoplasty, you can disturb because you put a spreader grafts. Once you put a spreader grafts, you suture. So valve phenomena will be very good. But in routine septoplasty, it is very stimulating to pass your Freres elevator between the cartilaginous and bony septum and go up. You can, just a single stroke you can separate. Total quadrilateral cartilage will get loose. Bony there. 100% that patient will develop supratip deformity. For that also there is a technique, but we will switch over to laminar. I request delegates not to come into the cochlear implant OT because Shankar Medikeri says it's a most sterile surgery we are doing in laminar OT, not much visitors, but everything will be shown to you. After that, majority of surgeries will come over here. Hope my endoscopic warming up session, septoplasty, this is to check the audiovisual system, image clarity, surgeon's voice, your communication from the moderators and delegates.
Yes.
Thank you very much. Enjoy
Thank you.
your
Thank
2
you,
days
sir.
and give your feedback. I'll switch over to the Ganesh. Laminar OT switch over, camera, voice, everything.
These septal splints are also very useful after synechial release.
Wonderfully useful. They very cheapest material. And previously when these septal splints were not available, I used to use unexposed X-ray film.
Yes,
So you
sir.
can cut in the same shape, but now it is available hardly some 100 rupees. So
Yeah, it's available with the decibel. company.
decibel and you throw it off. There's not much this thing you can keep.
Who is going to tell like this?
No, name sir.
उतना ही है क्या फोकस यस बॉस रेडी आई एम रेडी if somebody will tell about the case you tell about the case to somebody
Are you able to hear my voice? Is there a mic here?
my mic is on मेरा
Hello?
Yes.
Hello? Anybody from auditorium? Ganesh? Laminar OT to auditorium.
Sir, Dr. Madhu sir.
Hello?
Hello, good morning sir. Dr. Shankar Medikeri sir.
can you hear me
Yeah, we hear you sir. We hear sir.
Okay.
I'll give you
All
a
the
brief
delegates
history.
almost have come sir. The hall is full, packed with delegates.
okay thank you now
We
Dr.
are-
Madhusudan will give you a brief history about the
Yeah, yes,
patient
Yes sir.
then I will tell you what I have done and what I am going to do now
Sir.
Okay.
This 2 years,
3
7 months, Deva Harshit, a male child coming from Anantapuram, congenitally born deaf child. He has come early and we have investigated and there is a history of consanguinity, and the pre-operative investigations bear a 100 decibel loss both sides, so severe to profound sensorineural hearing loss. We have given 2 months of pre-op hearing aid trial, all investigations, MRI, CT scan, vaccination and everything. Patient is ready and fit for implant. Now, the most senior surgeon started in 2004, 20 years.
Yeah, scan you will show or you will later? Scan.
CT scan. Shall I show? Or?
Yeah, you can show.
I'll just show the brief CT scan. Riyaz oka chinna pulla iva. Camera can focus the CT scan.
Basically, this is a normal cochlea and a normal cochlea now on
Yeah.
both the sides.
The,
There is only a little high jugular bulb on the right side where we are doing, but
Yes.
that is covered with a bony covering.
I quickly follow. This is the axial sections of the temporal bone. This is the posterior semicircular canal. This is posterior semicircular canal. This is the starting of internal acoustic meatus, which is other than the cochlear canal, where 4 nerves will be there. We are operating on the right side. So this is clearly you can see the labyrinthine part of the facial nerve. And again, horizontal with geniculate ganglion. Now coming over here, it is clearly the horizontal part of the facial nerve is clear seen. Ice cone appearance, well pneumatized mastoid, that is most important. All cells are good and this thing. And here you see the modulus. You can see the cochlear nerve, basal turn and middle turn, very good thickness of the cochlear nerve as per MRI. We are all concentrating on the right side. Now you can see the sinus tympani and ossicular chain is disappearing. And here is the main part, the round window, and this is the aqueduct, and this is the sinus tympani, facial recess, and this is the long process of the incus, and this is the external aortic canal, and you can see the high jugular bulb. This is almost coming to the base of the round window, but there is a bony layer, so need not worry. So we are going posterior tympanotomy approach, posterior incision, go between the fossa incudis, where short process, from there chorda tympani anteriorly and facial nerve posteriorly, superiorly the fossa incudis and the V. That is the space we get, and go into the middle ear and we insert the canal. Very good wide canal of the external aortic canal. And MRI scan shows good 4 nerve view. In brief, this is the cochlear implant, minimum radiological, but this itself is a big topic. Over to Shankar sir.
Yeah. So, can you hear me?
Yes, sir.
Okay.
Sir,
Yeah.
can we participate actively, sir?
Yeah. No, can you see the microscopic picture?
Yes, sir.
Pinna.
Yes, sir.
So, this is the right side. You see, I just marked the incision. This is my regular minimal incision, just like your regular post-oral incision, with a little extension posteriorly, superiorly. Okay, this is the incision which I am going to take. It is about some 2 to 3 millimeter from the groove. And can you see this line? This is the orbitometer line. I felt the orbit and the external aortic canal and marked this line. I have extended this line posteriorly, same. This is because I want my receiver stimulator to lie 45 degrees to that. See, now I am putting the template. This is the template for the speech processor. Speech processor is going to sit like this, and my receiver stimulator template, can
Sir,
you see
what is
here?
the ideal flow? Yes, for cochlear implant surgery.
This should be about 45 degrees to this line.
Sir.
Okay? So I am going to create a subperiosteal pocket in this direction. So when you mark this, the anterior margin of this and the incision, at least there should be a space of about 1.5 to 2 centimeters. So that when the patient wears the processor later, it should not rub against the anterior edge of the receiver stimulator. Otherwise there will be a necrosis and implant might get exposed. And now what you are seeing here, I have kept a betadine wick after washing the ear canal. This is soaked in betadine. This is only as a precautionary measure. Accidentally, by in case if you open the external aortic canal during surgery, the betadine will come into your operative field, and before seeing the cut, you will definitely know that you have injured the external aortic canal. Okay. So now I am going to start. So, knife please. I have already injected 2% xylocaine with adrenaline at the incision site and the subperiosteal pocket site, 50 number. Yeah. Okay. So I am just starting, madam, I am starting. See, one thing, young children, you have to be careful about the mastoid tip. This child is about 2.5 years old, little more than that. So there is no issue. If you are operating on a 1 year and below 1 year child, you have to be careful. Your inferior part of the incision will be little higher up. Gauze. Hold this. Bipolar.
Sir, you have done number of surgeries, especially CIS surgeries. What is the lowest age group and what is the highest age group? So in our series of
My
implants,
lowest age group is 9 months.
9 months.
And
yes.
highest age group is 78-year-old.
78.
78 year
Yes, sir.
adult. Post-lingual deafness.
Sir.
Press. We have a big series. I have been doing this implant surgery for the last 2 decades. Almost, we have about 900 plus implants in our program. And not only that, I have mentored about 40 ENT surgeons in different parts of the country and even in few abroad like Sri Lanka and Vietnam.
Sir, do you do only the posterior tympanotomy technique or the varia also?
No, I do only posterior tympanotomy technique. I don't do varia technique.
Okay, sir.
In this series of your cases, how many patients are having congenital abnormalities? What is the most congenital abnormality? What are the contraindications of those cases in your experience?
Okay. I can say maybe about 10%. I don't have very high incidence
Sir.
of anomalies. Commonest was this incomplete partition type 2.
Yes, sir.
We had 2 common cavities.
You mean
Otherwise-
Mondini's?
Pardon?
You mean Mondini's abnormality, sir?
Mondini's
Mondini's
dysplasia.
dysplasia.
Mondini, yeah. Earlier it used to be called as Mondini.
Yes, sir.
Now it is called incomplete partition type 2.
Yes, sir.
Yeah, it is usually associated with a large vestibular aqueduct. Okay, now the thing is I am elevating 2 flaps here. One is the skin flap, which I have elevated now anteriorly. Okay, hold this. Forceps, tooth forceps. This is a skin and subcutaneous tissue, and another one I will elevate posteriorly, leaving the periosteum.
Again, what is the advantage of MRI over the CT temporal bone in CI surgery, sir?
See, MRI, you can see both the cochlea and cochlear fluid field, whether the cochlea is fluid filled or not. Especially in cases of post-meningitic hearing loss, only CT will not tell you whether there is a fibrosis or is there a fluid in the cochlea or is there any bony obstruction. That is very important. And of course, for studying the nerve,
For post-meningitis patients, there is a chance of ossificans. Then have you implanted any dummy implants prophylactically in your experience in a child?
what is that?
Dummy implants prophylactically
Huh.
for children who are suffered from post-meningitis, post-encephalitis.
See, you cannot know when the meningitis, this thing is going to, if you see that there is a hearing loss post-meningitic,
Yes, sir.
when they come for the follow-up, better to do the scans early. And post-meningitic hearing loss is one of the otological emergencies in ENT practice. So, if they have a profound degree hearing loss, and if your MRI scans show that it is a fluid-filled cochlea, and you audiologically prove that he has got a profound degree hearing loss, which is not going to be benefiting with the hearing aid, so it is better to go ahead and do the implant as early possible.
Sir.
So because this fibrosis and all to set in, it might take 15 days, 1 month, or it might take sometimes couple of months also because always it is better to insert the electrode in the cochlea before it gets ossified or fibrosed. So you will have a better results. Whereas the surgeries, whatever you do, once the fibrosis or ossification happens, like either you put a double electrode array which used to be available earlier, and or if you do a drill out, the results are not that good. See, you saw now our retractor, small retractor. Yeah. Now, after elevating these two flaps anteriorly and inferiorly, right angle, I am going to elevate the periosteal flap. Small right angle.
So the camera is not focused, I think.
Fine focus, sir. We need fine focus.
Fine focusing is required.
Oh, 1 minute. Hold this now. Put one here, one here.
Sir, when there is a cochlear nerve hypoplasia in the
Can you see
MRI.
now? Is it okay? One more.
Yeah, now it's okay, sir. When there is center, please centralize the picture, sir. Yeah.
Yeah.
Please. Good, sir. Good, good.
Yeah. See, now I am taking there are different ways of periosteal flap. You can take an anteriorly based flap or a posteriorly based flap or a superiorly based flap. I prefer to take a superiorly based flap because initially I was doing that anterior posterior flaps. We always used to end up at the end of the surgery when you suture periosteal flap, there used to be some gap, and sometimes especially posteriorly the implant part used to get exposed. So whereas this superiorly based flap, which is based on the temporalis muscle, so we have found it will absolutely not leave any gap. Okay, I have taken this along the posterior canal wall, the anterior cut, turning it U at the mastoid tip, and then going posteriorly and superiorly. Can you see this?
Yes, sir.
I have a wide based periosteal flap. So elevate this. See, it is easily elevatable, periosteal elevator. Big one. Yes, yes, at the posterior incision when you make, sometimes you get an emissary vein. So one has to be careful, it has to be controlled immediately. Many times with the bipolar you may be able to, otherwise sometimes you require bone wax. Because these are very young children. As I said, this is a 2-year-old child, 2 and 3 months or 3 or 4 months, something like that. So see, this is the subperiosteal pocket I have created. Any blood loss, see, even the 10% of blood loss will cause a lot of hemodynamic instability.
So are you talking about the mastoid emissary vein?
Yeah, yeah.
Yes, yes.
So where exactly will you encounter it? Can you show
See,
us?
most
please?
of the times when you make this posterior cut on the periosteum, here.
Okay, sir.
Again, the mastoid emissary vein position differs from the age. In the elderly people,
Yeah.
it's little more anterior when compared with this
Template.
adults. So you should look for the mastoid emissary vein when you give the incision,
See, I don't know why there
especially
are so many
the
instruments.
children who are going for implantation.
Record. See, now I am putting that template what I used to see my whether periosteal pocket is sufficient. It is little tight, but I want a tight pocket because I am not going to suture. Some people do this anchoring of the processor, receiver stimulator. I don't do that. Sometimes suction. But depending upon the curvature of the skull, you may have to little bit manipulate. It may be sometimes going little bit superiorly or sometimes little bit posteriorly.
So are you inserting it at 45-degree angle when you are
Yeah.
inserting that?
No, that is what I am telling you, exactly 45 artery forceps. See, now that my template has gone in completely, I am going to take it out. Final positioning we will do once we do the just hold this. There is some little bleeding, I will just check. You should not leave behind this template. I am telling you, it has happened. This is little more thicker. Sometimes the cochlear template is bit thinner. You won't notice. You put it like this. Then if you forget to take it out, with that only you will just put your implant also at the end. Later on you will realize when you take the check X-ray. Yeah, I have removed. It happened with one of my mentee surgeons. Next day I had to take it out by a separate incision. When we took the X-ray to see the electrode position, we noticed
Sir,
that.
the picture has to be centered, please.
Yeah, 1 minute.
Please centralize the picture and find focus, sir.
Yeah, just give me 2 minutes. I am going to just put the stitches to keep these things elevated. You give me the stitch. 20. Though I am using the scissors, I am using the mastoid retractor. I still prefer to put these stitches whenever later on when I take out the mastoid retractor for putting the implant. Okay, but yeah, hold this. Cut, cut. I'm just putting 2-3 stitches to hold the pinna anteriorly and to hold this posterior flap backwards and this periosteal flap upwards. Hold. Cut. If there are any other questions, you just keep asking.
Sir, related to radiology of this temporal bone CS surgeries,
Huh.
the MRI, how can you assess the cochlear nerve? Is it hyperplastic or normal cochlear nerve? And
See, in for assessing cochlear nerve, there are two views. We can take as an MRI of the brain and the CP angle axial cuts,
yes, sir.
where you will see the nerve bundle with the main facial nerve, and then in different cuts vestibulocochlear nerve, and you will also see the vestibulocochlear nerve getting dividing into cochlear and the vestibular nerve. Otherwise, best thing will be to have a oblique sagittal view of the internal auditory canal MRI, where you are supposed to see 4 nerve bundles. Okay, anteriorly you will see the superior vestibular. Posteriorly you will see
Facial nerve.
Facial
superior
nerve.
vestibular and inferior vestibular.
Yes.
Anteriorly you will see the facial and the cochlear nerve. Facial will be antero-superior and cochlear will be antero-inferior.
Yes, sir.
So the
Sir,
size
can
of the
we-
cochlear
sir,
nerve.
can we assess the cochlear nerve size in relation to the facial nerve?
Yeah,
I say the cochlear nerve is hyperplastic means there is a hyperplastic facial. The facial nerve is thickened. Is
Yeah.
it right, sir?
No, the facial nerve will be normal, cochlear nerve will be hypoplastic. Normally the size, small elevator could. Normally the size of the cochlear nerve should be slightly bigger than the facial nerve. If the size of the cochlear nerve, Madhu, is a fine focus cell is it?
Fine focus is small noise. You just rotate that.
Oh.
In what way this 1.5?
Can you take off my specs? It's getting fogged. AC is on, no?
Sir, in what way this 3 Tesla MRI is superior to this 1.5 Tesla? Can you comment?
See that how it is superior, that I think the radiologist will be able to
Labyrinthitis
tell.
also can see.
You'll get a better delineation, or I don't know if Madhu can comment anything on that.
Sir.
Artery first, could it? Tooth first.
Nageshwar Rao,
Sir.
you are
Take one,
telling about the
saline in
cochlear
one
nerve
bowl.
thickness
Yes, sir.
and delineation in a radiological. Certainly 1.5 it will be less compared to the 3 Tesla MRI.
Yes, sir.
But in a routine way, because we are not having any 3 Tesla in Nandyal, it's a very costly machine. But 4 nerve view, that is more important MRI, where you can see both facial, cochlear, superior vestibular and inferior vestibular.
Yes, sir.
If these 4 nerves are good and the dimensions of the cochlear nerve slightly thicker than the facial nerve and everything is okay, that is the criteria.
Sir, can you show us those features on MRI?
Yeah, yes, they will give you.
9 millimeter, 0.8 millimeter,
Yeah,
or 1
they will give
millimeter.
you.
No, 1 millimeter or no, one more retract.
MRI is mainly for the nerve creditability and whether it is going into the modulus, thickness at the modulus and turns and this thing. CT scan for your structural abnormality of the bony compartment, you are doing a posterior tympanotomy, what I am going to face like that.
See, Ivan,
Sir,
the hypoplastic cochlear nerve,
Sir.
in a standard condition, we say that the nerve should be completely normal and cochlea should be normal. But now they're doing we are doing implants for cochlear anomalies, different types, and even when the nerve is thin, of course, it's not only by radiological evaluation, you have to follow up with the audiological evaluation, and if there is a behavioral responses, then there are some special tests, elevator, drill ready ಮಾಡ್ಕೊಳ್ಳಿ, called some early speech perception test, pattern perception test, all those things will tell you whether nerve is okay, it is working even though it is thin. I have seen some patients where the double internal auditory canal, but no nerve was seen, but audiologically the patient was giving responses. Even with aided audiogram, one side she was showing a little better responses, almost close to the lower part of the base, speech banana. So in that case, in such cases, you can go one step, drill code. Go ahead and then do something called as a transtympanic EABR. That means you open the middle ear and put the electrode, there is a Golf electrode, cutting, which you can put in the round window and stimulate and see whether you are getting the wave 5. So if you are able to stimulate and get the response on the EABR, then you can go ahead and implant. Where is the drill?
So a little bit of fine focusing is required.
Finer focus.
Sir, when there is vestibular
it
duct
better?
enlargement, sir,
Is it
define
better now?
vestibular duct enlargement. What is the difficulty when there is vestibular duct enlargement in case of CS surgery?
Okay. Camera, yeah. Okay. 1 minute. Now you can adjust this. Is that okay
yes,
now?
Sir. Yes, sir. It's
Sir.
better. It's good now.
It's very
Yeah.
good.
So
The
this is
second
the external auditory canal.
Yes, sir.
You can see I just exposed. It's coming out now. Now I'm going to do a mastodectomy. The cortical mastodectomy. Like
Yes, sir.
the difference between the cortical mastoid, what you're doing for implant and for CSOM, is that in CSOM you usually saucerize all the edges of the mastoid cavity, whereas here we want to leave an overhanging edge, bipolar.
Yes, sir. So
Just
that the
press.
electrodes don't slip out.
That is just to keep the electrode array loop within the mastoid cavity, so that it will not come out easily. I'll just show you when we put the electrode array. Yeah, drill. want, you can change the burr. You want only round burrs, huh? No conical burr. Okay, I'm just marking this posterior canal wall, along the posterior canal wall, and the suprametric crest and the posterior margin. Okay. You had seen in the scan that it was a very well nematized mastoid.
So what size burr are you using?
So this is, I think, about 4 mm. That another burr was not fitting properly.
Regarding burr,
Burr.
the maximum number of varieties of burrs are needed in cochlear implant, and we are strong fans of Acumed, ACUMED. This is an American micro drill company. Really, they give you TC, tungsten carbide burrs, very sharp.
So very sharp means you have to be very precise.
Very careful also, sir. Speed.
Yeah, you have to be very
Yes.
careful.
Yes, sir.
For
Your
the
hand
benefit
has
of-
to be very steady.
Yes, sir.
For the benefit of the postgraduates, in the cortical mastectomy, simple mastectomy, the best landmark to avoid injury to all the vitals like your lateral canal or your facial nerve or sinusoidal angle or sinus plate, the best landmark is tegmen tympani, tegmen entry. Always follow the tegmen, that is the best landmark, and do dissect the other areas from the tegmen. The tegmen is the best and safest landmark for cortical mastectomy or simple mastectomy for the beginners, postgraduates.
Yeah, exactly. See, as you saw, I am leaving this overhanging edge outside. Suction change ಮಾಡ್ತಾ ಇರ್ಬೇಕು. We have a
We are already seeing the
Diamond
lateral
burr?
semicircular canal bulge.
coarse damage.
I think you are able to see the lateral semicircular canal bulge.
Yeah, lateral
Yes, sir.
semicircular
Yes,
canal
And
is seen.
incus also, it's glancing
Incus is
at
not
you.
at, so yeah, it is little.
So that two landmarks are good.
Sir, what is betadine sign?
Pardon?
Betadine sign.
Betadine sign, yeah, betadine sign is, as I told you, I have put that betadine wick in the ear canal. Here, when you are doing posterior tympanotomy, if you go too much anterior, sometimes people are scared of the facial.
Okay.
So they go more anterior and then they land up opening the external auditory canal. If you open and if you injure, then the betadine will flow into your operative field. That is called the betadine sign.
For two things, posterior tympanotomy is a bit disadvantageous, feel say. One is facial nerve. Second
you
thing
see
is
the
you can injure the external aortic canal and enter the middle ear. You can cause
Yeah.
some rent in the external aortic canal.
Can you see the incus there?
Yes, sir.
Body of the incus
Yes, sir.
Yes, sir.
and the
Sir is
process.
thinning the
Short
posterior
process
canal
also.
wall.
We
now
can
I'm
see the
thinning the
short
posterior
process of
canal
incus.
wall. The canal wall should be quite thin,
Quite
as much
thin.
as possible, but don't make any buttonhole in the canal bone.
Yes. When you see, you should have a good straight trajectory view of the round window through the posterior tympanotomy.
Yes, sir.
Yeah. See, there are two things. Your posterior canal wall has to be thin, and your posterior tympanotomy should be big enough to see the promontory, incudostapedial joint, pyramidal process, stapedius
Yeah.
tendon,
Yes.
a round window niche, and a bit of hypotympanic cells. I am telling because sometimes people have mistaken a hypotympanic cell for
Yeah,
round window,
window.
and ended up putting electrodes in the wrong places.
Sir, you have shifted to diamond drill now, diamond burr tip.
Yeah.
So when exactly do you shift to diamond burr from
No,
cutting
this is
burr?
a coarse diamond.
Yes,
Coarse
coarse.
diamond is one thing good is it cuts very well,
Yes, sir.
but at the same time, even if it exposes any soft structures, it won't cause much injury. Now, initial part you saw that initial work I did with the cutting burr. then I shifted here. No, 3 mm cutting bar. Sickle knife kodi. See, now I am showing you see, this is the posterior canal wall. I might thin it little bit later depending upon the requirement. This is the incus,
Yes, sir.
this is the lateral semicircular canal,
Yes, sir.
this is the incus pointer, this is the lateral semicircular canal. Your facial will come somewhere here at a depth deeper than the lateral semicircular canal level. So my area of interest for posterior tympanotomy will be the incus buttress here and the facial canal, and chorda might go something like this. So in this triangular area I have to open the middle ear. As you can see, the triangle is wide superiorly. As you go down to the chordofacial angle, it becomes very narrow.
Yes, sir.
So
The
my
apex.
idea or my suggestion will be to saucerize this whole area, and then last part we open first just below the incus buttress where it is wide, and the moment you open you will see you should see, may be able to, the incudostapedial joint. This is 3 mm, is it? It looks smaller.
This is the most crucial step for implant surgeon. So, posterior tympanotomy. Shankar sir has explained you very well.
Yeah.
So now you have changed to what bar, sir? Can you please tell us?
This is the 3 mm bar, cutting bar.
At this moment, how can you identify the facial nerve, sir? What are the warning signs to avoid injury to the facial nerve here?
Best will be, which you don't have it here,
Sir.
I routinely put the facial nerve monitor.
Yes, sir.
If you put the monitor, heat or even the mechanical transmission, when you are close, there you can even adjust 0.5 millimeter, 1 millimeter, 1.5 millimeters. Whenever at that distance itself, the monitor can give you a clue. It will beep. That will be the best possible if you can have it. So otherwise, when you are close to the facial canal, another thing, sometimes the bleeding will start. See, always while drilling also, you drill horizontal to the facial here in this area.
Yes, horizontal.
Okay, don't go vertical like this.
Yes.
Yes, sir.
So even if by chance you are exposed the adventitia and not cause. And another thing is, sometimes you will get some cells here. Can you see one cell
Yeah,
is here?
sentinel cell.
Sentinel cell. So if you get cell, you may be a little bit lucky to enter it faster, or it might take time. Sometimes it will be very sclerotic. So smaller section could it? Can we?
Because I am not having facial nerve monitor,
Yeah.
my two indicators that you are at nearer to the facial nerve, one is, as Dr. Shankar sir told, bleeding. Number two is the feeling that you are touching a soft part. Suppose a ball point
The
or a
tactile
needle or
sensation,
a
the
drill
tactile
bit.
sensation of the bar is different.
The
The
posteriorly
dullness.
you feel like a glistening white, pearly white is there, that is must be the sheath of the facial nerve.
Yes.
Bleeding, immediately you use a ball point or a needle to touch, is it soft? If
Yeah.
it is soft, it is facial nerve.
A
If it's
pinkish
still
nature,
hard,
sir.
that means there is
Pinkish
a bony
appearance over the facial canal.
On the diamond could it?
covering. Your
2 mm.
CT scan study also
2 mm diamond bar.
shows, if you DICOM and you have a CT scan study, the facial nerve cut,
Could it?
you can trace the distance between the posterior tympanotomy where the
There are the suction tips.
You mean the depth of the
Facial
facial
res-
recess, sir?
huh?
Radiological assessment of the depth of the facial recess.
Yes,
It
you
should be
can-
more than 2.5,
Yes.
2.3 millimeter in size. That's the ideal one, ideal facial recess for
Yes.
this. Radiological assessment.
So I change to the diamond bar again.
Now, sir has changed to the diamond bar.
Yes, sir.
And always safe if you are not sure with diamond bar, injury to accidental exposure of the nerve is less. Cutting bar, more damage.
See, as I telling you, from incus buttress to down here, I have saucerized that area. Can you see that?
Yes, sir.
I didn't drill like a bore well in one particular area, only here. Should not do. You should saucerize this area, make it thinner and thinner, and then you open the middle ear. See, now I'm drilling on the facial canal or close to the facial canal, but never drill vertical, drill always horizontal to the facial.
Sir, the lower limit of the drill, sir, here is it cardofacial angle or beyond that?
What is that?
The lower limit of the dissection post tympanoid, is it cardofacial angle or beyond that?
No, only up to the cardofacial angle.
Yes.
See, can you see here? I opened the middle ear,
Yes, sir.
just below the incus buttress.
Yes, sir. We can see that.
All of you can see.
Yes, sir.
See, this is the safest area to open. I am already seeing and then you can go on extending it down. Because now we have
Cardofacial
the
triangle is very good.
thin
Base
bone.
is at fossa incudis. Apex is at fascia and chorda tympani junction.
Cardofacial angle.
Yes, cardofacial angle. Now, sir, has almost
So
entered
smaller-
the middle
smaller.
ear. You should be able, now we
Smaller
should
per-
see the
oh.
IS joint.
I will show you once I complete the posterior
Yes,
tympanotomy.
tympanotomy.
I will show you all the, as a beginner, what all structures you have to see
Yes.
and what should be your exposure. Can you see that?
Yes, sir.
So now we
Stapedius
can
and
see the
stapedial joint.
stapedial tendon
Yeah,
also.
we can
see
easily
the
see that
IS
white,
joint.
small,
Stapedial tendon, you
pearly
can see.
white globular structure.
In the post tympanotomy approaches, the best landmark is pyramidal process, sir. Then you have to follow, then there will be a stapedius tendon and the best landmark is pyramidal process, sir.
You can see the stapedial tendon very well and the
Yeah, from the
IS
pyramidal
joint.
process, the stapedius tendon.
I should thank profoundly in all of, amidst all of
You
you.
already started seeing the round window also a little bit.
Yes, sir.
Yes, sir.
Yeah. We can see the anterior lip of the
Round window.
Round
Round window.
Round
So
window.
And you can see the
exposing
black
inferiorly
change.
now.
That is the round window membrane area inferior. The niche.
Niche.
Very nice, sir.
See the
Very
niche.
nice dissection. Dr. Bhaiya
I'm going to the-
Srinivas Rao, Dr. Raidu, and Dr. Sudhir. These
Okay.
three people are my mentors,
Oh, very
sir. They came to Nandyal and made me to do,
good. See, now another important thing is,
sir.
see, I'm just seeing the anterior lip. I want the full round window. See,
Yes,
I am not still close to the facial. Facial, see, lateral semicircular canal is here. The facial will be still deep. I can drill this bone very comfortably.
Very
So
comfortable.
now what you do is the
See.
bone on the facial now, anterior to the facial now, whatever,
This will
that you
give
can keep
very
on
good
drilling.
trajectory. Gives view onto
will
the
give
round
a
window.
better view of the round window and a better trajectory you can have for insertion of the electrode. So by chance, even if you expose the facial in this maneuver to see the round window, as long as you don't damage, it doesn't matter. They won't have any facial palsy. Even if by chance they have, it will be very transient. With a course of steroids and other things, it will settle down. So on the table, you can ask your anesthetist to give a shot of steroid and follow it up post-operatively for 5 days to 7 days. That will be good enough.
Yes, sir. We had 2 cases of facial palsy, and we could see that, yes, we have exposed the facial nerve and we could see the shining pearly white. We have stopped, but there is no injury to the facial nerve, but even exposure and the heat of the drill gives
Yeah.
paresis, and give a steroid for 1 week, they will recover, children. No issues at all. But only thing is you have to identify that that is a facial.
Yeah, but explain the patient and tell them,
Yes,
the
sir.
parents,
Yes, sir.
immediately.
Yes, sir.
Sir, for the benefit of the postgraduates, can you grade the round window visibility or accessibility?
What is that?
Round window visibility,
Huh.
can you grade it, sir? For many postgraduates here are interestingly seeing the case.
Round window visibility, I didn't understand the second part of the question.
Sir,
Grading.
He's
huh?
asking about the
Yeah.
grading, sir. Grading of the visibility of round window.
Grading of the round window, what you will do? How much is seen Antana? What is that? I don't understand. Anybody can?
Sir, Nageshwara, sir, I also grading of round window visibility,
yes, sir.
grading,
Yes.
anything you please
Yeah,
enlighten us.
this the what's called grade 1 is in completely
Nageshwara can
invisible.
add.
Yes, sir. He's professor of ENT, Visakhapatnam, sir.
Associate professor, sir.
Associate professor.
Okay.
Yes.
Again, incompletely visible is grade 2. Completely visible is grade 3. According to Dr. Satish Jain, sir.
Okay.
Round window visibility grades.
Sir, what is the limit of this posterior tympanotomy, posterior limit?
Posterior limit is facial now. Facial canal rather I mean.
Canal,
No, in
facial
the sense
canal.
now,
And
now that you're
inferi-
drilling, sir,
See,
how far posteriorly do you want to drill? Like till
No,
you
till
can
I
see
see-
the round window completely
Yeah,
or
till I
what?
see. See now we can see my
Yeah,
round
yeah,
window, whole
beautiful,
round
sir.
window.
Very
Yes, sir.
beautiful.
Can
very
you see?
beautiful.
And inferiorly, as I told, no, this is a round window. These are hypotympanic cells.
Yes,
Where
sir.
my suction tip.
When there is a high jugular bulb, when there is high
Yeah, that
jugular
is why I
bulb,
don't
sir.
want to go too much inferior.
Yes, sir.
I am happy with the visibility of the round window in this case.
Yeah, we can see it completely now.
Yeah, give me sickle knife.
Nageshwar Rao,
Sir.
Dr. Lasya, she has given me this from the Google. There are 3 grades of round window visibility. Grade 1,
Yes, sir.
round window visibility
Correct,
with more than 50% of the
Yes, sir.
round window membrane. Grade 2, between 25 to 50% of round window visibility.
Yes, sir.
And grade 3 is less than 25% of visibility. That is difficult.
Yes, sir.
So grade 1 means good, grade 2 medium, or grade 3 means it is difficult. You have to drill, the chances of facial nerve injury will be more, and you may have to go for even cochleostomy.
Yes, sir.
And even also antero superior niche cochleostomy widening is to be done. Sir is actually
Yeah.
very nicely polishing the posterior
Thinning the
tympanoid.
posterior canal wall to have a
Yes.
good access.
Yes.
You have a
Excellent
skeeter,
expose,
ma?
sir.
Skeeter?
No, skeeter.
Idea? Not then,
One
give me
minute.
that other contra-angle packet I had given, no, with one member. You just open and give. Give me a sickle knife, meantime. Give some saline. One saline could. Just flush this, flush here.
Sir, can you show the scrotum of the round window with pointer?
I'll show you 1 minute.
Yes.
I will show you the structures. Okay,
Sir, under what magnification are you operating now?
now I think I am under 16 must be. 16, ala?
16, sir.
6, Yeah, okay, suck. Enough. Yeah. See, this is open there. And connect. Can you connect that? I don't know. Give me the connector. See, this is a lateral semicircular canal.
Yes,
Once
sir.
again, incus,
Incus.
body,
Short.
Mm.
Buttress.
incus short process,
Yes, sir.
incus buttress.
Yes, sir.
This is a facial canal deep here. I have not gone up to there.
Yes.
This is the anterior part of the posterior tympanotomy,
Annulus.
and this is inferior. And now this big, what I said, structures, what all you have to see
Yes.
is, you can see the stapedius tendon,
Yes, sir.
incudostapedial joint,
Yes.
you can see the promontory,
Yes, sir.
you can see the round window. I am going to remove little bit of this upper lip of the round window.
Between the 12 and 1 o'clock, sir, between 1 and 2 o'clock.
Which one?
That round window lip by clock dimensions.
No, 11 to 1.
Okay, 11 to 1, yes.
Yeah, okay, and this is the hypotympanic cell.
Yes,
Inside,
yes, that is
deep inside.
hypotympanic, sir.
Okay. See what happens, why they sometimes if there is too much of overhang, you don't see this round window niche at all. It will be covered up to your lower part.
Yeah.
Then you will see a certain big cell below this, a hypotympanic cell. Then they think that hypotympanic cell is the round window.
Texanography.
And then they drill that and insert, they go down into the hypotympanum and you don't see the rest of the thing anterior to this edge. So it would have gone in the hypotympanum, it would have gone to the eustachian tube, the tip,
No,
it
no,
would
no.
have gone near the carotid area, things like that.
Sir,
Okay.
skeeter is there. You want to open, sir, or
Yeah.
not necessary?
If skeeter is there, I'll
Yeah,
just
yeah.
try this.
IPC, ma?
Did you put that?
First show the skeeters to
area-
sir.
1 mm.
What is
Otherwise,
peri
colour.
round window insertion,
No,
sir?
no. Where did you remove? This is another handpiece I had given, no? I told him not to open that. on another quadrangle lens, there were two burrs inside that.
What is round window insertion, sir?
It was there with this. Huh?
Round window insertion.
हाँ वो तो को देखना है मेरे को, इसको लगता है देखो. हाँ ओपन करो. See sickle knife कोड़े. Sickle knife. I will tell you where. See, this is the round window niche.
Yes, yes,
Sir,
sir.
we
normal-
need some fine focusing, sir, please.
I don't know. Better now?
Ah,
Yeah?
Yes, sir.
yes, sir.
Okay. This anterior inferior to this area.
Yes, sir.
This is anterior,
Yes, sir.
this is anterior inferior. Normally we do cochleostomy here,
Yes, sir.
if you are doing cochleostomy.
Yes, sir.
And when you said that you different grades, you say, no, when you are not able to see the round window, only you are seeing the anterior lip, then follow that and do anterior inferior to that, the
Sir.
cochleostomy. This is something new. We do round window or sometimes extended round window. Extended round window in the sense, if the round window is too much turned posteriorly,
Sir.
or if you are not able to expose the whole round window membrane, or if you feel it is little smaller compared to the size of the electrode array you are inserting, then can you see this where I am touching the inferior lip of the round window? Inferior lip of the round window.
Sir.
So this you can drill and extend the round window. That is called as an extended round window, cochleostomy. Or there is a new terminology which has come up called as a peri-round window.
Yeah, round window.
Yeah, that is Tom Roland from New York. He practices, he is an advocate of that. What it says, round window now different, because see, they started with round window, went to the cochleostomy and came back to the round window now. Peri-round window means they say round window has been given for some purpose, so let us not disturb that. Drill it inferior to the round window here. But
Yes,
you
sir.
must leave behind the edge of the round window should be intact, means the membrane should be intact. Do a cochleostomy inferior to the round window separately. That is called as a peri-round window.
Sir, we can use 0.6 and 0.8 tapered burr tips are also
Very
there.
good.
Diamond,
Cochlea.
conical for cochlea.
No,
This-
it's not fitting, is it? No, that burr is not fitting in there. I have given two burrs, no, just put them. See, if you are using a quadrangle handpiece with a, if you have a skeeter, there is nothing like that. So if you
Yes.
have this type of handpiece and burr, so you examine this burr. Can you see this is a 1 mm burr, but majority of the burrs you have seen, so from this edge it tapers. Only the last about 2 millimeter or 3 millimeter or so. Whereas this burr, can you see,
Yes, sir.
from the middle of the shaft, it has started tapering. Can you make out, please answer?
Yes, sir.
Yes,
Yes,
sir.
sir.
Okay. The
Right to
advantage
lip.
of this is when you are drilling a round window upper lip, the shaft will not rub. By chance, if you have exposed the facial here, it will not rub against the facial now. See, you see, there is space when you are drilling. Can you see this?
Yes, sir.
Yes,
sir.
very clear, very
Yeah,
clear.
that is very important. I wanted, of course, if you have a skeeter, it will be very thin, so you won't injure.
Please centralize.
You want some focus now?
Please centralize the picture, sir.
Center,
Yeah.
center.
Is it in focus?
Sir, no, sir, it's not in focus.
Yeah,
sir.
he will do little bit focus because I changed my. Is it okay?
Sir, can the magnification be increased, please?
Okay.
Excellent, sir. The focus is very fine, sir. No, or before focus is good, sir.
Huh?
Before
Now
picture
he's
is
changed the magnification. He'll have
No,
to
I
focus
changed the
it.
good.
magnification.
Yeah, very beautiful, sir. Excellent, sir.
Now it is better.
Yes, sir.
Is
It's
it better
clear,
now?
very clear, sir.
It is 1.0, I think.
Yes.
Okay. No saline. Can you reduce the speed of the drill,
Speed of the drill.
or is it only by foot control?
No control, sir.
No, 10,000 crore.
7,000.
So what is the minimum you do?
7, sir.
Yeah. So I have reduced the speed of the drill.
Yes, sir.
See, when you are doing cochleostomy, or when you are removing the upper lip, see, Can you see my drill?
Yes,
yeah,
sir.
See the way I drill.
yeah. Yes, sir.
I am not drilling here on the edge.
Yes, sir.
I am going inside. Can you
Yes.
see?
Yeah, yes, sir.
Inside the lip, and when I am drilling, I am just coming out.
Yes, sir.
So is that 0.6 mm coarse diamond?
Yeah, this is a 1 mm burr.
1 mm.
Diamond
1 mm.
burr.
Are you
Regular
drilling
diamond.
the scotum, sir?
Pardon?
Scotum of the round window you are drilling now?
No, no, top of the round window.
The lip.
This is called as the operculum.
Upper, yes, round.
It is the upper lip which covers the round window membrane.
Yes, sir.
See, the round window niche is in such a round and goes inside, and actually the shadow, and by drilling this, you are exposing that round window membrane which is hidden by this operculum.
Yeah.
360.
See, now sir is drilling that operculum, and the round window membrane will come into the view. Maybe it in such a way to prevent damage also by manipulations or all these things during routine middle ear surgery.
Okay.
Yes.
I have exposed.
I think
this.
still,
Now,
sir,
small
at
right
between 2 and 3 o'clock, or between
No,
1
no.
and 2 o'clock,
Small right angle
operculum.
pick kodi. No, that is okay. Now I'll show you something different.
Sir, sir.
You are not seeing the round window membrane yet.
Yes.
Okay.
Yes.
So what you are seeing is a pseudo round window membrane. See
Yeah.
this?
There
Can
is
you
a
see
bone
that?
yeah.
Yes,
Yes,
sir.
sir.
Yes.
I put my
Yes, sir.
There's a
small right
pick.
angle. I
Right.
removed that.
Yes.
Okay.
Yes.
Yeah, now the actual round window membrane you will see little later.
A faint
It is-
line of black line.
Yeah, it is
Yes.
facing inferiorly.
Please
Sir,
centralize the
center,
picture,
sir, center, sir.
Centralize the
1
picture,
minute.
Yeah.
Okay.
sir. Very nice.
And
We have a small micro curate, sir.
can you focus the
0.2
picture also,
mm
sir?
micro curate.
Okay.
So it's not focused.
Yeah, yeah, 1 minute.
Fine focus, sir.
Sir,
Now,
No.
sir, you fixes this, sir. Then
No.
you can focus at your
no,
end.
mine is okay.
You are okay, right?
Yeah.
Yeah,
okay.
it's okay, sir. No.
I think the camera focusing is required.
Camera focusing we did. This much we could get. Okay, smaller section. So now I am going to remove the further the operculum. Thinner, smaller. This microscope handle, I am just going to take a little. Is still okay, no?
No. Picture is not clear, sir.
Not clear?
Yes, sir.
The
Not clear, sir.
didn't focus.
Yeah,
now.
earlier was better.
Yeah,
sir.
yeah, we'll do that.
Yeah,
No, I
Still
change
not
the
clear,
direction
sir.
of the microscope.
Yeah,
Okay.
no, it's very,
Yes,
very,
sir.
very
Yes,
clear.
sir.
Sir.
It's
Okay.
better now.
Very clear, sir. Yes, 60. Entry inferiorly, there is small black spot like, sir. That could be the.
Now I started seeing the membrane. I will remove little more and then show you. So in this case, I may not be able to do only round window. I might have to extend it, but I will do that later. Should call it. Give me some saline. Saline. 156 syringe code. 1 minute. Small rectangle. No, I'm not used to curate. Actually, you are seeing the membrane, can you?
Yes, sir.
Yes, sir. Glimpse of membrane is visible. Is a 0.25 mm, 45 degrees peak.
No, the whole membrane is seen there.
Yes, sir.
See,
Now
if I
visible.
drill further, I will open the round window.
Right, sir.
Can all of you see this membrane?
Yes,
Yes,
sir.
sir.
What I am pointing? Hello?
Sir?
Sir, it's
Can
the,
you see this membrane?
Yes,
the
sir.
picture is not clear, sir.
Not clear.
No, no, very clear.
Focusing,
No, very
the
clear,
focus,
madam.
the focus, I mean.
Focus
The
करो.
round window part is not focused well, sir.
So, sir, Dr. Madhu, sir.
Ah,
It's
Yeah,
better,
it's
it's
very
be-
fine
yes,
now.
sir, now
Can
we
you
can see.
show with this nasal endoscope this picture?
Sir, now we can see it.
Now you can see the
size,
membrane.
Yes, sir.
aperture,
Okay,
Sir,
now
nasal
correct,
endoscope
correct.
cannot go to into
So I am
posterior
going to pack
tympanotomy.
this area
At
now.
1 o'clock position.
We'll come back later
We'll
after I
come
back the
back
bed, gel foam.
Silo
Gel foam.
endoscope can go.
Nasal-
Silo endoscope can go.
Dexamethasone ಕೊಡ್ರಿ injection open ಮಾಡಿ ಕೊಡಿ.
Nasal,
Now, I am
pediatric endoscope, na?
Yes, sir. Or silendoscope is also the better alternate to go.
gel foam में डाल के दे रही. एक
Cochleostomy, once you do cochleostomy.
Remaining addend I want. Just 1 or 2 pieces you dilute. Now I am going to put a gel foam
Yes, sir.
which is soaked in dexamethasone. I am going to put on the round window membrane, and then rest of the mid layer I am going to put the adrenaline for hemostasis. Okay. So this is a Dexona gel foam, adrenal gel foam. I want it to percolate through the round window membrane when I am making the bed. And you will see at the end when I am adrenal, when I am inserting the electrode, once I open the round window membrane, I will be injecting little Dexona into the cochlea, and I will put a puddle of Dexona in the mid layer, and through that puddle only I will be inserting my electrode. Kodri, ಇನ್ನೊಂದು ನಾಲ್ಕೈದು ಕೊಡಿ, take a bigger. Don't take that micro forceps, take regular forceps. That's forceps get spoiled. 3-4 pieces you give. Yeah, give. I'm putting here in the aditus area also.
So is it adrenaline soaked gel foam or plain
Yeah,
saline?
this is adrenal gel foam. Kodi now. No. Have enough. One big gel foam kodi. Where is the dry gel foam? Take this. One. Take. Now put a big gel foam there. Okay, now I'm going to make the bed.
Yes, sir.
Can you people see this? This area you can see now?
Yes, sir.
Where it track. One wet goes this way. You just change this drill. Change to straight and small cutting, 2 mm cutting. A template ಕೊಡಿ. This is very small, right? 2 mm cutting. Mark ಮಾಡಕ್ಕೆ ಬೇಕು ಅಷ್ಟು ಸ್ವಲ್ಪ ದೊಡ್ಡದು ಕೊಡಿ, ಅದಕ್ಕೆ ಸ್ವಲ್ಪ ದೊಡ್ಡ ಕಟಿಂಗ್ ಬರುತ್ತೆ. It is very small. करो, तुम करो. Not this. Retractor. Right angle retractor. No, not that. This one. Langenbeck. ನಂದೊಂದು ರಿಟ್ರಾಕ್ಟರ್ ಇತ್ತಲ್ಲ ದೊಡ್ಡದು. Yeah. No, I only brought it. Okay. Can you see that receiver stimulator
Yes, sir. Very
and
clear.
the marking?
Very clear,
Now,
sir.
yeah, good, drill. I'm going to just first mark the lower part.
Yes, sir.
Burr change ಮಾಡಿ. Give me a bigger burr, artery forceps. Hold it. No, big suction. Bigger suction. Touch it. Give me that big retractor. ಇಲ್ಲಿದೆ ನೋಡಿ ಅವನು ಇಟ್ಕೊಳ್ಳಿ ಅವನ್ನೆಲ್ಲ ಮುಚ್ಚಿ ಹಾಕಿಡ್ತೀರಂತೆ ನನ್ನ ಇನ್ಸ್ಟ್ರೂಮೆಂಟ್ಸ್ ಎಲ್ಲ ಡೋಂಟ್ ಕೀಪ್ ವಾಟ್ ಎವರ್ ಐ ಯೂಸ್ ಓನ್ಲಿ ಐ ಬ್ರಿಂಗ್ ಡೋಂಟ್ ಹೈಡ್ ದಮ್ this is a special retractor.
Sir.
If you can see, this is Dr.
This is a
Kirtane
special
designed
Dr.
it.
Kirtane.
Yeah.
Kirtane
For doing a bed,
retractor.
this is very good. Kodi. Hold this. Any bleeding? Hold this.
Sir, is that bleeding significant, sir?
Pardon?
There is
I think
bleeding from
there is
the
significant
posterior
bleeding.
part of the.
Yeah. I was just watching that. Suction kodi. Bipolar. Yeah. In headquarters, hold this. Shit. 1 minute. Give me the bipolar. Hold it and no, kೈ ಬಿಡಿ ನಾನು ಸಕ್ ಮಾಡ್ತೀನಿ ಬಿಡಿ here there is some press 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 small elevator ಕೊಡಿ hold it.
Madhu, sir.
Bipolar.
Madhu, sir.
Please.
Bipolar.
My guru, Dr. Prabhakar gar, Singari Prabhakar gar came now.
Yeah. Hi, Prabhakar.
Madhu, good morning.
Very
Yes.
wonderful morning, boss.
Dr. Shankar Madikeri, good morning.
Good morning, Prabhakar. How are you?
Excellent. We are very fortunate to
Wow,
see
very
opening batsman surgery. Excellent.
No, I'm one down. Opening batsman is always Madhu.
No, Madhu is the permanent. So, visiting opening batsman you are.
Yeah, okay. Thank you.
So, excellent demonstration, Dr. Shankar.
Yes. Oh, you were there from the beginning?
Yeah. I don't want to disturb the
Yes.
crucial steps.
Yeah, okay.
Madhu,
Yes.
Dr. Kumar Chaudhary, our president, Dr.
Oh.
Rahman, our
Ah,
secretary,
Sir,
they're all
Rahman-
with us.
Sir, welcome, President Rahman, sir.
And Dr. SVD Prakash also here.
Yes.
Okay,
After the implant, we will come for inauguration.
Okay.
just hold.
Thank you.
Drill. Now you are able to see now. So I marked that inferior portion.
Yes, sir.
This bar is not good. Somebody, you change this bar. Leave that. Leave this. ಸ್ವಲ್ಪ ದೊಡ್ಡದಿದ್ರೆ ಪರವಾಗಿಲ್ಲ. Okay, now I'm going to make the bed. Is it rotating forward or backward? It's jumping. I don't know. No. Oh, ಇದು ಕಡಿಮೆ ಇದೆಯಾ? Can you increase the speed? I think it is at 750. Yeah. Okay. That was because of the speed. I didn't realize that. We had reduced. See, this bone will be thin. Diamond ಕೊಟ್ಬಿಡಿ. Coarse diamond. I will take a coarse diamond. For the young child, the corticone will be thin. You expose the dura. See, it is not possible to have a good well without exposing the dura in this case. So in such cases, what I do, I expose the dura in the periphery of the bed, so that leave a island of bone in the center.
Okay. So all circumferentially you expose the dura.
Yes.
And you make a center piece of thin bone.
Yes.
So that it can, with pressure of the implant, it can go inside also.
Yeah, that will sink.
Well said.
And you put the implant. I will show you when I make it completely. There is advantage of doing that also for completing a good bed. Do you have another coarse diamond? This is not that much cutting. You have another one? You there. Changes. See, this retractor, I am holding myself with one hand and I am also using the suction tip.
Sir, the picture needs some centering, sir, please.
See, all this time what you saw, I have only one assistant, nobody else. I don't
Sir,
require.
you are really great, sir.
I don't require. No,
because of
I've
the
seen many
Kirtane
places
speculum.
where I go for mentoring, there will be three assistants
Yeah.
inside, and there will be 2 or 3 tables, which
Two
I
or
hate.
three.
One table, one assistant.
One assistant.
Good enough.
Yes,
And
sir,
minimum number of instruments on the table.
Sir, can you center the picture, please?
1 minute.
You are using the minimum resources of equipment and tables. I have also seen when I went to Patna for a cochlear implant
Yeah.
workshop, 3 tables will be there, 3 assistants will be there.
Yeah. They put so many instruments on the table, which you
Yes.
don't use, also many will be there. The moment you ask one instrument, they will be searching. See, the micro instruments I use here is only one small right angle pick, one sickle knife, that's all. One crocodile forceps, these 3.
Good thing. Yes.
And of course, drill bits you have to have all.
Yes.
You don't know which one you will require what.
The man of the match or whatever it means is the micro drill, number of drill
Yeah.
bits, coarse, diamond, and right from 0.6, 0.8, 1, 1.5, 2, 2.5, like that.
ಸ್ವಲ್ಪ ಚಿಕ್ಕದಿದೆಯಾ? ಯಾವ ಲಿಟಲ್ ಸ್ಮಾಲರ್? ಹಾಂ.
In the center, you're leaving the bone, sir, and all around the periphery, you're drilling. And
ಐ ಆಮ್ ಗೋಯಿಂಗ್ ಟು
to
ಎಕ್ಸ್ಪೋಸ್. ತಗೊಳ್ಳಿದೆ. ಗಿವ್ ಮಿ ಅನದರ್. ಟೆಂಪ್ಲೇಟ್ ಕೊಡಿ, ಅದು ಹ್ಯಾಂಡಲ್ ಇದ್ದದ್ದು, ಹ್ಯಾಂಡಲ್ ವಾಲ ಟೆಂಪ್ಲೇಟ್ ಇದರಲ್ಲಿ ಇಲ್ಲಿದೆ ನೋಡಿ. ಹಾಂ. See, this is a template. This thing should be the size of this bed. Okay, the edges, little more edges I have to widen. Celestic template ಇದೆ ನಿಮ್ಮ ಹತ್ರ? ಅದು ಬಿಟ್ಟು ಬರ್ತಲ್ಲ, ಅದು ಆಮೇಲೆ ಕೊಡಿ. ಹಾಂ, ಓಪನ್ ಇಟ್ ಲೇಟ್, ಅದು ಓಪನ್ ಮಾಡಿ ಕೊಡಿ, ಡ್ರಿಲ್ ಕೊಡಿ. Yeah, I have reduced. This is the lowest one. Now it is in the center.
Yes, sir.
Just hold it. A good tight fitting bed with all vertical edges is very important to retain the receiver stimulator in bed. Otherwise the chances of migration of the receiver stimulator will be there. So each and every step of cochlear implantation is important for something or the other, particular reason. Starting from the skin flaps, elevating the periosteal flap or making the bed.
Sir, will you make the edges sharp or beveled, sir?
Pardon?
Will you make the edges sharp or beveled?
No, no bevel, no sharp. It has to be vertical.
Yes, sir.
I'll show you. See like this. Why I told, see where you, like this, if you press it, this island, the dura goes away. So you'll be able to make the edges vertical if it is sloping.
The secret is here coarse diamond.
Yes, sir.
Yeah, it should cut also, and at the same time exposing the dura should not cause damage.
The disadvantage of medal is the thickness is, this is the thickest among all. AB or cochlea is almost 5 to 6 mm thickness. Rest of the things are a bit less. That's why medal implant you can see bulging from the skin after the surgery also.
or
Yes.
even cases of otosclerosis, cochlear otosclerosis, and where even they might have undergone stapedectomy earlier and enjoyed a good hearing, and now they have lost the hearing
Yes,
or
sir.
not getting benefit with the hearing aid.
That is even in idiopathic bilateral
Yeah, yeah,
sensorineural
yeah.
loss.
See,
Severe.
can you just see this one cell here?
Yes, sir. Hypotympanic cells.
Hypotympanic cell.
Yes,
See,
sir.
this is what, if this is completely covered and not opened,
Yes, sir.
people go and open here.
Yes, sir.
Okay. And lastly, the unilateral sensorineural hearing loss. Okay, give me a change gloves. I want to change the gloves because I will be opening the end of the dexamethasone injection ತಗೊಂಡಿದ್ದೀರಲ್ಲ needle syringe ಅಲ್ಲಿ ಇದೆಯಲ್ಲ ಬೇಕಾಗುತ್ತೆ ನಮಗೆ implant ಚೆಕ್ ಮಾಡಿದ್ದೀರಾ where is your audiologist boss let him check the implant whether it is all right ಕೊಡಿ ಏನು ಲಿಮಿಟ್ ನೋ ಲಿಮಿಟ್ ಅಂದರೆ 70 decibel, more than 70, 75 decibels, if they are not getting benefit with the hearing aid, with pure tone and especially the speech scores, if they are less than 50%, check madidra? Yeah, SDS, USL, other, less than 50 to 60%, then better to go for implant. Now that implant you have checked, all the electrodes are working. Impedance check, it should all be open. Yeah. The audiologist has checked the electrode, the impedance of all the electrodes before opening the box. Because they're not in the body, though, it should be all open circuits. But if there are any short circuits identified, then better not to use that implant. Oh, it is all getting stuck. Can you open? I give you another powderless or something. The powder is over on this very ಒಣಗಬೇಕು ಫ್ಯಾನ್ ಇಲ್ಲಲ್ಲ ಇಲ್ಲಿ ಒಂದು ಗಾಸ್ ಪೀಸ್ ಕೊಡಿ ಪ್ಯಾಡ್ ಕೊಡಿ ಇಲ್ಲಿ
Are you washing your hands in the normal saline, sir, with the gloves?
No, I use the
To avoid the dust.
no, he gave me, what is that, sterilium.
Sir. Sterilium, yes, sir.
Yeah. Left ala? I believe what he can do, he can help me by opening it, can you? Usually my sister opens up and gives me like this,
So what are the contraindications of cochlear implantation?
completely.
Shankar sir,
Yeah,
what are the contraindications of cochlear implantation?
the contraindication in the sense, there are, if you don't have a cochlea itself, or if you don't have the cochlear nerve aplasia, and even this, for example, I said no cochlear malformations, because complete labyrinthine aplasia or cochlear aplasia, only otocyst,
And in the abnormality in the spiral ganglion cell population also, sir.
that we cannot make out, I don't know.
Yes, sir.
Dead regions sometimes.
Sir.
And all these other like IP1 and hypoplastic cochleas, if they are associated with the cochlear nerve aplasia,
Yes, sir.
they will be contraindications.
IP3 anomalies.
Yeah,
IP3.
IP3 anomalies with, if the nerve is good, you can still do.
Yes, sir.
So and what about labyrinthitis ossificans, which stage? Like complete ossification is also a contraindication.
So the other complete ossification stage, they have done these drill outs. They have done the drill out and put the electrode, but the results of the drill outs also are not very good. So those cases, complete obliteration, then they go for ABI, auditory brainstem implant.
Yes, sir.
Yes, sir.
If you can identify when there is a partial obliteration, implant the
So if the child also has coexisting CSOM,
Eh,
if the child has a CSOM with the discharging ear coexisting,
you put one,
First
Go-
we have to treat
put
this.
one
Yes.
towel. Remove all these things. I don't require now. Only those those four things you keep.
CS one treat this.
Just repeat the question.
sir, if the child has coexisting
Put one
CSOM,
towel.
CSOM, sir, is
Then
that a
what is-
contraindication?
Just open. Put, don't open. Just half open. Open.
Sir, most of the children, most of the people, patients are children.
Hmm.
If they have adenoiditis grade 4 and secret arts media, and they are deaf mutes.
One second. I'm just organizing. Give that instruments. Put on fine suctions. That. Open it careful. One kade open agutte.
You have to upside down. Just fold it, just tap it. Now you can remove.
No, it won't.
Thank you.
No, there is one area where it opens. It is tightly packed. It won't come. Yeah.
Camera put for it.
On cable. Static. Okay. Yeah. Sorry, tell me.
Yes, sir. The question was if the child has CSOM also along with
Yeah.
profound loss,
CSO with central perforation, dry
Yeah,
central
if-
perforation.
or if the child has grade 4 adenoids with recurrent otitis media, secretory otitis media.
No, adenoid tonsil problems and all those things to be handled first. In CSOM, if they have a central perforation with a profound degree hearing loss, or if they have done multiple surgeries and then come, if they don't have any serviceable hearing, then there are two ways. Whether if you are doing for the first time, you can do the mastoid tympanoplasty and go ahead and do if it is a dead ear implantation at a second stage. Or if it is a cholesteatoma, especially if it is a recurrent cholesteatoma, then we may have to do something called as a subtotal petrosectomy. Clear everything, block the eustachian tube, remove all the epithelium, do the blind sac closure, and do the implantation at the same sitting. Syringe kude.
Same sitting it can be done, sir.
Yeah, it can be done. Or you obliterate with fat obliteration and come back 26 number needle. And after 6 months or so, take this.
Yes, sir.
Take it. You can go in again and then do. See now, just observe, I am puncturing the round window.
Yes, sir.
Okay, so I have punctured small right angle code in pick. That one instrument ಇಟ್ಕೊಳ್ಳಿ ಅಲ್ಲಿ. So I am just trying to where is my that quadrangle angle and put that 1 mm burr ನಂದು tapering burr. Can you see little bit of perilymph pulsating? I opened the membrane, but I am finding this is not enough. What I am going to do, I am going to drill this white bone, inferior ledge. Can you see that?
Yes, sir.
1 minute. Take this, Baba.
Sir, can you magnify that?
Yeah, I'll do that. Because I was doing the bed earlier. Is this better?
Centralize the picture, sir.
Yes, sir.
Yeah, fine focus.
Fine focus, no?
Is this better or is this better? Fine focus will do.
Yeah, this is better, sir, but you please go for fine focus.
It is off center now, sir.
Yeah, we'll do that.
Yes, sir.
Yes.
Is it okay?
No,
No,
sir.
sir, no, sir.
Blurred. Yeah,
Yeah,
it's
now
fine.
it's best.
Yes.
Sir, at this,
This is perfect, sir.
at this area, can you show the landmark for singular nerve, sir?
Landmark for
For landmark for singular nerve.
singular nerve.
Yeah.
Oh, no. Singular nerve where I can show here. No. Just hold this. Just hold this. Only that much. No, don't put any saline. Yeah, I have kept.
Yes, sir.
No.
Pillow should be.
I have kept in the shoulder. There is a towel, folded towel there. Is the focus to be adjusted?
Yes. And fine focus, sir, please.
Huh?
Fine focus.
Huh?
Sir, the angle has changed. Now we cannot see the round window so well as
Just
earlier.
please tilt the head of the patient or microscope.
This is good. Just focusing.
Fine focus.
Yeah. For
Yeah,
me it is
yeah.
focused. For you it is okay?
Yes. Okay. Best. Please tilt the microscopes. Yes, very fine, sir.
Suction. Speed ಕಡಿಮೆ ಮಾಡಿ 7.
Yes.
I have reduced the speed again.
This is a cylindrical cochleostomy burr.
What is the size, sir?
0.8 mm.
0.8 mm.
This is
Injection.
not like circular or cutting
Injection.
or diamond burr. It's a cylindrical.
See, this is the Dexona what I injected.
Decadron is injected.
Curved hook ಕೊಡಿ ಒಂದು curved hook ಇತ್ತಲ್ಲ
Do you use highlights also, sir?
No, not earlier I used to use for cochleostomy but not now. Can you see now it opened up?
Yes, sir.
Yes, sir.
Oh, your
Now
electrode array will
that
go
You
here.
black-
have removed the membrane now. You can
Yes,
see
sir.
it.
Just hold this. Let's see, this is holding my.
Any questions from the delegates? Please pass questions to me. I will ask the faculty, chief surgeon.
Yeah.
Please write
Should
down on
be
the
good
paper
enough.
and pass it to me.
Injection. Injection. Okay, I've injected that in that puddle. I'm just sucking on the inferior part
Yes.
in the hypotympanum, not on the cock. Okay. 1 minute. I'll just come back. I'll put the implant in the bed. Tractor could be small. Right hand. Hold this. ಅದನ್ನು ಬಿಡಿ ಇದನ್ನು ಟ್ಯೂಬ್ ಹಿಡ್ಕೊಳ್ಳಿ ಟ್ಯೂಬ್ ಹಿಡ್ಕೊಳ್ಳಿ
Now, sir
picture,
is
sir. No
putting the
pictures.
implant
Sir, no
in the
pictures, sir.
subperiosteum layer. I think overhead camera, the hand is coming in the way, I think.
No, I will just
Yeah.
show you. Just hold this.
No, overhead camera is there. ఇది మనకు కనపడుతుంది.
Yeah, now it is.
Can you see now?
Yes, sir.
Huh?
It is
Yeah.
Please
shifting.
centralize the picture,
It is
sir.
shifting, sir. The image is not constant.
Now,
Yes,
very,
sir.
very clear, sir.
Yes, sir, we can see.
Okay.
Yes,
You
sir.
can see even the letters there.
Yes, sir.
Remove
So
the
that's how
remove the retractor.
the implant has to snugly fit in the bony pit which we had made.
Right. And this will be
And,
covered by the
and this
periosteal flap.
musculo-periosteal flap
Will
you
hold
have
it.
to suture.
We don't suture it, sir.
No.
Scheme, serial number already taken.
It will just fit into the well.
ಸಕ್ಷನ್ ಇಲ್ಲಿ ಹಿಡ್ಕೊಳ್ಳಿ, ಇದನ್ನು ಹಿಡ್ಕೊ, ಹಾಂ ಸ್ಮಾಲ್ ಇದೆ ಇರಲಿ, ಹಿಡ್ಕೊಳ್ಳಿ ಇದನ್ನು ಹಿಡ್ಕೊಳ್ಳಿ ಸುಮ್ಮನೆ. ಗಿವ್ ಮಿ ದೋಸ್ ಫೋರ್ಸೆಪ್ಸ್. Now I am going to show you the electrode array. There was a tube which I am taking out. Yeah, you'll go. Yeah. Okay, can you see this electrode array?
Yes, sir.
And there is one knob here.
Yes,
This
there
is
is a
something
stop
like a
knob.
stopper. Okay.
Okay.
So I am holding this conical stopper is there. This is specially this type of, this is form 24 I think.
Yes.
This type of electrodes are good for CSF gushers. Okay.
Yes, sir.
And now
I'm
with
going
a
to the-
dual forceps.
With a jeweler's forceps in one hand, and this is a AOS forceps I am holding in the other hand. I am holding the electrode array behind the stopper. Hold this, suction. Can you see that cochleostomy, the round
Yes,
window area?
Very beautiful, sir.
Okay.
Yes, sir. Very beautiful.
You saw that it is going
Yes.
slowly.
Slowly,
Yes, sir.
steadily.
So what is the
with
direction
a
of
stable
introduction?
movement.
Anterior-inferiorly? Is it?
Yeah, it should be anterior-inferior.
Yes.
Because it should follow the lateral wall and then take a turn. That is why I removed that inferior lip, because that is where you have that crista.
Crystal.
Yes.
Also, there is a crest there.
Yes, sir.
It will obstruct otherwise.
Sir, the length of the cochlea is 34 millimeter. How much distance these cochlear
It is-
electrodes to travel in the,
It is
Oh,
variable.
This is 24.
sir?
This is 24 millimeter.
24
Yes, sir.
See, my stopper came there.
Sir.
Give me the claw ಕೊಡಿ claw.
Claw.
ನಿಮ್ಮ ಕೈಯಲ್ಲಿದೆ ಅಲ್ಲ ಕೊಡಿ. Okay, now
Yes, sir.
with the claw in the left hand, I am just holding the electrode array just above that stopper and trying to release.
So you're just gently pushing it
ಇನ್ನೊಂದು
forward,
ದೊಡ್ಡದಿದೆಯಾ?
sir.
ಅನ್ನೊಂದು
Electrode by
ಕೊಡಿ.
electrode.
One of the most delicate movements in implant surgery. So you are negotiating through 0.6 mm round window, and the stopper exactly onto the round window membrane. It will also prevent the leak of the perilymph, and stops as a stop notch.
Okay.
Okay.
Yes, sir.
Yes, sir.
Beautifully
I'm
inserted.
going to
Excellent,
Sir,
sir.
push
very
that.
good,
Yeah.
sir. Very good.
Straight
Very
to-
nice single
straight to-
insertion went on
Very
very
big applause
nicely.
from
Thank you.
the
I am going to
auditorium,
block.
sir.
Huh?
Very big applause from the auditorium. The art
Yeah.
one is
Oh,
tight-
thank you.
tightly packed, sir.
Yeah, I will pack
Ex-
now.
Excellent demonstration, sir.
Yeah, I'll put some tissue
Sir,
underneath that and then plug that cork
Yeah.
again so that it will snugly fit in.
soft tissue or fatty tissue or for
Periosteal tissue.
periosteum, master
So
perineum.
how many electrodes were inserted? For
Full,
the sake
complete
of the
insertion.
Completely.
complete insertion. For the sake of the juniors, can you tell us, sir, the number
Yeah.
of electrodes?
This is 12 pairs, I think.
34 millimeter.
Oy. ಬಿತ್ತದು ಬೇರೆ ಕೂಡ ಇದು ರೈಟ್ ಆ್ಯಂಗಲ್ ಕೊಟ್ಟಿದ್ದೀರಾ ಇನ್ನೊಂದು ಸ್ಟ್ರೇಟ್ ಸೀಸರ್ಸ್ ಕೊಡಿ ದೀಸ್ ಆರ್ ಟೂ ಬಿಗ್ ಕೊಡಿ ಇದನ್ನು ಸ್ವಲ್ಪ ಕಟ್ ಮಾಡಿ ನೀವು
So when can you get a false passage and enter into the scala vestibuli? What are the chances? I mean, when do you make such mistakes?
Although that you can see, if your direction of the electrode you ask, no, if you go more medially, you'll hit the modiolus instead of going anterior-inferior.
Yes,
Then
sir.
sometimes it may turn. That is why another thing is you have to scala vestibular insertion. If you are not slow enough, if you are rough and little faster, the tip might injure the basilar membrane and then go.
The bony plate
Hello,
between
sir.
the ICA and cochlea is deficient or thin.
Huh?
Is there any chance of injury to the ICA, sir? If the bony plate between the ICA and cochlea is thin,
What is that?
injury to the internal carotid artery with the electrode,
Uh-huh.
when the bone is thin between the ICA and cochlea.
Okay.
Any situations are there, sir, like that? Injury to the ICA?
No, I have not seen anything like that.
Yes,
I have seen people who have put the electrodes
sir.
in the hypotympanum, or it had gone to the carotid area
Sir,
between the carotid and the jugular bulb. That what is that called? Straight pick ilva ನಿಮ್ಮ ಹತ್ರ?
Septum, jugular carotid septum.
ಒಂದು ಸ್ಟ್ರೇಟ್ ಪಿಕ್ ಇದ್ರೆ ಕೊಡಿ ಅದರಲ್ಲಿ. ಏನು ಬೆಂಡಿರ್ಬೋದು, ಅಬ್ಸಲ್ಯೂಟ್ಲಿ ಸ್ಟ್ರೇಟ್. ಅವರ ಕರ್ವ್ ನೀಡಲ್ ಇದ್ರು ಕೊಡಿ ಇಲ್ಲಿ. We have revised those cases.
So is that periosteum you're inserting?
Yeah, yeah. Suction block ಮಾಡಿ.
So if the facial nerve is exposed during posterior tympanotomy, then how can you protect that from the electrodes, sir? Do you
Soft
keep
tissue.
something soft tissue
in
interposing?
You can put, but I don't think that will anyway cause the
That will not
stimulation
affect,
of the facial.
there will be distance and electrode, electrical passes. Once these,
As I said, it will not be stimulating here.
there is
If
enough
at all
thick
if it is
sheet is
stimulating,
there.
it will be stimulating in the electrodes are inside the cochlea. That
Yes, sir.
outside part, this is covered with the silastic, no?
Yes, sir.
So it won't, please ಕೊಡಪ್ಪ.
Suppose
Hold
Shakuntala,
that, no?
what it is there, suppose facial nerve is
Give me that
exposed,
with the forceps.
the part
No,
of
not
the
that.
implant
That is meant
channel
for
is there.
electrode, yaar. Take your regular
There is
forceps.
a thick
ಅಲ್ಲಿದೆ ನೋಡಿ.
sheet of silastic.
Non tooth forceps ಇದೆ
So
ನೋಡಿಲ್ಲ.
the
Silastic
electrical
sheet
impulses
Ah.
cannot
ಯಾಕ್
touch
ಕಾಣಲ್ಲ
the
ಅದು?
facial nerve even
Yes,
if it is
sir.
exposed.
Then why are there facial
No, there is
twitches
too
in
big
some
here.
cases
Cut.
post-operatively
Take
after
2-3 small pieces.
stimulating the electrode?
ಪಟ ಪಟ
I
ಮಾಡಿದ್
don't
ಬೇಕು.
know, I have not
Do it
seen.
fast.
Is it
But
possible
facial
current?
palsy we have seen because drilling or heat of the drilling, but not because of the
Give me.
electrodes.
So all this is to prevent the slippage of the electrode?
Yes, yes. Once to stop any leakage, perilymph leak, and also slippage for
Yes.
both purpose.
Yeah. And preventing infection later.
Yes.
Suppose if child gets middle-ear infection,
Yes, sir.
it should not go into the. Okay, now it is nicely blocked.
Excellent.
So forceps could. Electrode forceps. Yeah, is it ready enough? Testing. Okay. See, now I will just show you.
ನಿಕ್ಕುಳಿ ಅದು.
ಜಲ್ ಫೋಮ್ ಕೊಡಿ ಒಂದು ದೊಡ್ಡ ಜಲ್ ಫೋಮ್ ಕೊಡಿ. ನೋ ದೊಡ್ಡದೊಂದು ಪ್ಯಾಕ್ ಕೊಡಿ. ಜಲ್ ಫೋಮ್ ಕೊಡಿ. ಯು ಕಟ್ ದಿಸ್ ಜಲ್ ಫೋಮ್ ಕೊಡಿ ಒಂದು ದೊಡ್ಡ ಬಿಡಿ.
Sir, can we give injection
Cut,
hydrocarbons
cut.
intravenously?
Pardon?
Injection hydrocortisone intravenously, can we give it?
Yes,
this
yes,
moment?
yes, given.
Intravenously. Na?
Yes,
Yeah, I think usually given
sir.
during the time of insertion.
Sir.
Yeah,
Just before.
yeah. Yeah. Cut Ray. Cut this. And give me that. Okay, this flap will come. Okay. That injection was remaining, no, Dex? Kodi. Yeah, idu kodri. And gloves kodi. Now we are going to do the testing. I just put this little. Bidi. Kodi.
Sir, now you have soaked the gel foam with saline or steroid drops, sir?
No, that is a Dexona only.
Dexamethasone, sir.
Okay, now yeah. Now the implant is connected.
Yes, sir.
He is doing the testing. External camera you show there.
Sir.
We are checking the impedances.
Yes, sir.
Wow.
They open.
Sir,
Yeah, there are some 2 electrodes which are open. Open circuit indicate. Yeah, there will be air bubble. If there is a air bubble, can you get some more Dexona? Yeah, we can do the testing or no?
So what does this type of graph indicate?
It should not be a short circuit. It should, even if it open, there will be some air bubble. So what you can do, inject some Dexona into the cochlea, that air bubble disappears, or even later also this disappears, so it will become normal. Only thing, you should not have a short circuit. If the dry cochlea, then this can happen. So those open circuits, we can't do that ART testing. Huh? Yeah, the apical, that is a 12, no, that is. Apical and basal, both are there, na?
Both are there.
Yeah. Yeah. Yeah.
Yes, sir, it will get nullified, sir. Once
Yeah.
we suture,
So these air bubbles will disappear with time, and maybe even after the suture we can check once again. But otherwise, those other electrodes, apical and basal and all, we are getting the responses.
all the basal 6 are good, sir.
No, apical 2 also are there.
Because they will just get corrected by suture.
Dexona ತಗೊಂಡ್ರಲ್ಲ? Anyway, you can finish ಆದ್ಮೇಲೆ, can you just check the impedance once again? 1 minute, I will do. Section could be small. Electrode array has gone in smoothly, as you saw.
sir.
I am into the round window. I am injecting some more Decadron, Dexona, okay? Hoping that whether that, yeah, we'll just check once again if possible. We'll see. Otherwise, you wait for the closure and then it will be fine.
Very good, sir.
Yeah.
That is good. All are basal, only 2.
Yeah. Yeah, there are high impedances in the middle electrode, 2 electrodes. They should become normal. No, then it is fine. Now we are finishing closing. Maybe after the closing, you can just try once. Let it be. Okay. Late I thought. Dr. Madhu is going to close. So thank you very much,
Thank you,
everybody,
Mr.
and
Thank you, sir.
Dr. Madhusudan
Yeah,
for
start
giving us an opportunity to.
demonstration.
Hey, thank you.
Right, sir.
Thank you.
Any questions from the audience?
I'm coming down there until then.
Doctor, are you able to hear me?
Any questions, please come forward. This is the time to speak with the big faculty people.
I will come over there. Hello. I will come over there. If
Yeah,
there are
please
any
welcome,
questions,
sir.
you can ask me there.
Sir, please welcome.
Hello, are you able to hear me?
Yes, ma'am. Yes, sir.
Yeah, Dr. Shankar Medicary is coming to the auditorium. Inauguration will start. I request the Manideep or this thing to start this thing. I'll suture by the time function is there. I'll join.
Yes, sir.
Sir, Shankar sir has shown in
Thank you very much, sir. Can I ask Dr. Singari Prabhakar, sir, please come on to the dais. Please hand over mementos to our chairpersons. I ask Dr. Nagesh Rao, sir, and Shakuntala ma'am, please come. Please accept our memento, ma'am.
By the time Shankar Medicary sir comes, you can have the presentation of Vidyasagar.
Thank you very much, ma'am. Thank you, sir, for giving your
I'm
experience.
very happy today that my great philosopher, my guru, and he is more than my father, Dr. Singari Prabhakar. I have worked with him after my MS. I worked with him for 1 year. He is the Stamberger to me. I thank him. I owe a lot. Thank you, sir. I'm very happy here. He's a great person. Still, he is 4 or 5 people are working with him now. When I was working with him, there were nearly 10 post-MS graduates are there. Thank you very much, sir.
I welcome our guest lecturer, Dr. Vidyasagar, sir. Sir, topic is how to establish ENT center by budding ENT surgeons. Please start your lecture.
Good morning. At the outset, I would like to thank Dr. Madhusudan sir and his team, Madhumani Nursing Home team, and the organizing committee for giving me this wonderful opportunity to talk about this topic of setting up a nursing home for the ENT practice. I think I see a lot of youngsters here. The first and foremost thing I wanted to say is, why do we need to actually set up this nursing home? Or what made me, in fact, to give a talk on this particular topic? I am not an expert in it, but somebody has to bell the cat and we have to start this proceeding. Because this is one of the most important points that will ponder on any ENT surgeon. I'll just go through the as kind of a life story of a ENT surgeon, how he starts his practice. Once a ENT surgeon finishes his MS, he may either join a senior residency or do some fellowship programs, or may start a practice. He may start his practice either affiliate to a corporate hospital or a medical college hospital, or he may start his clinic and he may also attach himself to a multi-specialty hospital wherein he may take his surgical patients and go ahead and do the surgeries there. But what will be the problem? He will be to a certain extent happy that he doesn't have to establish a big setup initially. But gradually as the days goes on, this question nags himself. He is making all the effort. He is trying to get the patient. He is going to face the patient. He is going to face the complication if there is something. he takes to the patient to a nursing home wherein he gets paid only a pennies. In fact, the nursing home or the corporate hospital gets the major chunk. He gets only maybe 20%, 40%, 50%, 60, depending on the place where he practices. And that's when he will start to think the benefit of taking the patient for the surgery as well as the benefit of establishing a nursing home for himself. So what are the other problems also he has when he takes it to another hospital or another nursing home? He will not have the leverage to schedule his patient for that surgery according to his time. He will have to follow the protocol of the nursing home's timing schedule. He may have to not get satisfied with the instrumentation that the hospital may have, and he would have to bring his own instruments, which may not be maintained properly by the nursing home staff there. He may not even have a small luxuries of parking or having a say for the benefit of the patients that he is taking there. And finally, I think it is a dream of each and every ENT surgeon to have his own setup. And if you don't follow your dream, then somebody else is going to use you for their dream. So in that aspect, I think this topic is the need of the hour. But is it always green? No, it is not. It is very difficult task. There is a lot of flip side to it. By taking that for your own nursing home, you may lose the PR that you have developed. You may lose the interdepartmental assistance that you may have. You may not have an access to the insurance patients or the cashless schemes right away. Management is a very terrific task that needs to be done. Volume of the surgical administrative burden and getting the government schemes can also play a part. But the best thing is, even if you decide to proceed with this topic of building your own setup, then the one good thing I wanted to say is help is there always at your doorstep. You will be surprised to see that so many of your friends, colleagues, seniors are there to help you, guide you. I would take my own situation for your example. When I just discussed about it to our seniors, one of the best persons here is Dr. Singari Prabhakar. He came and he knocked our doors and he called me in the phone and he gave tips of how to start, whom to send. He will send the contacts for the tiles person, mason person. He will knock and he will tell all the details. Dr. Rahman Garu, who is also here, he would tell me how are you going to get the setup for the fire safety norms, DMHO permissions. I think more importantly, Dr. Madhusoodan sir, whenever we come to the conference or the workshop here, he would give us the tips of how a nursing home should be stabilized, how it should be established. Dr. K.V.S. Kumar Chaudhary, whenever I spoke to him about it, he will just say, Sagar, I am there. Either as a person or from the back or from the association, we are there with you. That's how the help you will be getting it. Once you just talk to your colleagues, talk to your seniors, your help will be available for you. Before you even start setting up your own nursing home or your plot or the land, you can actually accumulate your instruments that is needed. You may have to specialize in some particular topic. Maybe it is sleep apnea, maybe it is rhinology, maybe it is CI. Gradually you will try to gather the instrumentations that is needed. The first and foremost is going to be obviously a rigid endoscopy system, which I'm also going to say for the benefit of the juniors, within a budget of 20 to 30 lakhs, most of the instrumentations that I'm going to talk about are going to be available for you at your doorstep. A rigid endoscope, obviously having a stars is much better, but at least there are so many other instrumentations like Hawk, top line, top notch, and Medline. So many other endoscopes are also available, which is easily available for the budget of 25 to 30K. And obviously the stars is above 1 to 1.5. You also need to have at least one of them. And you also need to have a software like Endovision or a Ambala Soft, which is also available within the reach of around 40K, wherein you can document all the endoscopy procedures, given a report, etc. The next thing is, if you're actually going to practice on sleep apnea or on pediatric ENT, then I think you are imperative to have a flexible fiber optic endoscope. This will be available for you in the budget of anywhere between 3 lakhs to 3.5, and this is very handy. It can be attached to all your light source that you're going to have, like whether it is your star system or a serval system, this is available for you. The only difficulty with this is that the damages to the scope is very easy. You can get dots very quickly and you will have to replace them or service them frequently. For that, the best tool that came is the chip-on-tip fiber optic endoscopes. This is one of the V-video scope. This is a little expensive, maybe in the range of 7 to 10 lakhs you may get it, but this is a wonderful, wonderful fiber optic endoscope. I think it is a chip-on-tip endoscope that you can use it for your pediatric patients, you can use it for your sleep apnea patients, etc. If you are interested in setting up your own sleep center, for a budget of around 75K, you can get a sleep lab, which is a screening device. Apnea Link Plus or a Philips Respironics is available for that. If you're going for sleep apnea practice in particular, then you may need this BIS monitor. This is available in the range of 2 lakhs, which can be accommodated with your Philips monitors. For your intubation, you need to have this kind of special intubating laryngoscopes, which are available in the budget of 35K all the way to 1 lakh. But if you are not going to have this, you can use your 45-degree endoscope and you can still use it for intubating your difficult intubation patients. This is one tool that I would stress on you having it when you're establishing it. That is the end-tidal CO2 monitor, whether it is a main port or a side port, depending on the side system you're getting it. But I would advise you to get them mainstream or the main port end-tidal monitor, because this would confirm the placement of the endotracheal tube. It will avoid the mishaps of tube getting into the esophagus, or you can even, there are 5 to 6 different points that you can get with the help of this end-tidal, including whether the patient is going to come out of the anesthesia, etc. and etc. Coblator, nowadays you are having access to, I think Smith & Nephew makes the state-of-the-art coblator system. They are upgrading again and again, but there are so many other Indian-made systems, Chinese systems that are also available for the budget anywhere between 5 lakhs all the way to 10 lakhs. And the good thing is this is also available for rent, pay-per-use also. So microdebrider. Previously, only Medtronic Zomed was the one that everyone used to suggest. Still, I think this is one of the state-of-the-art equipment. But nowadays, you're also having Serval, Bharat, and many more who are also having this for a very economical budget of 2.5 to 3.5 lakh, which is having very many attachments, like even attachment of your micromotor to the system as well for the same budget. Radio frequency, I think if you're only practicing on sleep apnea, you may have to consider it, but allergy testing is another place that you have to consider having this, because for a budget of around 25 to 40K, you may get the allergy kit and you can do this, and this will be another area that you need to think about. So this is particularly towards the sleep apnea. Similarly, you can also think about establishing your OT. When you're designing your OT, you have to at least have a OT place of 20 by 20 according to the standard norms. But if in case you're not having it, the least I would say is at least 18 by 14. That is the minimum space you need to have. If you're planning a laminar airflow AC, always it's not prudent to use the laminar because the power consumption is more. In those cases, you may have to have a cassette AC like this, so that in the event your laminar AC doesn't work, still your cassette AC will work, and it will also help you in getting the NABH accreditation also. When you are planning your OT, you also need to have this ports for oxygen and the endoscopies on both the ends, both on the head end, on the side end, so that your workstation will get connected as well as your camera system will be connected. When you're going for your system stand for your endoscope monitor, the height of the stand should not be more than 5 feet. Otherwise, it is going to give a pressure on your neck and also to your shoulder. So you will be looking like this and doing it. So it has to be either 5 feet or little less. OT table, I think having a stand OT table is the best, but for a budget of around 75K to all the way up to 2 lakhs, you are having wonderful OT tables. But the thing that you need to see is the height of the OT table should not be more than 30 inches when you're sitting. Otherwise, it is going to hit your legs or it may not be comfortable for you. So that is one point. And if you're going to do OSA cases, the width of the OT table should also be adequate, big OT tables, and your head, the movement of this table should be all the way around, both head down and head up. Many other companies I have also listed for your benefit. Workstation, you may go for a GE or Dragger, but it's very expensive, but wonderful tools are available with Mindray and other systems which are available in the budget of around 4.5 to 5 lakhs. There are 2 gas systems and 3 gas systems that are available. You can go with 2 gas systems itself, but it is very good to have a sevoflurane vaporizer along with this. If you have a pressure controlled workstation, you can use it as well as the ventilator for immediate post-op as well. Monitors, I would insist you to go for Philips, but Mindray and other companies are also making a reasonably good ones. But if you're going for the Philips one, you can go for this CM12 or CM10 one, which is having all the attachments to your end-tidal, BIS monitor, etc. Suction, even though portable suctions are easily available for your very economical price, I would suggest you to go for the central suction unit, at least 4.5 to 5 horsepower, because this will be more powerful and more beneficial for all your fist surgeries, tonsil surgeries, micro ear surgeries, etc. But even though if you have a central suction, I would strongly advise you to have a local portable suction like this, either a Venki's one or etc. OT lights, go for a double domed OT light, at least with a lux of 160 lux, with a budget of anywhere between 75K to 1.5K. Endoscopy systems, Stars, Serval, Striker, all are making good ones. I think for a beginner, even a Vansari or a Serval one is more than enough to start your practice. But if you are going to have your Stars, take it to your OT and have the Serval or the Vansari one in your endoscopy suite. Microscope, Zeiss and Leica are very good, but Sanma Serval are very handy for your budget pocket with a budget of around 3.5 lakhs all the way to 5 lakh. You have to make sure that the head tilt adjustment is available in the microscope that you have, and also a beam splitter is available so that you can visualize it and document it for your future. Having a good cautery, especially the Excel, Valley Lab is good, but Allen makes a wonderful one which is very least expensive with all the attachments that you can have, even the vessel sealing forceps. It is not just the OT and the OT setup, even care has to be taken in having your minor instruments like a bougie, stillets, airway, flexometallic tube, McCoy blades, bipolar instruments, tracheostomy trays, and tonsil instruments, etc. Here I am also showing this monitor that actually alerts you whenever there is a leakage in your oxygen or when the air system goes down. So this is also important when you are having your own setup. Most important thing is having a good post-op ICU. This is a very user-friendly ventilator that is available in the budget of 5 lakhs for 5-year warranty. This is having an inbuilt air compressor. This can be used for your full-blown ICU setup. This is one of the important tools that you need to have it, especially you're going to have a sleep apnea setup. When you're having a fire systems, always make sure that you do not have this powder-based fire extinguisher near your endoscopy system and near your OT. You need to have this one, the one in the middle, that is the CO2 based one, that should be near your OT so that it doesn't destroy your instruments that you have. Once you are ready with the plan, always talk to your ENTs that I had told you about. At least you should have a minimum of 350 to 400 square yards for having a decent setup. But one important advice I would have is don't have a square land. It is always better to have a rectangle one with a 40:60 ratio. Remember, you would need lot of side setback norms that you need to follow. So you have to take that into consideration when you are planning your nursing home. You also have to have at least 120 square feet for your pharmacy, and your rooms should be at least a minimum of 12 into 10. OT, if you have luxury, 20 by 20, if not 18 by 14. The OT floor height should not be 10 feet like you built for other, but it should be at least 11.5 or 12. So when you're planning your construction, you should tell your engineer about that. So otherwise, the headlight is going to hit on your head. So once you plan it, discuss with your colleagues, discuss with your seniors whether it is okay, follow the NABH norms, and then start with this. When you're planning for the bore well, go for at least 8-inch bore norms with both inner tube and outer tube, like how you have for the tracheostomy. You need to have it. Otherwise, there are instances it will get stuck in between. You will have to remove it and change it. Always do a soil test before you start your construction. And this soil test is imperative and mandatory. And when you are constructing the basement itself, you need to plan for your fire norms. You need to have a fire tank and the lift well. The lift well construction is also important because what you see the cabin space for the bed lift is not what you leave for the bed well, lift well. It is much more. It is at least 8 into 6.6 you need to leave. While you are constructing the floors, you will have some breathing space, but at that time you should plan for your wiring systems, how it all should be concealed, whether your AV, whether your electrical wires, whether your OT cables, all should get concealed before you finish off your elevation. Your server room to your OT, your endoscopy room, all cabling should be concealed so that it doesn't show up outside. A good audiovisual integration is also imperative because from your OPD chamber, you should be connecting to your endoscopy suite so that when your junior does it, you can actually visualize it from your OP and you can modify it, correct it, and check it, and even show it to your patient in the OPD. Having a good lab is important. You need to understand that there are 3 para monitors, 5 para monitors for your CBC, and all you need is only 2 important things. One is CBC and the other one is your basic blood analyzer. If you're planning for an NABH, think about this. Think about the ramp. Having a proper ramp is imperative if you're thinking of getting an NABH entry level. So once you do this, you will finally get this picture of how you have visualized. This is how mine came out to be. It is not perfect, but it was a beginner. This is the temple with the parking space. I'll just fast forward it. And this is the waiting lounge for the patient. I'll just fast forward it. This also with the corridor, with the reception, with the pharmacy counter, with 3 consultation chambers. And the most important thing is your own room, how it should be. It should be very spacious. It should be very spacious because that is the most maximum number of time and hours you are going to spend. So that should be spacious. Don't constrain on your OPD. You should have all access to your endoscopy suite, suction, AV, server room, etc. So should also have an access to your endoscopy suite. This is our endoscopy room. How it has a provision to have 2 endoscopy chamber, but we can do even a flexible bronchoscopy with all the accessories that is available, including suction port, oxygen port, etc. This is our audiology suite with the audiology chamber. For the budget of around 40 to 50K, you can have a sound treated room. You can have all the other accessories. You can even have a VNG lab within that same room. Coming to the rooms, I think I have mentioned it before, you need to have at least a space of 10 by 12. But if it is going to be the reason I am saying that is, while you are constructing, you will not think about the bed size. You will think only a 6 feet bed. But for a bed, you need at least 8 feet with the 2 feet on either side. So you have to take all those things into your consideration. And coming to the OT suite, last 1-2 minutes. This is the ICU, wherein the ICU that I had showed has the ventilator, Philips monitor, bed, oxygen port, suction port, air port, and this is your CSSD chamber, wherein initially we can go for a vertical one, later on you can go for a horizontal CSSD, and this is the major OT. You can have a minor OT as well with the setup that I had shown you prior. We also have this conference hall. I think we took the inspiration none other than Dr. Madhusudan sir, and we were very fortunate to open it with Professor KKR along with Professor Singari Prabhakar sir, Madhumani sir, Madhusudan sir, and everyone here. So is that all? No. This is where your question comes back to you. Does it answer most of your questions that I had put forth in the first slide? Almost yes, mostly at least 4 points, yes. But the real challenges are really forward, wherein we have to go for getting into the insurance system, EMR, staff training, recruiting, marketing, MRD, documentation, billing, auditing, medico-legal stance, etc. So to conclude, think and plan before you execute. It's the first step that you take is going to be difficult, but once you take it, the help will come to you as you go in mysterious ways. This is just the beginning, surely. I am not the expert in it. There are so many more experts here, but someone has to lay the foundation to give such talks so that the chain continues and benefits much more youngsters to live their dreams. So it is always nicer to be the leader. You may have to take the risks, yes, but it benefits also comes in the same way, rather than being attached to a corporate hospital or to a setup of elsewhere. So thank you once again for giving this wonderful opportunity. I'll be happy to answer. I think to put forth a 2 or 3 year work within a 15-20 minute talk is very difficult, but on each and every aspect I have gathered a lot of information which I'll be able to dissipate to you. If in case you want to contact me, please feel free to contact me. Thank you seniors and well-wishers who had been my mentor for creating such one. I don't know whether it's the journey started, how it's going to end, I don't know, but let's hope it goes well. Thank you. Sure thing.
Sir, one doubt, Dr. Vijayasagar sir, apart from the cost of the site, how much it costs to start a ENT hospital like this one? Total cost construction, apart from the site, it varies from city to
cost
city.
Would be anywhere between, including the instrumentation, sir.
Yes, infrastructure and building.
Including the instrumentation, I think at least 1.5 CR would be needed, sir.
Only 1.5 CR for construction of the hospital and equipment.
1.5 is bare minimum. 2 will be the best.
Okay.
By 2, I think we can construct, sir. Yes, sir. Without site, that's what his question was.
Yes, yes. Site cost varies from place to
Site
place.
cost is not included in it. Sir, 1500 per square foot, you can have. Yes, yes, including all. I have calculated everything, sir. Yes, sir. I told about each budget of the bare minimum things that you can get it for 50 lakhs. Equipment. But sky is the limit for the person like you, sir. You have top end gadgets that even if I give 10 crores, it will not be enough for you. But I am telling it in the beginner's perspective, at least 2 crores, you can get a decent enough space with the OPD, floor rooms, minimum rooms, and a OT setup.
I think Vijayawada is cheaper than Nandyal, sir. we are paying 2,200 per square feet, nearly 2,000 to 2,200.
Even if you calculate that, sir, approximately how many square feet you need?
You are constructing
6,000 is more than enough for you to have. Sir, I have also included my
Five
home
floors.
in there.
Yeah, okay.
I have, you should exclude
Oh, you
all
have
those.
not included home.
So
Okay.
only ground floor, first floor, and OT floor is more than enough for you. That I think you can get it with the budget what I have told you, sir. Yes, please.
It's a very good guide for the young budding ENT surgeon, sir.
Thank you, sir. Thank you so much.
Sagar, actually, I went on August 14th this year to, with Dr. Ramalingam, he made me to open one door in his hospital. So I was very fortunate. No, Sagar, you have made a data and cabling, data information that he has given enormous importance. He want to store the data of endoscopes, OPD, interiors, theater work. That made him more attractive because majority of us, we don't show importance in data storage. Before the inauguration, by the time we invite the dignitaries and chief guests onto the dais, we will present a 10 minutes PPT because once the dignitary is on the dais, we cannot present the PPT. We just want to show you a 10 minutes PPT about why Madhumani Charitable Society is doing these services since 33 years. And this is the 14th year we are doing this workshop. Over to you, Manideep.
So, I welcome all the delegates who have come to our 14th surgical workshop. So, this is the 33rd year that we are doing free camp. My father, since he started his hospital on the wish of his mother, we are doing this. We do 100 free surgeries. No matter what the surgery is, the investigations, the admissions, discharge medication, everything is free of cost. And this is the banner that we have inaugurated on this Monday by our local politicians and our esteemed politicians who are very close to us. So this is the workshop brochure. And you can see the very eminent international faculty, Dr. Shankar sir and Satish Jain sir. Satish Jain sir will be joining us tomorrow morning. It will be an entire day dedicated to him, so he'll be showing you all the cases. And here is the photo of my grandfather and grandmother. Even I didn't see them. This is the only photo that I have seen. Of course, I have seen my grandmother, but I was a month baby before she passed away. And this is the first opening of our clinic, not here, in the heart of the town, 1991. I was a month baby old, and my grandmother in center, and my father, my mom, and my relatives opening. It was by her hands, and with her blessings, we are right now what we are today. And this is the inauguration of the present hospital, the old Madhumani here, opened by our esteemed senior politician, Katsan Rambupal Reddy Garu. And the free camp, then the opening ceremony, and this was the upgraded Madhumani nursing home 10 years ago with the ICU setup and everything. But once I joined, I wanted to join, so my father was interested in renovating, and we wanted to bring corporate care to a small place like Nandyal in the field of ENT. So whatever that's being done in cities, we want to provide the care to the people of Rayalaseema in Nandyal at an affordable cost. Of course, corporate costs will be big because of due to many reasons. We have the state-of-the-art instrumentation and everything, and I've been bugging him to buy me the latest equipment. So he's been so kind and generous to grant all my desires, and this was the vision, of course, my father's, my mom's, and mine, and he was behind me, helping me in renovating and everything. And this is the exact look that you can see for the elevation. And this is the latest opening again by the esteemed politician, and also all the local, all the front guys are the 5 MLAs of our Nandyal and Kurnool district. So they have come and opened our hospital. Our local MLA, Ravi sir, and Pocha MP, and Ram Reddy sir, and Shilpa Chakrapan Reddy garu. And this is always with the inspiration of our past MP, SPO Reddy garu. We used to organize the free camps. It was inaugurated by him. He was always interested in service activities, and he was inspiration for my father to do this long. And our in Madhumani Charitable Society, all these service activities are being done via this trust, and not only health. So my father wanted to give back to society. You know, you all remember the dialogue in Srimantudu. కొద్దిగా ఊరికి తిరిగి చాలి లేకపోతే లావ్ అయిపోతాము. I think so that's why he stays young. He gives so much to the society. He has inspired me to give so much to the society. And these are all the 6 sectors that we do service. In the education, we give interest-free loans to the poor and needy. It's not like a complete free loan. We do not take interest. And once they get the job, they can pay it in monthly basis. So we just want to give them the sense of responsibility and the sense of support, so that it's just a loan for them, but without interest. And in sports, I'll show. So many have asked me, really, did you guys were doing this even in the beginning? Did your father do did the free camp? I don't think so. So this is the first free camp pamphlet. I mean, not the third. We didn't have first 2. So since 1993, we have been so diligent. We have been so particular, and my father always wanted to give back to the society. So this is the free camp pamphlet back in 1993. We have been doing this for the past 30 years, believe me. So 3,000 free surgeries have been done. And for the past 4 days also, we have been doing, many faculty have joined us and imparted their wisdom and skills and taught me and my father many new things to learn. Always, it's free camp 1 week it's like a surgical feast and entertainment, I call it, because we just work from morning 6 to evening 6, and again work up the cases for the next day. And this is the latest free camp pamphlet. And these are all the guest faculty that have been with us for the past 1 week. Few of them are also joining in the workshop. Dr. Deepak, Srinivas Murthy sir, Arshad Hussain sir, the Bangalore team, they always come. For the past 16 years, they have been coming for at least 1 day, and they operate all complicated cases completely free of cost. And Vidyasagar sir, also the second senior faculty that has been with us for the past 15 years, he's also coming and helping us out. And Gaurav sir, Shankar sir this year, and my brother in the fraternity, Sripati Naidu, Sandeep Naidu, is also coming for the past 2 years. And we also thank Dr. Ravi Krishna and Madhavi ma'am, who are our in-house anesthetists, and they've also been giving free anesthesia for the past 30 years. So I really thank them. Can we have a big round of applause? So we doing us on our part is our motto, but they doing this for the sake of us and in the part of service is a really big thing. And these are few photos, so this is like maybe few years ago, our 3 musketeers before me, Suhas, Srikant and Prashant, they're also seniors to me and our alumnus. And this is the present stainless steel OT that we have upgraded. So with this state of the art, this is of course 2 tables, so this is positive pressure. In the OT that you saw Shankar sir operating, it's a laminar OT. And this is, I think so, this year's myself and Sripati Naidu operating in free camp. And this is few years ago, workshop So yeah, education loans, I think so, MBBS, all the people who are really poor, we give them interest-free loans, and these are all the kids that have, not kids anymore. So these are all the people that have got loan from us, and they're right now doing good, and they've also repaid us. So that's the great part on behalf of them. And I think so, yeah, total amount given interest-free education loan is 45 lakhs over 30 years, and we received 3860, and it's still coming because still few people are yet to get their jobs. And sports, we organize Madhumani Cricket Trophy for the local in the Nandyal and Kurnool district area, the degree and PG institutions. For all of them, we organize a tournament, and that is the trophy that we started after the 2003 World Cup. And cultural, my father is a big dramatist. He even performed in the Nandi stage. He acted in few dramas too. So he is also the founder president of cultural organization called Kala Radhana, which is very active in the state. And the secretary is Dr. Ravi Krishna only. So both of them have been doing service in cultural area, in the cultural part for the past few years. And the latest service activity that he has taken up is Swargadamam. So our graveyard, Hindu graveyard in Nandyal, was so pitiful and so disorganized. So he took this up, and with the help of local people, they formed a trust called Navanirmana Samiti, and with the help of local enthusiasts, they went to house door by door, and they collected the money, and they've renovated the graveyard in such a big way. It's a 5-acre graveyard with LPG gas burning system to cremate, to perform rituals. There's a grievance hall, everything they have renovated in a big way. That is his latest project, and this is the brochure. And my sister, she also finished her dermatology, and she's joining us in Nandyal, establishing a state-of-the-art skin and cosmetology center. Mostly by the end of this year, her clinic will be ready, and she'll start off her career. But we are small hospital in Nandyal, but with a big heart, doing 50 lakh worth, so 100 surgeries. If you even complicated cases, if you take 50,000, all are done free of cost. Even the coblation vands or defibrillator blades, everything we do not charge them. Even the discharge medication is also given free. So I thank my father for starting such a service activity and inspiring me to continue this, and I've told him this will continue on till I take my last breath. So I'm really happy that I have a father and an inspirational figure like him. So thank you. Vijay. So, our present AOI AP President and 6-feet bullet, I welcome Dr. KVS Kumar Chowdhury sir onto the dais. Sir, please. Kumar Chowdhury sir. Go chair. The present IMA State AP President and brother to my father in profession, service, anesthesia, I welcome Dr. G. Ravi Krishna sir onto the dais, sir, please. And we believe in education, so we always love to give some book to the faculty so that they can go and increase their knowledge. And I welcome today's chief guest, ex-educational Higher Education Council Chairman of AP State, Vice Chancellor for several universities, and also the guy who believed in me a lot because he gave his daughter to me, my father-in-law, Dr. L. Venugopal Reddy garu onto the dais. And I welcome today's young and next chief guest, future chairman of SRK institutions, Hemant Reddy, onto the dais. He is also my school buddy, friend, my gaming partner. Yeah. And President-elect of AOI National Branch and today's international faculty, I did not describe him. He is, his surgery has spoken for himself. I welcome Dr. Shankar Medikeri sir onto the dais. I welcome his evergreen personality, ever smiling, and he has guided what he has gone through just before the lecture. I welcome Dr. Vidyasagar sir onto the dais. Sir, please. Please. Sir. And today's another faculty, upcoming young star, bright skull-base surgeon, I welcome Dr. Gaurav Medikeri sir onto the dais. AOAP secretary and close friend to my father, I welcome Dr. Rahman sir onto the dais. A big brother to me in the fraternity and also faculty in the free camp, I welcome Sripati Naidu onto the dais. So, the reason for my existence, the reason for this workshop, the reason for everything I feel regarding Madhumani, and also I don't believe in God because I believe in my parents. I am an atheist, but if there is any God or an energy, that is my mom and dad. So I welcome my everything, my past and my present. Of course, my future will go to my wife. So, mom and dad, please occupy the stage. Thank you. And at the last, senior faculty, he is also like my father's brother. I can call him Pednana. I welcome Singari Prabhakar sir onto the dais, please. Now I hand over the mic to Dr. Ravi Krishna sir to take over the meeting. It will, yeah.
We welcome all you for the 14th ENT live surgical workshop. We invite the chief guest to inaugurate the workshop by lighting the lamp. Sir. I request Dr. Professor Venugopal Reddy garu former Vice Chancellor of Andhra University and Nagarjuna University, former Chairman of Andhra Pradesh Higher Education Council, to light the lamp. I request Dr. Shankar Medikari Garu, AOI National President-elect, to light the lamp and inaugurate the workshop. I invite Dr. KVS Kumar Chaudhary Garu, AOI AP State President, to light the lamp. I invite the family of Madhumani, Dr. Nagamani, Dr. Sindhu, Dr. Deepu, Preeti and Sindhu, Praneeth. Praneeth. Ra. Ah, సరే అది కాదులేండి సార్, అక్కడ వెలిగించాలి, కర్పూరం ఉంది సార్ అట్లా. సార్ ఒక్కసారి మీరు ఫోటో కోసం ఒక్కసారి పట్టుకోండి సార్, మీరు ఒక్కరు పట్టుకోండి సార్, జస్ట్ కీప్ ఇట్ దేర్ అండ్ వీ విల్ హ్యావ్ ఎ ఫోటో. రండి దీపు, ఇట్రా ప్రీతి, రా రోహిత్, ప్రణీత్, కొంచెం ఫోటోలు అందరూ వచ్చేటట్టు ఉండండి. ఐ విల్ ఇదో ఈ ఫోటో నాకు పంపించమా. AOI President-elect Dr. Shankar Medikari is inaugurating the workshop. Thank you, sir. Thank you. Prayer song by Dr. Madhu Preeti.
హలో గణనాయకాయ గణదైవతాయ గణాధ్యక్షాయ ధీమహి గుణశరీరాయ గుణమండితాయ గుణేశానాయ ధీమహి గుణాదీతాయ గుణాధీశాయ గుణప్రవిష్టాయ ధీమహి एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि श्रीगणेशाय धीमहि.
Thank you, Madhu Preeti. You are singing this prayer song for the past several years, the inaugurations. And I request Dr. KVS Chaudhary, AOI AP State President, to address the gathering briefly.
Good afternoon, all dignitaries and dais. Any amount of congratulations on behalf of AOIP will not be enough for the hard work that is being done by Dr. Madhusudan Rao and family. So I want to add upon the word family. So he has been calling me almost for the last, I think, 12-13 years. So I have a family reason that I cannot attend on the end of July. So he called me this year saying that, Doctor, one of the reasons I am preponing is you. So I could not say no. So it took me 12 years to land into Nandyal for this occasion. I am associated with Nandyal for two great people. One was S.P.O. Reddy and the other man is Madhusudan Rao. We had a business with S.P.O. Reddy in the initial days. So once we came into college, our dad stopped doing business. And the other thing, yeah, you have seen so many things. I don't want to waste my time here. There are two things that you should understand. Dr. Madhu saw this in 1991. He saw this 2023 in 1991. So, like that, you also should envision some future, what you want to do or what you want to be after next 15 years or 20 years. Don't plan something like 2 years, what I will do next year as resident, next year as consultant, next year as something. Imagine your future, at least minimum is 15 years, where you want to be and work in that aspect. See, when you're born as child, your parents dreamed of you becoming a doctor or engineer or something else, and that's what you are today. You are a doctor because your parents thought you to be a doctor when you are in first standard itself. But after you became 28 or 30 years, you're all confused what to do. Either I should be a consultant, I work in a medical college, I do this, I do that. But have a vision. You'll be something when you are 45 or 50, but not when you are 32 or 33. Have focus. That's what I'm telling, where you want to be. And the other thing is, love for what you do. Without love for what he does, Madhu is not here today. And he has involved his entire family in the same thing. I'm sure all of them sacrificed so many things for his aim. It is not so easy to convince everyone. So I wish that all of you learn how to focus with love on your work, and I wish the family of Madhusudan Rao a grand success to do in doing good to this society. Thank you for this opportunity.
Thank you, Dr. KVS Chaudhary Garu, for gracing the occasion. Now I request Dr. Hemant Reddy, Director of Ramakrishna Educational Institutions, to address the gathering briefly.
Well, honorable dignitaries on the dais and off the dais, future and present doctors and non-doctors in the hall, a very good morning to one and all. Well, today I'm here on behalf of my father. What I say, like, I've been seeing this hospital since my childhood. Well, I used to remember like this hospital as like where we used to have this playground, so like playing in these hospitals all the time. But coming here after seeing like through the years, like I've been seeing Manideep, and the change that he has bring to this hospital was like, so like when some younger generation comes to the next, I mean like, or like adds to the older generations, what brings the new ideas is like, as you see the innovation and all the new equipmental things you can see in Madhumani. Well, I wish this conference a grand success, and I hope like this conferences goes on for the next 50 years at least. I request Manideep. Thank you guys.
Thank you, Hemant. Now I request Dr. Shankar Medikeri Garu, AOI National President-elect, to address the delegates.
Dignitaries on the dais and off the dais, and ladies and gentlemen. So I never thought that I'm going to address anyway. So at the outset, I would like to thank Dr. Madhusudan Rao for inviting me to participate in this 14th live surgical workshop, which has followed a 33rd free annual camp, which he has been doing for the last so many years. And he has been conducting free camps, almost more than 100 patients every year, with the help of so many ENT surgeons from different parts of the southern India and even from northern India also. So as told by the earlier speaker, I really appreciate his vision, which he had almost about 25-30 years back, and today has been one of the very successful practitioner, and Madhusudan has got a very extensive different facets of his life. So he is really a hero, and he's one of the, I can say, as the role model even for a senior person like me. I really want to imitate some of the things which he has been practicing in his social service, apart from the surgical workshop for the help of the junior faculty. He's doing so much other good social works. So I really wish Madhumani and family to continue this trend, especially to his son, conducting these free camps as well as spreading this knowledge by way of conducting this live surgical workshop for many more years to come. So I wish them all the best, and I hope all of you will enjoy and take benefit out of this surgical workshop. Thank you very much.
Thank you, sir, for coming all over from to Nanjal to participate in this workshop and gracing the occasion. Now I request Dr. Venugopal Reddy Garu. He is a renowned educationist. He worked as Vice Chancellor of prestigious Andhra University. He worked as Vice Chancellor of Nagarjuna University and also Chairman of Andhra Pradesh Higher Education Council. And I request him to address the gathering.
Guests on the dais, invitees, and galaxy of doctors. I think this is the second time that I am witnessing this free camp program organized by Madhumani Nursing Home. I think, as already said, this is the 33rd year. It's almost the third year, which Dr. Madhusudan Rao is organizing a mega camp. As I look at the calculations, if one go by calculations, I think the last year, around 50 lakhs worth of surgeries as well as medicines and other expenditure is involved every year, which means 33 into 50 lakhs, you can imagine how much he has already spent on public domain, mainly. So for, which means a lot of service is extending to the public, not only doing service every day, but at the same time free service is extending to the people of Nandyala and in and around Nandyala. And people are coming from different places also for this sake of surgeries. And he is a very renowned surgeon known in entire Rayalaseema. Of course, that I need not tell you, all of us are very much aware. So the entire family, Dr. Madhusudan Rao, Dr. Nagamani, Manideep, Sindhu, Madhupriti, and Praneeth, all of them are very much associated with the development of the Madhumani Nursing Home as well as all the activities involved in this. See, one thing that is, what I would like to tell you, see, organizing this program is a very difficult task. Inviting people from all over the globe, all over. Last year I have seen several doctors, galaxy of doctors coming from different places. This time also, I think that people have come from different places. So, which shows the connections Dr. Madhusudan Rao has got with different, ENT surgeons all over India. So I wish, then as already, because Dr. Ramakrishna Reddy waited here for some time, but the things have got delayed. That is why he had to go elsewhere. So he left the place, and in his place, of course, his son is here. So he wanted me to convey this message also. He wanted me to convey to the doctor that everything, whatever he plans and does, will be a grand success. And Dr. Madhupriti is also establishing her own clinic as well as dermatology lab here in Nandyala. Within soon, I think maybe in 4 or 5 years, I wish Madhupriti will also organize a camp like this. Very talented girl. I am sure she will definitely come up and extend all her, the service to the entire, not only to Nandyala and around Nandyala people. So I thank everyone for giving me this opportunity. Thank you one and all.
Thank you, sir. It's a great privilege to have you as our guest on this occasion. Now I request Dr. Nagamani Garu, the woman behind all these camps and workshops, to say a few words on this occasion.
Dignitaries on the dais, renowned surgeons, students, we welcome you all for this conference. We worked hard to come to this stage. Why I am telling this? Students are there. You have to fix your mind. Yes, there are no shortcuts for success. Hard work, intelligence makes you this. After coming WhatsApp into the cell phone, YouTube and all social media, everybody wants to kill their time by enjoying that. And everyone's life is different book. You have to write your own book. ఒక చిన్న సంఘటన చెప్తాను. మాకు అసలు నర్సింగ్ హోమ్ లేదు, క్లినిక్ ఉన్నింది. టింపనోప్లాస్టీ పెట్టుకున్నాడు సహదేవుడు సార్ దగ్గర. అన్నీ పోయి ఆయనే అరేంజ్ చేసుకోవాలా. చేసుకొని వచ్చి చేసి నాతో అన్నాడు, నేను ఇంకా చేయలేనేమో సర్జరీ, 3 గంటలు పట్టింది అని చెప్పి. బట్ హీ ఈజ్ నాట్ ద మ్యాన్ ఫర్ లూజింగ్ ఇన్ ఎనీ ఆస్పెక్ట్. అలా స్టార్ట్ అయింది. ఇక్కడ నర్సింగ్ హోమ్ పెట్టినప్పుడు ఫస్ట్ సర్జను ఫోలిస్ క్యాథిటర్ లేదు. అంటే దట్ వాజ్ ద health system at that time. It was in 81. In 81 he had started his nursing home, MS General Surgeon. You have to work. There are no shortcuts. And you have to train the staff. You have to train the staff. Don't expect that staff will know your thoughts and does. This is everyday problem, and you have to train the staff, and you have to teach the staff, and you have to correct the staff. Why I am stressing this point is, many young doctors are there. After seeing one staff, you will get irritated, and you will get many thoughts will come. But you should not get that irritable stage, and you have to train the staff, and you will be peaceful. And I'll thank my staff for dedicating their time and work and learning every stage. Whatever we advise them, we have to correct them when we say. I thank one and all for giving me this opportunity and listening. Thank you, one and all.
Thank you, Dr. Madhumani garu.
Thank my family members, my daughter-in-law and son-in-law, mingling with my family and making us happy and going with our flow. Thank you.
Before inviting Dr. Madhusudan sir to speak on this occasion, I would like to announce very good information to all of you. This year, Indian Medical Association at national level selected 25 doctors, both in academic and service to the society. Out of 425 applications, Indian Medical Association selected 25 doctors, especially Dr. Ketan Desai selected all these awards. And Dr. Madhusudan Rao has been declared for the National IMA Doctors Day Award. And he is going to be presented this award in Kovalam, in Trivandrum, in a National IMA conference in the month of December. And Dr. Madhusudan Rao sir started his practice in 1991. And I have started my anesthesia practice in 1992, and I had the privilege of introducing the cannula to the Nanjal, and I have brought the first pulse oximeter to the Nanjal, and we are associated with surgeries, and I am his anesthetist for the past 32 years, and Dr. Madhavi joined the team for the past 15 years. Along with this surgical anesthesia association, we both had love for the cultural aspect. We have founded Kalaradhana, a very big cultural organization in Nanjal. We are producing stage plays, and we have won several awards at state and national level. Our teams have performed theatre plays in almost all the cities in the country and in almost all the places in the state. Even in Kuwait also we have staged our plays. And along with these arts, we have love for the sports. I am Cricket Association President, and Dr. Madhusudan sir is sponsor for the C.K. Naidu Memorial Trophy. And we are working for the development of the town Nanjal also. It's a great privilege to work with him, and I request Dr. Madhusudan Rao sir to address the gathering on this occasion.
Uh, dignitaries on the dais and stars in the auditorium. I will not take much time because time is very precious. I am interested to show surgeries to you all. Before that, 35 years back, 1988, I came to Nandyal, leaving my job at Gangaram Hospital after my MS in Chandigarh PGI. That's because my mother told, you should serve to your native place. Whether you are in America or whether you are in Delhi or in Jupiter, Mars, that doesn't matter much. Are you serving to your local people? That made me and Madhu and Mani. That's how this hospital formed. We are going to announce a 6 months Madhumani fellowship course on teaching and giving training for young budding ENT surgeons in basics and fundamentals or bread and butter procedures for one person for 6 months. So, interested ENT surgeons can contact me or my son Manideep. This is first time we are introducing a fellowship in Madhumani nursing home, and we are confident that we are having the best equipment even on par with any corporate hospital, and we want to train good ENT surgeons. So this time first time we are announcing. Everybody may think that Madhusudan is organizing 33 years, every year 100 surgeries. Morning I was telling to Vidyasagar, Sagar, it's getting very tiresome, I should stop this huge workload. But after the camp or workshop is over, you get so much of rejuvenated, again the itching starts, again my scratch goes on, and the whole strength for me to scratch myself, and sometimes she also scratches, is my girlfriend, Nagamani, and now 2 pairs have again joined, Manideep, Sindhu, and Preeti, and Praneeth. Madhumani is having the art of scratching themselves for the betterment of the society. So, this is this thing. And Madhumani staff, you are all thinking that this drama is being played by us as an artist, but the whole music, choreography, fighting, music, art, decoration, all because of Madhumani staff. We are almost about 60 member staff. And today we are going to have a face-to-face interactive session, sir. You can ask whatever question you like, write on the paper. We are given a pad. Give it to the organizer here. Dr. Anil Kumar is there, and Dr. Nageshwar Rao sir is there, Maheshwar Reddy is there. The best 3 questions will get prizes. The prize is nothing. It's a good one. 5,000 rupees free for next year registration. There was a small mistune in the music of last year announcement. The winner was unhappy. The responsibility, we have announced that Mr. X or Miss X, Y got this prize. It's your duty to contact us that I got the prize, and we will announce. But they are thinking that we will be contacting and we will be inviting and we will be garlanding them. It's not like that. We will announce and we accept. Please take it in a broader sense. The prize winners will get free registration for the next conference, so that the names or this thing, our names are there always, and you can contact us and get that benefit. Use this thing. And Sunday, tomorrow, Dr. Jain, 5:30, he will be landing at Hyderabad, reaching at 11:30, and he will have a nap. Morning 8 o'clock we will start. The whole day, Dr. Jain, we will be, he is a dynamic surgeon, and actually he is not there for inauguration. So tomorrow, Monday is his birthday. We will have a small felicitation in the theater only, and having a cake cutting, and we do not want to waste time coming all the over here and everything, because Satish Jain was already there. As a last word, values and ethics with futuristic vision. Values and ethics with futuristic vision will always give happiness. Money is not the only thing. Have a wonderful futuristic vision, like what I dreamt. Now 2023, I think 2053, my son, even after 30 years, maybe 63rd ENT free camp and workshop will be there. So the same way, this service to the society, and last, put your hand on your heart and question yourself, am I useful to the society? Am I useful to the society? To your consciousness, if you get the answer yes, you are the best, happiest person on this earth. And that's all. With these few words, thanks a lot for all of you coming all the way, participating in this workshop, making it, and next cases will be no lunch break and continuous we will be showing, and by the time we go and make the theatre arrangement, Dr. Gaurav Medikeri will give a PPT presentation after the felicitations and give to the dignitaries. Thank you very much.
Before closing, I have not completed my speech. I will take a few minutes. Though I am participating in this inauguration program for several years, for the first time as the State IMA President, I am participating in this program. Respected dignitaries on the dais, Dr. Venugopal Reddy Garu, former Vice Chancellor, Dr. Shankar Medikeri Garu, AOI National President-elect, Dr. Chaudhary Garu, AOI AP State President, Dr. Rahman Garu, AOI AP State Secretary, Dr. Madhumani Sir, and all the dignitaries on the dais and off the dais. A warm welcome to you all for Nanjal workshop. Nanjal is known for its several aspects. It is surrounded by several Nandi Shaiva temples. Because of that only, it is being called as Nanjal. And Nanjal is also known for political dynamism. We have elected President of India, Dr. Neelam Sanjeev Reddy. He worked as President of India from 1979 to 84. He got elected from Nanjal. And Dr. P.V. Narasimha Rao Garu, Prime Minister of the country, he got elected from Nanjal. And now Nanjal is famous in ENT circles also. A destination for young and budding ENT surgeons who would like to learn the basics in ENT. And Dr. Madhumani Rao sir coined the term entry to entire basics, having the ENT word in the catchy slogan. And this is the 32nd year he is organizing this free surgical camp. And this is the 14th year surgical workshop, live surgical workshop he is organizing. And I hope Dr. Manideep will carry forward this as desired by his parents. Dear friends, most of you are members of AOI. Certainly AOI will take care of your academic interest and fulfill your academic activities. And many specialty associations are there. They will take care of your academic interest. But when you face a problem in your practice from a public, from a police, or from a politician, from a media, you need an association. That is the Indian Medical Association. Indian Medical Association is the largest professional organization not only in the country, in the entire world, with 4 lakh members in 1750 branches spread over 35 states and union territories. And in our state, we have 98 branches and 20,000 members as its members. So whenever doctors faces a problem, it is the IMA which stands for the problems. IMA is working for the welfare of the doctors practicing modern medicine in the country. We are fighting against the central government for trying to integrate the medicine with all other systems. We are working on the next exam also. And we are facing a lot of problems. And recently we have seen Dr. Vandana Das brutally killed in Kerala. And in Andhra Pradesh we have 2008 Medical Protection Act. Dr. Y.S. Rajasekhar Reddy, himself a doctor, then the Chief Minister of Andhra Pradesh, with the initiation of IMA, he promulgated that act in 2008, and similarly 16 states have followed that act. And 2012, Kerala also adopted the same act. After the incidents of Vandana Das, the Kerala government amended the act with a stringent laws. And we are asking for a Central Medical Protection Act also. And recently we have seen in Rajasthan, right to health. And the government has asked all the private nursing home and hospital to provide medical services without asking money and without telling about the payments. It is the IMA which led the agitation and made the government to rethink and withdraw that bill, and it is the IMA which spearheaded the program there. And we have seen one gynecologist committed suicide in Rajasthan 2 years back when he was booked under attempt to murder case when a patient died in the process of delivery. At that time also, entire IMA stand behind this incident, and SOP, standard operating procedures, under the Supreme Court directions have been issued in several states. So I request all the specialty organizations, specialty association members, ENT doctors or ophthalmologists, cardiologists, you join IMA. So it will protect you. And we spend a lot of money, 10 to 15,000, 25,000 for car insurance, whether we don't know whether the car will meet with an accident or not. Spend 10,000, you will get a protection for your entire life from the Indian Medical Association. So friends, I request you all to join Indian Medical Association, strengthen Indian Medical Association, and get strength from Indian Medical Association. With these words, last word I would like to share is, because I am the anesthetist for the past 32 years in this camp, probably I am one of the few anesthesiologists in the entire country who has worked with the luminaries of the Indian ENT surgeons. I have worked with Mahadevaya sir, Singer Prabhakar sir, Dr. Vidyasagar, Dr. Madhusudan sir, and now Dr. Shankar Medikeri, Dr. Jain, and last year Dr. Janakiram. All luminaries have given anesthesia for the cases done by the luminaries of the ENT surgeon. Thank you, Madhumani family, for making me involved in these camps for the past 32 years and for the past 14 years in the live surgical workshop. And I hope all the delegates will leave this place with enriched knowledge and with enhanced confidence to start your practice in their respective places. Thank you. Thank you.
Now it's our great, memorable, pleasurable moment to felicitate Dr. Shankar Medikeri, who has come earlier for free camp also, and now as a president-elect. Sir, please come on to the felicitation chair, and shawl, garland, turban. Dr. Chaudhary, sir. Garland, Ravi. Turban. Rahman, sir. My feelings of expression are written on this citation. What is Shankar Medikeri, sir, to all of us? He is a middle year gymnast and all these things, sir. This is for you, all the senior surgeons who have come. This plaque is there. Please display in your clinic so that my expressions will be there. Thank you very much, sir. This is with your small photo. We will pack it up and give it to you, sir. Thank you very much, sir. Gift. లిస్ట్ చదవండి, నాకు కూడా తెలియదు. ఎవరికి ఇవ్వాలి? నాకు లిస్ట్ నీ దగ్గర ఉంది. నేను ముందు అరేంజ్ చేసుకోమని చెప్పినాను పేరు. ఇది ఎవరికి? డాక్టర్ రవికృష్ణ, కేవీఎస్, డాక్టర్ ఏఆర్ రెహమాన్, కుమార్ Prabhakar boss, he is my brother, and I always want to wish, I want to see him become angry in your Vidyasagar. He is for the past 15 years he is coming for this free camp as a surgeon to participate. Sir, last Venugopal Reddy garu, Ayyapalli. Gaurav, actually in night discussion enlightened my mind. We have to explore his futuristic vision thoughts.
So, before the OT starts with local tonsillectomy, Gaurav sir will start his lecture.
A small brochure inauguration. This is the program we are organizing for the past 23 years on the occasion of Independence Day celebrations. We organize 75 events for the school children from August 1st to 15th of August, and we will distribute prizes on August 15th. And I request Dr. Venugopal Reddy garu, Dr. KVS Chaudhary garu, Dr. Shankar Medikar garu, Dr. Vidyasagar garu, Dr. Rahman garu. Hemant, etla chudu. Akkada okati.
As President, myself and Dr. Ravi Krishna Secretary, we are running this cultural organization Kala Aradhana from 2000. This is 23rd year, and we are doing this Matrubhumiki Kalarchana.
Photo this నాకు పంపించాను తర్వాత.
In connection with our Independence Day from August 1st to 15th, we conduct almost competition for students in 70 events. You may be getting astonished. Various halls and various galleries, all related to integrity and freedom struggle and India's unity and everything. All the subjects will be in that.
Nearly 5,000 students participate in these programs every year. Apart from this, we organize free training programs in fine arts every year in the month of May. And we prepare stage plays, we organize theatre festivals.
Myself as son and Ravi Krishna as father, we both acted Vamana Bruksham, Dositlo Samudram, many theatre art dramas. We also have the teaching.
Sir, we have acted in Ramoji Film City,
Ramoji
telefilm
Film City,
also.
Telefilm also. Now age is increasing, so
Thank you. Thank you, sir.
Akkada. Little time. I thank our media brothers, both digital and press, for always supporting us in this free camp and workshop. So Gaurav sir.
Thanks for Great. We'll go.
So can we start? Yeah. So very good afternoon to all of you. So I'm Dr. Gaurav Medikeri. I'm a consultant rhinologist and an endoscopic skull-based surgeon. I work predominantly out of two hospitals, Medikeri Hospital, which is my father's place, and I also work through HCG hospitals. So I'm heading skull-based for all 26 centers of HCG group as of now. So today I'm going to be talking to you about the basic stuff on how to read a CT scan of the paranasal sinuses, which is a very important thing for most of our younger doctors here. So if you just look at why we get a CT scan done, there are certain key features that a CT scan is supposed to deliver on. So what is the role of a CT scan? So if put in simple words, it's basically the Google Maps for endoscopic sinus surgery that we need to study before we go into surgery. It is important for us because it helps us to identify key landmarks, key anatomical landmarks, and we make sure that we are on the right track. It also helps us to plan surgery. This is more important if you're dealing with a complex case like modified Lothrop surgery or endoscopic skull-based surgery. And it will also help you identify all the important risk factors and helps you avoid complications. And whenever you find a risk factor, it is always important for us to discuss this with the patient before we venture into surgery. It is never used to diagnose disease alone. This is something that we need to understand. So your decision to do surgery or not to do surgery depends on a lot of other factors rather than just what you see on a CT scan. So I've seen some surgeons where they see haziness on the CT scan and they take away the patient straight away for surgery. That's not a good thing to do. You need to do a SNOT-22 scoring. You need to see their response to steroids. You need to actually see if they genuinely come into the criteria for surgery rather than depending on whether or not they have haziness on the scan. Haziness is found in a lot of conditions, including vaginous granulomatosis, including acute sinusitis, and it is not a key factor in deciding whether or not I would do surgery. So this is sorry. Do we have volume, do we have audio for this? I don't have an audio. Yeah, I have an audio out. Here. Let's put the audio. Okay. So I don't know why we are not getting the audio, but I'll anyway explain the situation. There's 3 surgeons here, and one of them, I don't know what an ENT surgeon who's got a headlamp is doing with a chest X-ray, and the 2 young guys are actually saying, okay, on the X-ray there is a lesion in the chest and maybe we should operate. So then they decide to operate, and this is what happens. So when they come back, obviously the 2 young surgeons are very frustrated because they are the ones who actually went in for surgery. But then the senior surgeon is like, look, the lesion is gone even on the X-ray. We don't have a lesion anymore. So this is what happens when you operate on scans, you know. So you have to remember that we do not operate on scans, we operate on patients. So a scan is only going to help you to do the surgery. It's not going to help you to diagnose whether or not you need to do surgery. Okay. So I have a very robust system because predominantly what I do is rhinology and sinus and skull base surgery. I have a very, very robust system of doing endoscopic sinus surgery. In fact, my residents who come to me also are trained in a similar manner. So this is the checklist that we follow for our patients, and you see that CT scan evaluation comes much after history taking, examinations, not 22, diagnostic nasal endoscopy. After all this, we do a CT scan. And this is the version 1 of my CT scan point-wise evaluation list. So this is something that I created, I think, when I was in my final year of my master's. This is in 2013 that it was created. Now we have I have actually made this into a software actually, where we document all of this data on an app, and with the click of a button it will tell you how many cases of Kiros type 2 you operated, or how many patients had lamina papricea dehiscence and all that. So this was the latest one. Before we went on to the app, this was the latest one that I had used. I'll be showing you glimpses of these towards the, in between when we are doing the lecture. So the idea for this, came to me because I wrote this chapter on complications in endoscopic sinus surgery with Dr. Satish Jain, and I realized that all the complications that ever happen during surgery, they can occur despite having all the information that you have. And why is this happening? Because you are not assimilating this information in a robust manner. So you have the scan, there is a skull base dehiscence, or there is a lamina papricea dehiscence, but still you cause a CSF leak or you enter into the orbit. Why? Because you have not registered it in a correct manner. So documenting this is a very, very important task. Okay. So there are some ground rules which we are going to start off with. So first thing is, always you have to read the scan from the first cut onwards. Don't try to read the scan from somewhere in the middle, because a CT scan is like a movie. It is not just one picture, it is a movie. In fact, I would say, read the scan on DICOM images on your laptop, because you get continuity in data. It is what happens when they print images is that what the radiologist thinks is important, he will print out. He might skip some cuts in between. So I usually just tell them, don't even bother giving the CT scan films, just give me the CD. That way patient saves money on the films also. And read the scan on DICOM images. Always speak about the type of scan. This is mainly for postgraduates who are exam going. So always talk about the type of scan that it is, whether it is a CT with contrast, without contrast, which view, axial view, coronal view, sagittal view. And also try to assess what thickness of the setting has been taken. 1 mm cuts, 0.625 mm cuts, 0.75 mm cuts. So this has to be mentioned. Do not skip the cuts, because there is some interesting pathology in the later cuts. Don't try to skip. Try to read the anatomy first, and then we move on to the pathology. And do not read the scan for pathology the first time around. So always address the pathology later on. So the first film, if you look at, is something called as a scout film. So this will basically tell you in what position the scan was taken and how many cuts were taken. And you can see that there is a difference here. The thickness here is much less than the thickness in this area. So this is probably the area of interest of the operating surgeon or the radiologist. Also, the position in which the scan was taken is very important. You can see there is a debris here. So in the sitting position, it is actually on the floor of maxilla, whereas in the lying position, it is on the roof of maxilla. So this is a free migrating ball of fungal debris actually, which was moving with the patient position. Okay. So this is probably the first cut that you will see in your scan. So as you can see, this is probably a female patient because she's got a nose ring. So here you can also see the upper lateral, lower lateral cartilages and the soft tissue of the upper lip, and the forehead has started to appear here. So here also you can actually figure out something interesting. That is, the details of the nasal valve can be studied on these cuts. You can see the internal and external nasal valves which are there. So the internal nasal valve is nothing but it is between the caudal end of the lower lateral cartilage and the septum. Whereas if this angle is less than 10 degrees, then you have to address it. Why? Because this is the primary cause of the patient's nasal obstruction. So if you do a septoplasty and still the patient is not getting better, if you go back and see, you will see that on the scan itself you will figure out that this nasal valve is not very wide open. So the area which is caudal to the vestibular area, that is the fibrofatty tissues of the lower lateral cartilage and the alar lobule, that is the external nasal valve. So internal nasal valve has higher chances of being narrow, and that needs to be addressed. Whenever we are looking at a scan, we should also register this part in our head. Okay. So the next image that we have here, so you can start to see the appearance of the frontal sinus, the levator palpebrae superioris, the nasofrontal suture line can be seen there. That is the frontal process of the maxilla, the perpendicular plate of ethmoid, the septal cartilage has come into view, and the anterior nasal spine. This is the premaxilla. So what makes you say that it's the premaxilla? It is because you can see that the roots of the incisors and the canine teeth are actually present in this bone. So that is why we call it as the premaxilla. So if you look at the part of the whole maxilla as such, right, there are 5 processes. So this red thing what you're seeing is called as the anterior nasal spine. I don't know if you can see my pointer. Okay, let me just try to get a laser pointer. Sorry. Do we have a laser pointer here? Okay, I think you can see now. Okay, so this red thing what you're seeing is actually the anterior nasal spine. So the teeth bearing part is called as the alveolar process. The horizontal segment that you're seeing here, this is called as the palatine process. This part what you're seeing here is the zygomatic process, and this part which is going upward is called as the frontonasal process. So you have 5 parts of the maxilla. This is important for us to know. So in the next film you're seeing the interfrontal septal, which is creating 2 uneven frontal sinuses, and you can also see that the anterior end of the inferior turbinate has started to appear, and here you can see the alveolar process. Okay, alveolar process, the part which was holding the teeth, right? That is why. Now here you can see there is an incomplete septation here on the left side in the frontal sinus. You can start to see the appearance of the frontal T sign, which we call, or the frontonasal beak here, which is the thickest part of the bone. This is the part which we drill when we are doing a lothrops, right? And here you can start to see this is the palatine process. Now how do I know this is the palatine process? Because it does not contain any teeth. In fact, the 2 palatine processes, when they meet in the midline, they create a vertical ridge of bone, which is called as the maxillary crest, which houses the vomer, right? So this is the palatine process of maxilla. That's why I wanted to show you that video where that maxilla is rotating, so that you understand. So here this is an intraoperative picture. Sorry, not intraoperative, postoperative picture of a patient who's undergone a lothrops. So this dense bone which was there here, this whole dense bone, which is nothing but the frontonasal beak, has been drilled out. Now even at this level there is some things which can go wrong. So this is a surgeon who is trying to open the frontal sinus. So there is blind usage of debrider. He is probing medially, and what is this? Anyone? CSF, correct. Sorry? So you can see the pulsating brain there. Okay. So there are many things which went wrong here, right? Like blind usage of debrider, person is probing medially, using a suction tip to open the sinus. But I'll tell you one thing, none of them is as bad as what actually is there on the CT scan. This patient had frontal aplasia actually. That means there was no frontal sinus at all on the scan. Now with such a scan, this becomes a gross negligence, which means the surgeon can be sued very easily, right, for this CSF leak. So even just presence or absence of frontal sinus itself is a big documentation which needs to be done. The surgeon did not see the scan before surgery, or maybe he did not register it. He went in to open the frontal and he created a CSF leak when there was no frontal sinus at all. Okay, so such silly mistakes can be avoided just by reading the scan and documenting it correctly. Okay, so in the next you can start to see that on the left side here you can see the appearance of the agar nazis, right? Agar nazi, your Haller cell, all these cells which are named, they are nothing but ethmoidal cells which have migrated and pneumatized into other parts of the facial bones. Like agar-nazi is nothing but it is pneumatization of the frontonasal process of maxilla, okay, or lacrimal bone some people say, but either of them is fine. You can also see, just look at this curve of this medial wall, this front ascending process of maxilla, and you can also see there is a notch here which is for the supraorbital nerve and vessels, and the orbit or the eyeball is coming into view here. You can start to see the appearance of the maxillary sinus also. The perpendicular plate and vomer both will be visualized shortly. Now in the next cut you can see both sides agar-nazi have come into the picture, and this creates something which is called as the McDonald sign. McDonald sign is nothing but if you take the medial walls of the agar-nazi along with the perpendicular plate of ethmoid, this is called as the McDonald sign, okay, or this is called as the frontal T sign also. If you take the base, that is the floor of the frontal sinus along with the perpendicular plate of ethmoid, that is called as the frontal T sign, like this, okay. So I told you to observe this smooth curve which is there along the ascending process. If you observe carefully, you can start to see this notch here. Can you see that? So this notch is nothing but the appearance of the lacrimal sac, okay. So that is something also which you need to document. It becomes more prominent in the next few cuts. One thing I want you to observe is, look anteriorly. If you look, I want you to see that this is the level of the floor of the maxillary sinus. We will come to this point later on, when you will start to see that the maxillary sinus becomes deeper as you go backwards, okay. So now you can start to see that this frontal T is being broken. Can you see this? This break in the frontal T is what means that your frontal sinus has opened now, okay. It is opening into the frontal recess, okay. That is what it signifies. You can also see that this groove has become deeper and it is forming the nasolacrimal duct. You will see this very clearly as we proceed. And also here, can you see this tip of the middle turbinate has started to appear, okay. This is something that we need to document. So since we are talking so much about frontal sinus, it is important to bring up this very the latest classification of which is called as the IFAC, which is the International Frontal Sinus Anatomy Classification, which basically they have simplified the whole system into 3 groups now. They have made it as anterior cells, posterior cells and medial cells. So this is pretty much what we need to know. So earlier we used to have Kuhn's type 1, type 2, type 3, type 4, all that is out now. So we have just the agar cell, supra-agar cell or cells. Okay, if there is one cell, it's cell. If it is more than one, it is cells. In the posterior group, you have suprabullar frontal, supraorbital, ethmoidal if it is crossing and going laterally. And in the medial cell, you have the frontal septal or interfrontal sinus cell, which we used to say. That is what is the medial cell. So we're just going to take a look at these cells on the scan, what they look like. Agar-nazi, we all know, it is nothing but pneumatization of the lacrimal bone. It is the mound which is anterior to the middle turbinate, and it is present in all, but agar-nazi, it is the anterior most cell of the ethmoid, but it is not necessarily the most constant cell, okay. So the difference between agar-nazi and bulla ethmoidalis is that agar-nazi is anterior most and bulla ethmoidalis is the most constant anterethmoidal cell. So this is something that you need to understand. Don't get confused between these two, okay. So agar-nazi is present in about 90% of the patients. So in the remaining 10% it may not be present also. That is something that you need to understand. So what happens, what are the variations that can happen with agar-nazi? If you have a very large agar-nazi, right, then and if it is infected, then it makes your life easy actually, because it is thin. So it's easier to open, and when you open it, that means the pneumatization is already quite big. So your frontal sinus drainage pathway will be very big and wide, okay. But if you are not planning to open the agar-nazi to open the frontal, it can make your life difficult. So in such cases, it makes sense to open it off, so that your access to frontal sinus is easier. So you have a wider pathway, that's all. Whereas if you look on the other side here, there is hardly any agar-nazi. Either it has not appeared on the scan yet, or it is a hypoplastic agar. So in such cases, it's going to be difficult for you to open into the frontal, because the bone is going to be thicker. So always remember, the more pneumatized it is, the thinner the bone, the easier to open. The more thicker the bone, you might have to drill. Okay. So coming to the next cell, that is the supra-agar cell. So if you look here, we have the agar nazi and there is a cell above that, so that is called as a supra-agar cell. Okay, but it is not crossing the frontal beak and going above. In supra-agar cells, you have more than one cell. So here you can see this is the agar here, and there are 3 cells which are above the agar. So that is why it is called as supra-agar cells, but it is not crossing the beak. The beak is here. Okay. Now, if you talk about supra-agar frontal cell, you can see this is the agar nazi here. There is a cell which is crossing the beak and going above, and these are all anterior cells. None of them are along the posterior wall. We are not talking about cells here, okay? So we are not talking about these cells right now. We are only talking about cells which are anterior, okay? So this cell is going into the frontal, crossing the frontal beak and going into the sinus, so it's called as a supra-agar frontal cell. Now the posterior recess cells, we have the suprabullar cell. Basically, you have the bulla ethmoidalis here, which is this is the uncinate process, correct? So behind the uncinate process, we have the bulla ethmoidalis cell. Above the bulla ethmoidalis, you can see that there is suprabullar cells. Okay. Again, this is not crossing the frontal beak. That is why it's called as a suprabullar cell. If it crosses the frontal beak, then it is called as a suprabullar frontal cell. Okay. Simple. Now, supraorbital ethmoidal cell is one cell which is crossing the orbit and coming beyond the lamina papyracea over and above the orbit. That is called as a supraorbital ethmoidal cell. Almost always when you have an SOEC, that is supraorbital ethmoidal cell, you will see that the anterethmoid artery will be in a mesentery. Why? Because it pneumatizes behind and anterior to it also. That is the reason why it will be hanging in a mesentery. In such a case, it's very important to document that. So if you do not, then your chance, whenever you are removing the cells, there is a possibility you might damage the anterethmoid and it will retract. Okay. So the pneumatization can go as far as the zygomatic process also. Laterally it can come all the way up till here. I have seen that happen. It's that area. Okay. Second thing is you can do something called as orbital transposition, which is you drill out the lamina and the supraorbital part of the lamina, push the orbit downwards, and then you go and attack that part of the pathology. So these are the 2 options we have. So it's important to figure out how far lateral pneumatization is and how far lateral pathology is also. Third group I told you is the medial group, which is basically the interfrontal septal cell. So this is the frontal sinus, and this is a huge cell which looks like the frontal, but it's actually just pneumatization of the interfrontal septum. So I'll show you one case intraoperatively. This is the frontal sinus. This is the supraorbital cell here, and you can see there is a interseptal cell in this case. Okay. So sagittal is the best view if you want to study frontal sinus cells, because you get very clear distinction between anterior group of cells and posterior group of cells all in one picture. So it makes a lot of sense whenever there is frontal recess pathology or frontal sinus pathology, always ask for sagittal images. So that will help and make your life so much more easier. See the anatomical detail that you have. This is the agar nazi. This is a supraorbital frontal cell, supra-agar frontal cell, right? But if you look at the same image here, you will not be able to tell that with so much confidence, right? So that is why it is always better if you have a sagittal picture. Okay, so this is a very interesting paper which insists that whenever you are dealing with frontal sinus, it is important to have sagittal images in your hand. Because these people, what they did is, they gave 100 cases to a couple of surgeons, and they actually asked them to write down their plan of action, and this is only on the coronal pictures. And after the plan of action was written, they gave the sagittal images to the same surgeons, but they did not tell them that it is the same patient, and they told them to write their plan of action now. And in about 55% of these observations, the surgical plan was changed by about 70% after having the sagittal images in hand. So that is the importance of sagittal images in this, in this case. So just one second. Okay, there was a video which I wanted to show you. Anyway, it's not working. So the next thing that you want to also study on the sagittal picture is something called as the ethmofrontal angle. So if this ethmofrontal angle is more acute, which means that this angle, if it is less, this angle on the where the arrow mark is pointing, if it is less, then it is easier for you to do frontal sinus surgery because you have more space. If the ethmofrontal angle is more obtuse, which means if it is like this, then your ability to do frontal sinus surgery will be more difficult. Ethmofrontal angle usually the range is between 135 to about 171 degrees, and if it does not matter if you are working in the frontal recess, but it matters when you want to go into the frontal sinus per se. So that is where ethmofrontal angle is very important. Now this is another case. This is a case of a frontal sinus osteoma where we had to go into the frontal sinus. You can see that there is, if you observe in the picture sagittal image, you can see that there is collection of mucus above the frontal sinus osteoma. So frontal sinus osteoma, we have 3 grades, that is grade 1, 2, 3. Grade 1, there is no obstruction to the frontal sinus. 2, partial obstruction. 3, complete obstruction. So in grade 2 with symptoms and grade 3 without symptoms also, these 2 are indications for surgery. Okay, because even though there are no symptoms in grade 3, it is only a matter of time before the patient is going to have a mucocele. Like in this case, you can see there is some air at the top, there is some air at the top, but there is collection which has already happened and the sinus is completely blocked. So this will cause erosion of bone once the mucocele forms. So posterior table of frontal sinus will get eroded. That is the reason why it is important to operate this. Okay. So what did we do? So we had to do a drill out here, and you can see that the frontal sinus was opened, and once we opened, that was the frontal osteoma which was blocking the frontal sinus, and you can actually remove it very neatly and nicely without any issue. And this is the post-operative picture of the patient 1 year later. Okay. Now coming back to our scan, now you can start to see that the middle turbinates have started to appear, which means the uncinate process has started, but the free end is not yet visible. That is what it means. Okay. So the NLD also you can see very beautifully now. The NLD on both sides is very nicely visible. So that will be covered by the uncinate process. So you look at the NLD coming down, and if you go further, you can see that on the patient's right side, the NLD has opened. That is the valve of Hasner. Okay. And on the left side, the NLD has not yet opened. Okay. In the next couple of cuts, it will open. That yellow dot that you are seeing there, that is the infraorbital nerve. Okay, which is nothing but continuation of V2 segment of trigeminal nerve, which comes through foramen rotundum. Okay. So this is I have just superimposed how the drainage pathway of the eye is. It's important for you to understand. You have a superior inferior canalicus which becomes common canalicus and the lacrimal sac, because I am going to be demonstrating a DCR next, so I am just telling you that. Okay. So the crista galli has started to appear, which is nothing but, if you take the whole olfactory fossa, the part which divides the olfactory fossa into 2 is called as the crista galli. Okay. So here you can see that both sides the NLD is open through the valve of Hasner. Okay. So now you will see this arrow mark, which is nothing but this is the appearance of the cribriform there. So the medial and lateral lamella of the cribriform, you can see medial lamella will usually be very small, lateral lamella is the one which is long. Okay. So this is the attachment site of the middle turbinate to the junction between the medial and lateral lamella. Here you should observe carefully, because
hello, Gaurav.
Yes, sir.
We are ready here in the theatre.
Yes, sir. Yes, sir. We can carry on, sir. Then I'll stop the lecture. No problem.
Yeah. We will show the local tonsillectomy. Then father is ready with stapes.
Okay, sir. Okay, sir. No worries.
I'm sorry.
Yeah. No, sir. No worries. Because it's anyway it's quite a long lecture, so no worries. Sir.
Right.
You can carry on. Yeah. Thank you. Thank you so much.
Now overhead camera, Babu. Are you all getting the picture from my OT?
Hello.
Yeah. Hello.
Before starting the second session, I would love to invite Dr. Prabhakar sir, KVS Chaudhary sir, and Ravi Babu sir to moderate the next surgical session. And I thank Gaurav sir for his
No, it's a local
lecture.
tonsil.
But sorry for the shortage of time, sir. I know you would love to take an entire day and explain CTPNS, maybe some other time.
That will
Dr. Madhu?
Hello.
Dr. Madhu?
Yeah, Prabhakar.
Yeah, welcome back to surgical session.
Right. So, I think Prabhakar also knows how a local tonsillectomy is done. No pain, Babu. Are you getting the picture of the endoscopy into the
yes.
tonsil?
Yeah.
So what is, this is the injection points we give. This is the first at superior pole of the tonsil. You just
Okay.
pierce and give 1 or 2 cc. Then anterior pillar,
Yes.
lower end.
Yeah.
Next, posterior pillar, superior end,
Yes.
and posterior end, posterior pillar, posterior end.
Yeah.
After that, you go to the bed of the tonsil by just lifting the anterior pillar and
Yes.
go and give about 2 cc into the bed of the tonsil.
Okay.
Before that, we have made the patient to swallow lignocaine or xylocaine viscous and also sprayed 10% xylocaine spray.
Okay.
Now I am holding the tonsil, you are getting the pus from it, and now only mainly 4 instruments: tonsil holding forceps, tooth forceps, dissector and snare. Now I am incising the anterior pillar
Yeah.
with the same forceps, separating the superior pole of the tonsil.
Yeah.
So you recatch the tonsil and take your dissector. So once you get into the, this is the plane. Are you able to see the
Yeah.
plane?
Very clear.
So in the plane of the fibroareolar tissue.
Yeah.
So slowly with the tooth again recatch the tonsil and just the posterior pillar I am dissecting
Sir, yeah.
and coming to the lower pole of the tonsil. Once I feel I have come to the enough amount, I just use a snare, give me snare. I take the snare. This is only a historical demonstration that people used to do local tonsillectomy, but I don't even ask you to dare enough. So I am using this snare, going to the lower pole of the tonsil.
Why are you not advising, Madhu?
What the present generation and the way of the patient's mentality,
No,
it's still
for the
too
sake
tough.
of patients, not for the sake of deadness of the doctor, surgeon.
ఇది పోయిందా ఇది ఇంకొకటి tonsil snare. Right. I have cut the tonsil
Yeah.
and snare and keep it in this thing and taking suction and putting these cotton balls.
So patient is not at all moving. What is the anesthesia you have given?
Anesthesia is Fortwin and Phenergan 45 minutes before surgery.
Okay.
And kind words. Sripati is behind me and he has given the treatment of kind words.
Okay.
Okay?
Madhu,
Now I'll do the
saying
other
as
tonsil also.
Madhu sir might have given verbal anesthesia.
Shall I show you bipolar tonsillectomy?
Yeah. Madhu, what is the instrument you are using to hold the tonsil?
This is tonsil holding forces, very
Okay.
classical.
Okay, okay.
I think only 4 instruments: tonsil holding forceps, tooth forceps, dissector and snare.
Okay.
Sir, bleeding.
So
appears to be
now,
less.
same way, you have to incise the superior and part of the anterior pillar, and you can pass your dissector all around. Yes, now I have passed my snare. The tonsil holding forceps. Now, give me the tooth bipolar forceps.
So this is the extracapsular tonsillectomy.
Yes. So I am putting a cotton ball there. Now I'm teasing the cauterizing. So if anybody asks you, will you do laser tonsillectomy? Yes, this is laser.
Poor man's laser.
Poor man's laser.
But pain will be very much.
But see, I am using cautery very minimal and towards the tonsillar base.
Yeah.
Okay? And not into the bed. If you use here,
Yeah.
you will get pain. What
Okay.
I'm using here.
Okay. Over the tonsil.
Yes. Over the tonsil. And once you come to the lower pole, you have to use a bigger strength. Sripati says, can you do this in sitting? I used to do, but presently I'm making the best, just like a general anesthesia endotracheal tube position only, nothing special. So with the bipolar forceps,
Yeah.
I am cauterizing and separating. I am cauterizing and separating. Okay, last,
Yeah.
I think I have come to the last part of the dissection. Give me the snare. So to be on safe side, you can cauterize the blood vessels.
Okay.
Now the whole tonsil is with me.
Okay.
Now
So left
I am
side
passing
you
my snare.
Yeah.
Some people even totally cauterize the inferior pole and cut with scissors.
Okay.
You can do that also.
Madhu, have you done any time Gilliton's tonsillectomy?
No.
No, because you are showing history, I thought you might have
No,
show that
no.
also.
Scissors. Bipolar forceps.
Madhu, how much time you have waited after giving local infiltration?
10 minutes.
10 minutes.
Yes.
Yeah, so there is a
Scissors.
bloodless surgery.
Artery forceps. See, the snare did not cut the exact. So I am putting the artery forceps
Sir, have you
and
added
removing this
adrenaline also for
and
your
cutting with the
lignocaine, sir?
scissors. Scissors.
Yeah,
yeah.
yeah.
Okay. But the end of this has to be again cauterized because there may be a big vessel here.
No, tonsil is out. So whenever bleeding is more, just initially
you can
during
tie.
the dissection,
No issues.
on dissecting out the upper pole, one cotton ball will
Give me a elevator. So I want to make sure the inferior pole doesn't bleed.
Madhu,
Yes.
have you had any opportunity to tie also in local
Yes,
tonsillectomy?
Tie only during student days.
Okay.
But once these cautery machines have come, I don't think I have used any tie or something.
Okay.
So now I'll remove the cotton balls which I have kept on the left side first. 3 cotton balls. You can use a ferracrylium also. I started exactly at 130.
Okay.
So now it is 139.
Okay. Great.
But I took time for infiltration and was waiting.
16 minutes.
Came with Shankar Medicare and Sar is preparing Stapes patient in the other theatre.
Okay, great.
So in 16
There
minutes,
is a small bleeder here.
Madhu, suppose if you get a severe bleeding, what you will do?
What?
If you get a severe bleeding,
Severe bleeding, huh?
yeah.
We have to identify the vessel, that's all.
See, patient when they getting a severe bleeding,
Got
patient
it.
will have a difficulty to breathe also. If it's a pouring, what you will do?
See, this is the thing that there is a bleeder for me. Oh, there is still a cotton ball. See, I forgot. I thought it's a bleeder. The same. Your good question, Prabhakar. Let us think. There is a bleeder from the superior pole like this.
Yeah.
So you catch hold like this.
Yes.
Okay, this is the bleeder.
Yeah.
Cautery. That's all. I think, hope you have seen the cautery
Yeah, yeah.
black. But as you told, this much cautery will certainly cause some amount of pain.
Yes.
And now see the fossa, clean, neat, your margin of the posterior pillar,
Yeah.
anterior pillar,
Yes.
and here you can see the anterior pillar and posterior pillar.
Yes.
Overhead camera, see what the instruments we have used.
Yeah.
One is tooth forceps,
Yes.
this is the snare, this is the dissector and tonsil holding forceps.
Yeah. Madhu, what
These-
I would like to ask is,
Yes.
suppose for the juniors,
I'll
if
just
patient
relax,
get a
I am relaxing the gag and
Yeah.
I'll see again. Tell me juniors.
no, suppose if they get a severe bleeding and patient is not cooperative in the middle, what you will do?
Severe bleeding, not cooperating in the middle, you have to convert it into general anesthesia.
Yeah, that's what I would like to.
Say,
Yeah.
Ravi Krishna is just before in front of me and he is telling by his body language, convert into general, we are here. Why
Yeah.
should you worry?
So
Yes,
surgeon
yes.
must be prepared.
So you should
Be
be
prepared.
always, anesthetist should be there with you.
Yeah. My anesthetist is there in front
Yeah.
of me. And
Even
what-
while doing local anesthesia also, one must be prepared
Yeah.
for
Yes,
converting
yes,
it at any time,
Suppose
whenever it
you-
warrants, by keeping the anesthetist by side and by having collected the fees.
Sir, you are in a
compliance.
position where there is no anesthetist. You have
Sir.
started the case.
Sir.
Severe bleeding you have encountered. The best way is, if you have a ferracrylium, take Surgicel,
Yeah.
dip it in ferracrylium,
Yeah.
suture the anterior and posterior pillar. That's all.
Okay.
100% the fibrosis of Surgicel is instantaneous.
Okay.
Once you put, it starts fibrosis because other thing.
Okay.
And be in touch with the patient, and because oral cavity, repeated swallowing movements, that means patient is still bleeding. Now almost 1:43, I have given about 3 minutes gap. We will again see whether there is any bleeding as you told. So this is the right side.
Endo camera,
fossa.
We're
please.
not seeing, sir.
Okay.
Now we're seeing. Yes, clear,
Right.
sir.
This side is the left side fossa.
Yes, sir.
I think you can see the fibers of the constrictor muscle, not much, and very good extracapsular extraction, and all the anatomical structures are there. But I beg you or pray you or whatever it may be, don't think that Madhusudan is doing local tonsillectomy and you want me to do. But I was telling that Prabhakar and myself got trained in local tonsillectomy. When I joined in PGI, I requested Professor Mehra, sir, give me one chance, I'll show you how to do local tonsillectomy. He bluntly refused. No. How can you do local tonsillectomy? How, I mean, the words they use is, it's very, very painful, barbaric, keeping the patient open mouth and all, but still patient, మూసేసుకోమ్మా. నీ పేరేం పేరు? ఏ ఊరు నుంచి వస్తున్నావురా? సో సిరివెల్లా అల్తాఫ్, హీ స్టిల్ కాన్షియస్, బట్ Fortwin and Fenergan, your good preparation. But even Madhumani, my son also says, only for historical reasons I am showing, because it is a workshop, there is a procedure called local tonsillectomy. That doesn't mean, but if you are interested, you can do. Only adults. He is a 16 years old boy. Good individual, good counseling. నీకు నోట్లో చిన్న మందు వేస్తాము, ఒక చిన్న ఇంజెక్షన్ ఇస్తాము, నీకు నొప్పి ఉండదు, భయపడవలసిన అవసరం లేదు, బాగా చేస్తాము, అయిపోతుంది.
Verbal anesthesia you are given, sir.
Verbal anesthesia is also
Madhu.
Dr. Ravi sir.
Right.
Madhu. Either both are professors from one from Vishwabharati, one from Shantiram. I don't know whether they are doing any local tonsillectomy in government general hospitals or private medical.
Long ago we used to do, sir.
You are not doing nowadays.
No, nowadays we are not seen.
So don't try to venture.
Or PG, sir.
Yeah, only for the history of the sake you do. Nowadays, to say frankly, we also are not doing in our hospital. Only for demonstration sake like this, I did one surgery. I think a few months back.
Sir, Madhu
Only
sir,
for
we
the
have to
demonstration.
take this recording.
Sir, Madhu
and we
sir.
have to show to our PGs, sir.
Hello, sir.
And,
Yeah.
Madhu sir,
Yeah,
local
tell-
and under local in sitting position.
Yes, I have done in sitting position, but after knowing the comfort of, see, in sitting positions, one of your assistants
Has to hold.
has to hold with a tongue depressor. and he will be holding tongue depressor, but he cannot see what surgeon is doing. He will be standing on the side of the right side of the patient on a backrest of the a wall, and he will be holding the tongue depressor, and you will be infiltrating, and he will be gagging, he will be spitting the blood, saliva onto you, and you will be scolding, and he will be irritating. Ayyo.
But we trained like that.
2000
Afterwards we changed for lying posture.
2023, it is not to continue anymore, because
Yeah.
days were there without anesthesia, everything was done. But now every comfort is there. Give patient comfort. This is only for demonstration that I want to show one side conventional tonsillectomy. Other side I have shown you bipolar tonsillectomy. If time permits, I will show you Colorado needle, beautiful tonsillectomy. Now Dr. Sagar is going to show you cobbleator tonsillectomy, and we are going to show you debrider adenoidectomy. Whichever procedure you would like, and depending upon the patient's pocket, economy, everything you can do. Okay?
Thank you, Madhu.
Thank
Give
you.
a big applause for Madhu.
Thank you
for
very
excellent
much.
demonstration,
Right,
local.
right. And camera to the laminar OT, Dr.
Yeah.
Shankar Medicare is ready.
Sir, Madhu sir.
Okay.
Sir, if any bleeding which is not controllable, that time we can use like a pressure pack
That's what
and we can suture the thing.
Yeah, that's what I told just now.
Yes, sir.
మీరు లేరు అది అడిగినారు.
Yes,
Just
sir.
put a Surgicel.
Yes,
Over
sir.
that you can put a gel foam and suture
When
anterior
you
and
remove the
posterior
suture,
pillars.
sir?
You can suture the anterior and posterior pillars.
No, when you remove the suture.
Vicryl.
Usually 3-4 days you can remove, it will not cause fibrosis.
Okay.
And Surgicel will be there. Gel foam you can suck out.
Okay, sir. Right. Sir.
No problem.
Thank you, sir.
Yeah, Dr. Shankar Madhukeri.
Yes, can you hear me?
Yeah, we are with you.
Okay, ready. See, this is a case of bilateral otosclerosis.
Yeah.
An adult man with both the sides almost equal hearing loss, around
Yeah.
60 decibels. And
can I have-
A-type tympanogram.
Yeah.
Can you see my microscopic picture?
Yes, yes.
And see, clarity is good.
Yeah, we are clear.
Yeah, side type circular type. I have already actually gave the injection.
Yeah.
So local, he has been sedated 45 minutes back.
Yeah.
And what I gave was, I had taken 2% xalocaine,
Okay.
10 cc, and added 8 drops of adrenaline to that.
Okay.
Out of that, I have used maybe maximum 1 cc.
Okay.
Different positions manual, making sure that there is good blanching,
Okay.
but not raising any blebs.
Yeah.
Okay?
Can you show
Side-
preoperative audiogram picture, sir?
Pardon?
It's a case of autosclerosis, na?
Yeah, bilateral otosclerosis.
What is the conductive loss, sir?
Other 60 decibel
Okay.
air conduction. Okay?
Okay, sir.
See, now I am using a side knife.
Yeah.
This is the part I had injected. I am taking 2 vertical cuts, one superiorly.
Yeah. You
Sir,
are
do
starting
you
from
do-
12 o'clock, sir?
Around 12 o'clock.
Okay.
Sir, do you size CT temporal bone in every case of autosclerosis preoperatively?
No, no, I don't.
Okay.
I don't think that is necessary, according to me. Of course.
What are the indications of CT in case of autosclerosis?
Or if you are suspecting a cochlear otosclerosis, or if there is a severe mixed hearing loss, but anyway we are going to do stapes. I hardly do the CT. anytime.
Okay.
So this is around 6 o'clock.
6 o'clock. Sir, you are giving almost vertical or you are giving angle? You are giving straight?
No, little angle.
Okay, okay, okay.
Posteriorly.
Posterior.
Sir, what are your clinical criteria to do the stapedectomy, sir, in autosclerosis?
If the patient has got a conductive hearing loss,
Yes.
with a reasonable good air-bone gap,
Yeah.
at least about 40 decibel, 35-40 decibel air-bone gap with a good neural function.
Yes, sir.
The bone conduction is good, cochlear reserve, what we call,
Yeah.
and then the patient is finding problem in cotton ball. Day to day, his conversation and his work schedules, and he doesn't want to use the hearing aid.
Do you consider any family history of autosclerosis, sir?
What history?
Family history.
Yeah, family history will check this side. I not know. They must ask. We do ask. Many of them do have a family history, but some may not have also.
Yes, sir.
There is a little bit of bleeding, but that's okay.
What is the anterior limit of the elevation, sir, at the 12 o'clock position?
I have not yet elevated now here.
Yeah.
Yeah.
I just started elevating.
What is the anterior limit, sir?
I literally scrape the skin from the posterior, from the bony canal. Yeah, what is this BP here? BP and heart rate? One more cotton ball, slightly bigger. I am using a cotton ball with 4% xylocaine and adrenaline.
Okay.
I usually take about 1 ml of adrenaline. Out of that, 8 drops I put in the 2% xylocaine for injection.
Okay.
And remaining adrenaline, we put 5 ml of 4% xylocaine.
Okay.
And use that for local.
Okay.
As a
I think what is the blood pressure, sir? What is the blood pressure?
That is what I told him to check. How much is it? There is more than unusual bleeding actually.
Yeah.
I don't expect, because I had already injected and kept also. One more cotton ball.
Sir, have you ever practiced the post-auricular incision for the stapes?
No, not really.
What is the
I had
disadvantage,
done couple of
sir?
endoral. There
Sir.
was one
Sir,
equation where there was a very, very narrow canal.
sir.
I had suggested him post-oral, but that patient didn't come. But he got it done somewhere else, but post-oral only. Endoscopic surgery? Yeah, no, I don't do endoscopic surgery at all, endoscopic ear surgery. I'm not very fan, or I'm not a conversant with endoscopic surgery, not like a fan. So this tympanomeatal flap you elevate till you reach the annulus.
So you have reached annulus.
Yeah, almost.
Sir, at what which area you will open the middle ear?
See, I will show you sickle knife. I will open this middle ear. You have this Carrat's notch, no? The posterior margin.
Yes, yes.
Just there.
Yeah.
Yeah. So let's show you. So, sickle knife. Where the annulus is deficient there, I will start there.
Yeah.
Then I will come down here.
You are using a sharp instrument.
Yeah, yeah. I am using a sickle knife. Can you see?
Yeah,
now?
you are using sickle knife.
Yeah. The moment I open that, I will see the chorda many times.
Yeah, chorda tympani.
Okay. Once I open the middle ear with the sickle knife, then I will use the side knife for further elevation of the annulus.
Okay.
Can you see the chorda there?
Yes, yes.
Okay, I'll just separate that chorda.
Yeah. You are pushing it back
Yeah,
posteriorly.
yeah,
Okay.
pushing it back. Side knife. Take this. So now I am using the side knife
Okay.
to elevate the rest of the posterior part or inferior part of the annulus and the
So
drum.
again you are shifting to flag knife.
Yeah. Okay.
Okay. Very clear.
You can see incrustable joint there.
Okay. Sickle knife.
Sir, how can you differentiate this from the superior semicircular canal descent, or also called minor syndrome?
Pardon?
How can you differentiate this atherosclerosis from the minor syndrome, superior semicircular canal descent syndrome?
Superior semicircular, that only I think scan will tell you. I don't.
Sir?
Only scan can
Scan.
tell you.
Only scan.
Or they might also have some fluctuating hearing losses.
Sir.
Third window phenomena sort of thing. Now see, I just lifted the chorda.
Yeah, chorda.
Actually, I am able to see the incudostapedial joint.
Yes.
Okay, now after lifting the chorda, I am going to remove the bony overhang. Hold
Yeah.
this. Curate.
So you are using the curate.
Yeah. I can use, I use curate, and if there is too much of overhang, because already I am seeing the incudostapedial joint,
Yeah.
I am using the curate. Otherwise, if it is completely obstructed, then I might use the chisel
Chisel and
or
hammer.
a gauze,
Okay.
stapedectomy gauze.
Okay. So what
I
is the
hardly
direction, sir?
use a burr.
Yeah, direction of curating. Direction of the curating.
Yeah. Yeah, I am curating from above downwards
Yeah.
and from inside out.
Yeah. Inside out and
Yeah, but sometimes close to the chorda,
yeah.
I may curate from below upwards.
So how to prevent a dislocation of the incus at this juncture? Because many times for the juniors, if while curating, they may dislocate incudostapedial joint or incus.
Yeah, best is first you make the bone thinner
Yeah.
by curating the superficial part,
Okay.
and then you take a smaller curate and just go underneath that and break the final part.
Okay.
Clean material, but cause this look here, please. The tip clean ಮಾಡಿಕೊಡಿ ಅಷ್ಟೇ. How much was the BP? Give another section. Just hold this. I am thinning that bone.
Yes.
See, curating, it depends. Sometimes it may take less time, sometimes it may take more time.
Yeah.
One has to be patient. You can't hurry up.
Yeah.
You can use, if you want to remove a big piece of bone,
Huh.
you can use, if you want, I can just show. Hold this. Give me that gouge in hand. Gouge in hand. See, this is the stapedectomy gouge.
Yeah.
This is the hammer.
Yes.
So it has got something to hold. So you can, if you want to remove a bigger part of the chunk,
Yeah.
you can put it.
This is stapedectomy goose.
Yeah. Here also, see, you have to have a good control,
Yeah.
because this is another thing which can cause dislocation also.
Yeah.
If you are not careful,
Yeah.
ಕೊಡಿ ಗೌಜ್ ಕೊಡಿ hammer ಕೊಡಿ, yeah. I'll put another one more tap here, up little bit. Take this sickle knife. So I did 2-3 fractures there.
Yeah.
Sir, the laser stapedectomy versus conventional stapedectomy. Please comment.
Pardon?
Laser stapedectomy versus conventional stapedectomy.
Yeah, laser stapedectomy, of course, if you have an access, there is nothing like that.
Sir.
But we don't have access to laser. Laser stapedectomy very useful, especially because you don't create any floating footplate or things like that. If you have fracture footplate or a floating footplate, laser will be much better. Here I am going to use, can you see a big chunk of bone?
Yes. Very clear.
See this?
Yeah.
See, the one disadvantage of this stapedectomy gouge and hammer is sometimes if the crack happens down here, and if your chorda gets entangled in that bone piece,
Yeah.
then it is very difficult to separate the chorda.
Okay.
See, now I'll curate. So it went there. So this one.
What is the most common cause of stapedectomy failure, sir?
See, if you are not identified,
Sir.
as somebody was asking earlier, malleus fixation or incudomalleolar fixation, I will tell you how to check the ossicular mobility also once I expose it, or very rarely round window otosclerosis. Failure sometimes if you have put a, means not getting a good result, if you have used a very short piston. I will also tell you how to check that short piston and long piston. There are some special tests you have to do. And audiometry is very important. Your diagnosis has to be perfect.
Sir.
Sometimes an SN loss, especially if it is a unilateral otosclerosis, can be diagnosed as a conductive loss, and you might land up with a problem if you have not detected it early.
Advantage of the titanium piston over the Teflon piston, sir?
No, I have been using always Teflon piston.
Sir.
I don't have any experience with titanium piston. There is a little more bleeding than what I expected.
We can see clearly the long process of incus.
Pardon?
We can see very clearly long process of incus.
Yeah, long process of incus is seen. I want to see the whole foot plate. And the cotton ball kudi.
Hello, sir.
Yeah.
For the benefit of the juniors, can you tell us the limit of the curettage, superiorly and inferiorly?
Yeah, limit of the curettage. Superiorly, until you see this, if you can see the complete round window, the oval window, and if you are able to see still the horizontal part of the facial, it can be better. Posteriorly, you must be able to see the stapedius tendon and the pyramidal process, origin of the stapedius.
Okay.
Yes.
Shakuntalana asked that question.
Yes.
Sir. Yes, sir. Yes, sir.
Yeah, anything you want to add?
Right. See, there are another two methods. There is a small goose also is there with a small handle. But the danger is, if that goose slips, you will hit the IS joint.
I used that. You didn't
You,
say
I think,
sir,
Sir
just
Shankar
used it.
sir telling he used to use. You put at the posterior superior at 11 o'clock and tap.
No, I used just now. You didn't say.
Sorry.
He demonstrated.
Sorry, sir. I was in that case. I think I was right. Micromalleator. Yes. Sir, you use any diamond drill?
No, I don't use much of drill for posterior
right.
bony overhang.
Right.
This stapedectomy goose thing I learned from Professor Karnik, Senior Karnik.
Senior Karle. Okay.
He was my guide.
Okay.
He was very expert using.
Okay.
As Madhu mentioned, one has to be very, very careful.
Yes.
If your left hand, if it slips, then it will dislocate the incus for sure.
Yes.
But
What are
one
the-
thing is, you will remove the bony overhang very fast with that.
Sir, what are the precautions to take to prevent the long process of incus necrosis after clipping the piston?
Clean matter. For
Long process of incus necrosis is the one of the
necrosis. Necrosis, I don't know. We can't. Don't do too much of crimping.
Yes, sir.
Because some of these pistons have got a very good elastic memory. There is not need of much piston.
Usually, I think Teflon pistons that long process incus necrosis is rare, Nageshwar
Not
Rao.
heard much.
Yes, only with
The
titanium.
Steel pistons.
Titanium
they
or steel pistons is more common.
You crush it so much,
Sir.
It's a metal one that causes total avascular supply.
Sir, the Teflon piston wind 360 degrees almost winds around the Incus.
Yes.
But in case of titanium, only after medial wall and lateral wall only there is clipping. The
Okay.
anterior and medial and posterior bars are free in the titanium piston. So the titanium piston will not circumference the entire Incus.
Okay.
But this Teflon circumference almost 270 degrees around the Incus. So chance of necrosis of long process of Incus more with Teflon than this titanium.
Okay.
I have
Do you
not
agree,
seen
sir?
Nagesh, so because you are all in
Yeah, what
academic
I agree.
institutions,
Sir,
you must be coming across.
No,
Sir,
section there
Shankar
block.
sir, have you seen any avascular necrosis because of crimping or something?
With Teflon?
Teflon.
Very rare. In my last, I think, 35, 40 years of experience, I might have seen maybe 2 or 3. But I do regularly stapedectomy.
Yeah.
I do about maybe about 4 to 5 in a month. I've been doing that for so many years now.
Sir, will you be doing reverse stapedectomy or the conventional method?
No, stepidotomy I'll be doing in the sense, once I expose, I'm going to drill the foot plate and I'm going to put the piston, and then I'll separate the incudostapedial joint, cut the stapedius tendon and separate the incudostapedial joint. That is what you call as a reverse stapedectomy?
Yes, sir.
Yeah,
Yes,
Yeah,
sir.
I don't know. I call it as anyway stepidotomy. The advantage of with this is the floating foot plates, dislocation of the foot plate is not common.
Dr. Shankar,
Yes, sir.
now we are able to see the horizontal facial
Yeah,
nerve.
you can see the foot plate.
Yes.
Yeah.
You can see the horizontal part of the facial.
Yes.
I can see the stapedius just.
Yes.
Yes, sir.
I will expose little more. I am comfortable with this.
So what would you do if the horizontal facial nerve is dehiscent?
Don't do anything. As long as the foot plate is exposed, you can do. We had cases where it was not only dehiscent, it was bulging onto the foot plate.
Overhanging.
Overhanging. So, but if you are able to see part of the foot plate, and if you can create a fenestra, you can put a little thinner pistons. Normally I use 0.4 or 0.5. So in such cases 0.3 piston also you can put.
So can you focus?
Can you see the?
Yeah. Sir, fine focus.
Yeah, I'll do that.
Yeah.
I'll just go for one more step higher.
Yeah, yeah. Would you like to put any interface between the facial nerve and stapedius?
No.
This Teflon piston?
Just hold this.
No need.
Skitter is ready, no?
No, what sir is asking
Sir,
is
you have opened the middle ear when you see the obliterate autosclerosis.
Is it in focus now?
Fine
we
focus,
need
sir.
fine focus.
You do. Yeah, he will do it.
After you open the ear, sir, then if you see the obliterate autosclerosis,
Clear. Now it is clear.
Okay.
what will you do in case of obliterate autosclerosis? Because you are not practicing CT temporal bone
Drill.
prior to surgery.
Pick, straight pick. What you do with the foot plate, is it?
Obliterate autosclerosis.
The obliterative autosclerosis, we had to do a drilling only, straight pick.
Drilling only.
Yeah. I use the skitter.
Skitter. Okay.
Yeah, first one. In my this thing, first one here.
Why do you prefer posterior 1/3 foot plate insertion than the anterior 2/3, sir?
Because underneath the anterior to 1/3, 2/3 or the anterior half,
Yes, sir.
the saccule is very closer.
Saccule.
Yeah.
Yeah.
Closer to the anterior part of the foot plate, very suction tip different. Whereas in posterior part of the foot plate, it is a little away.
Okay.
So that you won't cause any stimulation of the saccule and post-op giddiness.
Okay.
Okay, see now, this is important, this test, you move the, I'm moving the handle of the malleus,
Yeah.
I can see the movement of the incus, can you?
Yes,
Yeah.
sir. Yes, sir.
Okay, and now I am directly touching the stapes head and trying to move, it is not moving.
Yes.
This means
Yeah.
stapes is fixed because
Yes.
the incus is moving,
Yeah.
that means there is no incudo-malleolar fixation.
Okay.
Once it happened to me, everything looked like a female patient, conductive loss, exposed, and when I just checked this, incus was fixed.
Sir, in your career, how
Malleus-
many times has that happened, sir, in your experience?
No, I think it is only once.
Okay, sir.
And stapes was moving. I was getting a very good round window reflex. So that too, she was a wife of a justice. Then I had to go back and talk to them. This is the reason. What is? I'm not prepared to explore and others mobilize that incus and all. So either we can do and remove the incus and do an ossiculoplasty, or explore from behind and then try to mobilize that incus. So they agreed to do it. Finish this here now. Okay, one gel foam kudi with adrenal. I am putting a gel foam with adrenal just on the round window,
Okay.
just to stop that little oozing. So
Yeah.
you can put adrenal before you open the vestibule.
Okay.
And then I had to remove that and put another, but she had a very good results also. I interposed the incus.
Sir, if there is a malleoinguinal joint dislocation, what will you do, sir?
So if there is a
Inguinal dislocation, iatrogenic.
then you can remove.
Sir?
Malleoinguinal dislocation, huh?
Yeah. Then you can remove the incus and interpose, no?
Incus
Sir,
and
sir,
again?
in autosclerosis.
In
sir.
autosclerosis. Malleoinguinal
autosclerosis.
dislocation.
Okay.
Iatrogenic malleoinguinal dislocation.
No,
Yeah, then-
hydrogenic.
Why will it
Yeah,
happen? Why will you go to the malleoinguinal area? when you are
Accidentally, if we
By
injure, sir.
accidental. Madhu. By
Yeah,
chance,
if
if
that
happens.
happens, then you have to remove the incus, and then I'll put the prosthesis, that is a piston from the neck of the malleus to the vestibule directly.
So from directly malleus to
Malleus
handle of malleus to the
Yeah.
Malleus
stapes.
stapediopexy has to be done.
Yeah,
Then this.
You need a longer piston for that.
Then the titanium piston.
yeah, you
is
require a longer piston for that. Forceps kodre? Skitter ready idea? Huh? Huh? Bit malum nahi? Just 1 minute, I just put that gel. Oh, kidhar hai? Skitter kidhar hai? Yahi hai? This is your skitter? Yeah. So I am going to use the skitter as I told earlier.
When you when there is a fractured foot plate, sir, again, what is the treatment? What is the choice? When
The fractured foot plate, you have to use a very small right angle pick. If
Sir.
you can pass between the fracture line and
Skitter.
hook
Sir.
out
Sir.
the posterior part of the foot plate, you do that
Sir.
and then put the piston. And if it is a big hole, then you better connect the connective tissue.
When there is a floating foot plate, sir.
Floating foot plate also is very difficult. Sometimes you may have to create a you have to create a fenestra just on the promontory next to the superior part of the foot plate area, oval window,
Sir.
and through that you see whether you can pass your hook.
So
And
can we just put a piston on the floating foot plate and
that is one option, but it might get refixed again. If you don't want to do too much of juggleries and if you are not very confident, that is another option.
Sir, you are doing with a skeeter, sir?
Huh?
You are making a perforation with the skeeter?
Yeah.
Yes.
Sir, can
With
we
a
show in
skeeter.
sir, can we show in conventional method?
What you want?
No, you show the instruments
no.
though, how you can use the conventional method also. Burr and
perforator?
crochet
Yeah, I will show it 1 minute. I will
and
perforate
perforator.
first, and then I will show
for
you the
demonstration purpose, later you
Forceps.
show with the perforator.
Yeah, I will do that.
Sir,
Anyway,
as you are not practicing CT temporal bone,
Yeah.
When there is a collapsed facial nerve because of the dehiscence, natural dehiscence of the horizontal canal of the facial nerve, the hanging of the facial nerve over the foot plate. Will
Yeah.
you operate or not?
No, if I am
If
able
at all, what will you do? How do you put the inserts?
Can you see the, can you just give me
Yes.
2 minutes?
Yeah.
I will finish this drilling. Can you see the foot plate?
Yes,
sir.
yes, very clear.
See, I am at a very low speed.
Yes.
It's a very steady, stable, secure way of holding.
See, I have done caused a depression there.
Yeah.
Yes.
You can see the depression. How to know how much depth you have to go? Is it by
Feeling.
only
That is the
feeling?
Feel.
Feel.
The moment you are
We
done
feel
the
a
burning,
give.
You feel the give, you
Yeah.
have to stop.
And the patient will complain of vertigo immediately.
Yeah.
is the
We
feel
see that?
now, and maybe once in a while you need to check.
Yeah.
Very transient vertigo, sir.
Yeah.
Just immediately jerky vertigo, that's it.
Yeah, Gati.
Do we have a smaller suction? The size of the suction tip is also very important here. Can you see that?
Yeah,
Yes,
very
sir.
I
clear.
drilled so much, but still, hold. Still, I have not opened.
Yeah, yeah.
What is the rotation speed, sir?
He told very low speed he is doing. Yeah.
See, it is quite a thick foot plate.
Very thick
Yeah.
foot plate.
Yes, sir. It's blue line now.
I think now you are able to see the blue line.
Yeah, yeah.
For
See,
just my,
almost there is a
yeah,
small
now
hole.
you
Yeah,
got
yeah.
the small
Hole,
black
can you see
dot.
that?
Yeah, yeah.
We
We can see
the
the
fenestra.
Yeah.
perforation.
So now either you can enlarge that again.
Yeah.
See, I got that. I gave
Feeling.
it gave way
Yes.
the moment that my drill entered the inner ear. Now,
Sir, we-
while sucking, can you see that black hole?
Yeah, we
Yeah,
can
yeah,
see.
It is a
We
perfect,
should. Yeah, we
yeah.
should not suck directly, sir. Or
Pardon?
what is the precautions of suction?
No, I am not sucking directly. You have to suck
Yeah.
on the side,
Side.
Yeah.
adjacent to the
Side
foot
of the
plate.
perforation you have to suck.
Yeah. Now that I don't think.
When you put the
Actually,
suction on the
now-
fenestra opening, the
if
whole
fenestra is
perileaf
small,
will
I
come into the
encourage.
suction.
So see now this is. Otherwise, you have to use the picks. Then you
Suction
perforate
members, sir.
first,
Yeah.
like this, rotate it.
Yes.
First, you use a very fine pick.
Yeah.
Then 0.2, 0.4, 0.6 like that.
Okay.
So in this case, it is not required now. Give me the depth measuring rod. ಇದರಲ್ಲಿ holes ಇದ್ದಿದ್ದಿಲ್ಲ.
Sir, once you put the piston,
Huh.
next case they will start, sir.
Yeah, yeah, please.
Right. Then complete the putting piston. That side,
Can you see
cobbler.
that this is for measuring the depth?
Okay,
This is
the
a measuring rod.
Yeah,
This is a measuring rod.
From that fenestra, I am
Yeah.
seeing the medial surface of the long process of the incus. How much distance?
Yeah, yeah. So medial surface of the long process of the incus is
The
measuring.
first one is 3.5, the lowest one.
Yeah.
Then every 0.25 it will be. So
0.25.
here, 4.25.
Yeah.
Yeah.
So 0.25 millimeters into
I
the
am getting
vestibule.
the third one here
to
Yeah.
add
because the
that.
foot plate also was a bit thick.
Yeah.
I will say little more, about 3.75 or 4 it is.
Okay.
I'll put about 4.25 piston.
Okay, okay. 4.25 you are using.
Yeah, this is the depth. Give me the piston.
What is the size of the piston in the width, circumference, diameter?
See, I have created a 0.8 fenestra.
0.8 fenestra you created.
Yeah. So I usually put 0.4. We don't have
0.4.
0.4 here, so you
Okay.
have 0.5.
Okay.
So I am going to put a 0.5 piston.
0.5.
This
Okay.
is the piston. It is the length is about 5 millimeter.
Yeah.
I am going to put, this is a piston cutting jig.
Piston cutting
Jig.
wig. Okay.
So I am
Zig
putting
zig.
in that
Z.
ZIG.
Zig.
Okay. I have put it in that 4.25. Then can you see there?
Yeah.
No, you can't see.
Is there any technique to how to cut the
1
end?
minute, I'll tell you. I'll just show you this. So can you see my piston now?
Yeah, we can see the piston and also zig 4.25.
Okay,
Yeah.
this jig is blade could you. See, I don't use a regular surgical blade.
Acha.
Surgical blade, again you will have a bevel cutting.
Bevel cutting.
You remember these blades?
Yeah,
we used
this.
to use for shaving
Yeah,
earlier.
shaving blade.
They are very thin.
Yeah.
So I use this. You cut
Yes.
once like this
Acha.
and then cut from the other side.
Other side.
Okay?
Yeah, there is
If
no
there is-
sharp edge.
Yeah, sharp edge. You should have a flat edge.
Okay, good.
Straight pick. So now I am going to open this piston.
So you are opening the eye.
Yeah, I am opening the eye or C, whatever you call.
Okay.
So what is the company of the piston being used?
Osseous company.
Osseous, no.
Yeah, it is available in the stalls.
అది focus చేయమ్మా.
Eon.
పెట్టు. Now I'll just show you from
External camera.
Even Decibel has a
Yeah,
self-crimping.
Decibel is also there. This is a
Self-crimping.
better company. Osseous are able to
Give
see
me
the
forceps.
piston.
Forceps.
Yeah. Fluoroplastic.
Yeah,
Okay.
yeah, yes. Fluoroplastic tape is piston from Osseous company.
Sir, can you focus the...
You see, I am holding it like this.
Yes.
I will go back, hold this. Hold this.
So for the sake of the juniors, it is very important to hold the piston correctly in the
Yeah.
same axis as that of the piston.
నాకు ఇక్కడ మైరింగో ప్లాస్టిక్ నేను ఇక్కడ మైరింగో ప్లాస్టిక్ చేసేస్తాను.
No, the axis, what I mean. The
Suction
same
block.
vertical line.
Suction is blocked, 1 second.
The anterior border of the Encus is spared in the...
Just hold this.
The piston is not engaged with the anterior border. Most of the blood supply of the Encus coming from the anterior border of the Encus. So this anterior border is free from the piston, so that blood supply will not be jeopardized. So there will not be any Encus necrosis.
I will go a little anteriorly and suck.
Sir, it's not focused.
Sir, focus there.
Please.
Fine focus. Yes, yes.
Okay?
Centering of the...
Please center the picture, sir.
Push Madri. Push the head forward, this side. Breath.
Please center the
Just do it
picture.
like this.
Yeah, thank you.
Yeah.
Hold it like this.
It's good, sir. Now.
Yeah.
Can you see that?
Yeah,
Yes,
yeah,
sir.
clear.
It's not
But we
centered.
need centering,
not
sir.
centered.
It is
sir.
going away. Okay.
It's 12 o'clock and one.
You're not holding.
Yeah, now it's clear.
Yes,
Just
sir.
hold it like this.
Yeah. Yeah, clear.
I'm supporting with the left thumb.
Yes.
The forceps. Okay. I'm going first to enter into the
Yes. You
Lower
entered into the
end.
fenestra.
and then put it.
Yeah.
Yes.
Wow,
Very
very
good.
good.
Give a
With
big
a
applause.
single go.
Single go you
Sir
did, sir.
could insert
Yeah.
nicely.
Big applaud for your
Yes.
placing.
Sir, when you are inserting the piston,
Yeah.
first you engage the shaft of the Encus, or you will put the
No, first-
piston
No,
in
no,
the
no.
fenestra.
First the lower
First
end
into the fenestra.
Sir, you will keep in the fenestra.
First.
Yes.
Then only you will engage it.
Yes,
Yeah.
yes. Otherwise, if you first put the upper end,
Sir.
Yeah.
see, it is nicely fitting. There is hardly about a millimeter all round.
Yeah.
Should we do
Okay.
the bend test and the lift test to
Yeah,
confirm the
I
length?
am just coming to that. I don't know, give me the forceps. ಇಲ್ಲ ಇದನ್ನು ಕೊಡಿ ಸ್ಟ್ರೇಟ್ ಪಿಕ್ ಕೊಡಿ it is again going out of the field. Okay.
When there is a persistent stapedial artery, of course, is very less in cases, very few cases.
See, I am pressing bending
Yeah.
test.
Yes, sir.
It's a bending test, sir.
Yeah,
Bending.
I am pressing the shaft.
Yeah.
It is not coming out of the,
So it is snugly fitted into the fenestra.
yeah.
So it is not
It is
coming out of the fenestra.
Length also is not shorter.
Yes, yes.
Is it palatability test, sir?
Actually, yeah, for seeing whether the length is more or less,
Yeah.
or is it perfect.
Yeah.
For lifting
Bending
test, actually,
Ah.
it
Sir,
should
can you
just
make a fine focus? We are not able to appreciate.
appreciate, yeah. Yeah, let him. He is doing it.
Yeah. It is clear.
Actually, I should first remove the superstructure.
Yeah, yeah, yeah.
Now I'm lifting it.
Yes, yes.
Very difficult. There is some bleeding is
Yeah,
happening.
Sir, in a
Actually,
patient,
in
in
the
a-
lifting test,
Yeah.
what should happen? The lower end should just come out of that fenestra.
Yeah.
But here, another possible thing is, better suction could be, because the foot plate also is thick.
Yeah.
So if it is a thin foot plate, it can just come and lie on the side of the fenestra.
Okay.
In a thicker foot plate, it is difficult. Thicker foot plate means that 0.25 has to come out extra.
Yeah.
Okay, scissors could be.
Sir, when there is an adolescent girl,
Forceps,
20,
forceps could be, forceps.
adolescent girl with dry central perforation, CSOM, and autosclerosis,
Yeah.
how do you manage, sir?
Both the sides, huh?
One side,
Same side autosclerosis and CSOM.
No,
Both.
no, same side.
same side, CSOM with dry central perforation with autosclerosis. How do you manage the case?
So we'll do the mastoid tympanoplasty first.
Acha.
Then tell them that second stage she will require stapedectomy.
So once second stage you will do.
Yeah,
second
even in a CSOM you can't do the stapes.
Okay, okay.
Suction. The scissors could be. Curved scissor is nodi. Iris
Sir,
scissor.
dry central perforation.
No, even dry central perforation also.
So in the second stage
I
only
know,
we'll do.
yeah, if dry central perforation also, there will be some amount of infection there.
Okay, so
I know
you.
if we create a perforation during surgery, we close it.
Okay,
But in a case of dry perforation, I would not do a stepidotomy
okay,
along with myringoplasty.
okay. Yeah.
So we have
So
lost the
just-
endoscopic picture, the
Okay.
microscopic picture.
Sir, is it contraindication, sir? Dry CP
I
with
just cut the stapedius
autosclerosis?
tendon. Can you see that?
Yeah.
Okay.
So
You are
we
seeing
missed
the
that.
microscopic picture?
No, we are, but clarity we lost.
We missed the tenotomy step, sir.
Fine focus.
Fine focus is okay.
We missed the tenotomy step. The picture was not.
Sir, when there is extensive cholestoma, for cochlear implantation, subtotal petrosectomy with blind sac closure, you can implant the cochlear implant.
Yeah.
Why don't we do dry central perforation stapes surgery?
Why can't we do dry
Dry-
perforation stapes surgery?
Yeah.
That is
Because
a
in the
very-
extensive
very good-
cholestoma,
Very good question. I know. Madhu, do you have, Madhu is not there here. I don't have an answer. I don't know why not to do.
in the extensive
See, the thing
cholestoma,
is,
Yeah.
in cholesteatoma,
yes.
the patient has already lost all the hearing. Right angle pick, big one. Nammali is nodi. Those could is a profound hearing loss.
Yeah.
You are not going to cause any hearing loss.
Sir.
Okay, only what you are worried is about meningitis or something.
Yes, very, very good answer.
Yeah.
See, In cholecystoma and there is a profound SN loss, you are not going to cause any more hearing loss.
Yeah.
In the atherosclerosis, if you do, there is a very chance that they may go into SN loss,
Yeah.
sensory deafness. That's why better to do in the second stage.
So I'm just separating the incudostapedial joint.
Yeah.
So what instrument
Sir,
did you use for tenotomy?
So what is the instrument you are using to?
This is a right angle pick only.
No, for the tenotomy, sir, stapedial tenotomy.
Slightly longer one, yeah. Little bit flatter.
Okay.
So what instrument did you use for stapedial tenotomy?
I use the iris scissor, curved iris scissor.
Iris scissors.
For cutting the tendon, no?
Okay.
Yes, sir.
Yeah.
The right angle pick bigger.
A question from delegate, sir. How will you diagnose a dry CP with otosclerosis? Because anyway, PTA, you can have AB gap. You can get confused with ossicular
Intraoperative by
intra.
palpating the ossicles.
So you can never know. Impedance will also be B, sir.
Did anybody see that?
Yeah.
I fractured.
Yeah.
As you are telling, in dry CP in the same year with otosclerosis,
Yes.
you will anyway get B type. Then
Stapedial reflex.
Directly.
Stapedial reflex is something you can look for.
No. He's asking, sir, Dr. Shankar,
Yeah.
suppose if there is a dry CP and
Can you see
conductive
the
loss.
1 minute, can you see the superstructure?
Yeah, very nice.
I'm just taking
We
out.
can see.
Okay, togole. Yeah, tell me.
How to differentiate
Suction.
when there is a atherosclerosis or it's only dry CP, conductive loss?
Yes.
Only
If-
otosclerosis or?
It's only dry CP or associated with the atherosclerosis. How to differentiate?
Dry CP, oh, okay.
Dry central perforation with the
only.
conductive loss,
See.
with the B-type curve, B-type impedance.
Yeah.
How to differentiate if the patient is also having atherosclerosis? How to differentiate?
See, I don't know whether you have
Sir,
heard.
stapedial reflex.
I worked with Dr. A.B.R. Desai, very famous otologist of India.
Okay.
So, have you heard anything called as a patch test?
What's the tap?
Patch test.
Test. Yeah, very nice. Sir.
Patch test.
Sir, what the role of stapedial reflex, sir, here?
Yeah, stapedial reflex is one thing.
Yes, sir.
See, if it is only a perforation,
Okay.
you do an audiometry, then you put a gel foam
Okay.
Yeah. Good answer.
soaked in a medicine
Okay.
to close that perforation.
Okay.
Now, what I mean, you remember when some of the patients which come with a perforation,
Yeah.
sometimes they say they hear better.
Yes.
Sometimes when the ear is dry, they don't hear bad.
Yes,
When
you are
the
correct.
ear becomes little wet, they
Yes.
hear better.
Yes.
So that, like that, if you just, very tiny, no, tiny.
Very good answer, sir. And also, Dr. Nasharov said stapedius reflex also will be there.
Yeah, and if you, with a normal stapes mobility and only a dry central perforation, very small.
Yeah.
Take a big.
Sir, hello, sir.
Take one forceps.
Sir, will you show round window reflex here?
1 minute, yeah.
Round window reflex.
I have not checked. Like this, you pick up.
So, Madke sir,
Yeah.
when you suggest junior colleagues when to start this stepidotomy and stapedectomies, and when you suggest PGs, and what is the criteria? So, can you?
No, boss, I don't think there is any fixed criteria, but during our PG days, of course, at that time the accessibility was there for the temporal bones. We were asked to do the temporal bone dissections. We used to get easily the temporal bones from the mortuary in KEM hospital. So we were supposed to do minimum some 50 temporal bones and show them. And initially they will allow you to assist, and then they will give you a chance to do.
Yes,
So,
sir.
but for doing stapes surgery, either 1/4 of this. You would understand, yeah. You should not be able to see. Only I should be able to see. So I am putting such a gel foam seal in this case.
Okay.
Because there is hardly any space. Actually, even if I don't put a seal also, it is fine.
So even that blood, whatever is accumulated, will.
Yeah, within the next 24 to 48 hours, it forms a membrane. And
it will give a good seal.
Yeah.
Will you put any soft tissue plug around the foot plates?
Sir, will you put any soft tissue?
No, I am not putting. That is what I
Acha.
did. If
Hello?
I do a total stapedectomy or a
Okay.
half of the foot plate is removed,
Prabhakar,
Yeah.
then I will put a soft tissue.
Yeah, Dr. Madhu?
with a very good demonstration of stapedectomy or
Yeah.
stepidotomy on right ear under local anesthesia.
Yes.
We are now shifting the camera and audio to another OT where Dr. Vidyasagar is going to show debrider adenoidectomy and cobblator tonsillectomy.
Wow, very good.
And
Yeah.
this is a 12 years old Jashwant
Yes.
who has suffering from chronic adenotonsillectomy infection and blocking of the ears.
Okay.
Actually, because of his deafness and more, we did right myringotomy and grometube insertion, and he got good relief. And now we posted this boy for adenotonsillectomy in the free camp.
Okay.
And now over to Dr.
Madhu, just one
Vidyasagar.
second. See, now I am moving the handle of malleus. It is nicely moving.
Yes, yes.
I won't be able to show the round window because it is covered here with the bone. Again, I have to remove the bone.
Okay.
So this chorda, you can see it is
Ganesh,
just below the head.
Vidyasagar mic ivandi.
Okay.
Okay.
Okay, sir.
So
Thank
now
you.
okay, I'm
Give
just
a big
putting-
applause to Dr. Shankar for excellent demonstration of the stapedectomy under local anesthesia. Thank you very much, sir.
Welcome, welcome.
Yeah. Dr. Vidyasagar?
Hello, sir. Am I
Yeah.
audible?
Yeah, we are with you.
Am I audible, sir?
Yes, yes.
Okay. Sir, this is a boy who is having a bilateral tonsillar enlargement and a significant adenoid enlargement.
Yes.
And with the snoring and sleep apnea along with bilateral otitis media. I think sir has given a wonderful history about it.
Sagar?
So we are going
Sagar?
to... Yes, sir. Yes, sir.
You told sleep apnea also for this child?
Yes, sir. Snoring. But
Snoring.
sleep apnea is not documented, but it is witnessed. That's
Witness.
it.
Okay. So the child is
You can also see the
awakening.
X-ray.
Okay.
Okay.
Sagar, for general anesthesia,
Yes, sir.
for coagulation or normal tonsillectomy, do you infiltrate or you don't infiltrate?
No, sir, I don't.
You don't infiltrate?
No, sir.
Okay.
So
yeah,
the
we are
first
able to
and
see the
foremost
X-ray.
thing
Yeah.
I do is
Yes.
I check the depth of the tonsil.
Acha.
I wanted to see whether it is an endophytic or exophytic.
Endophytic or exophytic?
Yeah.
How to differentiate?
So when I move the tonsil tissue like this, you can see that this is pillar, and you can see the bulge of the tonsil even going up to here.
Yeah.
So that is the actual depth of the tonsil. Okay,
that,
sir?
That means exophytic or endophytic?
It is going endophytic.
Endophytic.
Exophytic means it will be purely away outside the anterior pillar.
Okay.
So now I will be going till that end so that I
Okay.
will be able to visualize the lateral end of the tonsillar tissue.
Okay, okay.
So the most, sir, patient bucking. Sir, patient bucking.
Yeah.
So the most important thing is I am using a coablator tonsillectomy.
Yeah.
You can see
Yeah.
there is a distance between my wand and the tonsillar tissue.
Yes, yes.
Can you see that, sir?
Yeah, yeah, yeah. You are
And
not
there is
touching.
a plasma going there.
Yeah.
So that distance has to be maintained
Yeah.
for doing the dissection.
Okay.
So it is unlike your, I think still the patient is moving. sir.
Unless otherwise there is a bleeding, to use diathermy only you will touch.
Yes. So now you can already see that there is a capsule there,
Yeah.
and I'll be going slowly millimeter by millimeter.
Yeah.
हाफ cc to ml को dilute कर लो.
This one needs
Yeah.
both traction and counter traction, sir.
Okay. Traction and counter traction.
So the traction is given by my tonsil loading forceps,
Yes.
and now and then I do the counter traction with my wand itself.
And okay. While you are using coagulation, how to identify the plane?
Yes. So the most important thing is for the beginners, if they want to use you can use the suction to suction the extra saline. So we need, can you move this from the dissection point? Yeah. So we need, yeah, take it out. we need to use a good magnification. You can even use your microscope
Okay.
to see the plane between the tonsil and the bed. Can
Yeah.
you see here, sir?
Yeah, very clear.
Yes.
So, Sagar, this is extra capsular, huh?
This is extracapsular.
Yes.
Like a regular tonsil I wanted to show.
Yeah, yeah. So, what is the you advise usually for the children?
So
when you are
if
doing
the
only
age of the
tonsillectomy?
child is less than 3 years,
Less than 3 years,
then I would suggest an intracapsular tonsillectomy.
intracapsular.
Your
More
endoscope
than
is
3
coming.
years, you go regularly for the extracapsular.
Yes. So when I'm seeing any oozers, just use the blue color pedal
Yeah, that is
and
the
give a
diathermy.
contact mode.
Contact mode. Otherwise, you will be always no
Going
touch
in
mode.
the ablation mode only.
Okay.
Suction, please.
Suppose if you go into tonsil tissue, what will happen?
If you go into the tonsil, you will be, I'll just show you one place how it will come. Suction on the fossa slowly.
No, it's endoscope.
Yes, gently. I will show you what happens if you go into the tonsils purposely for user.
Sagar, you are seeing directly and doing, or you are seeing the monitor?
I am not seeing the monitor.
Acha.
I am seeing directly and doing.
Okay.
So I don't know actually what you are seeing actually.
Okay, okay, I can understand. We are seeing with the magnification, you are seeing without magnification.
Yes.
So you have gone to the lower pole.
Can I see a tooth forceps? So ideally you need to have a syringe pump.
What?
A syringe pump should be there.
Uh-huh.
In the absence of syringe pump, the saline will be flowing continuously like this.
Okay.
So if it goes like that, one of your assistant have to
Suck.
use the suction to suction it. The other thing is, for the wand to get declogged, you can take it out. Is it clean cheyandi? You have to use a hydrogen peroxide
Okay.
and a brush. I need a brush.
Okay.
brush hydrogen peroxide.
So it will prevent clogging, anti-clogging.
Yes. Suction cheyandi. So, the smaller the age, easier will be the tonsillar dissection. The reason is less amount of repeated inflammation.
Repeated?
With the repeated inflammation,
Okay.
there will be lot more fibrosis and adhesion.
Yeah, yeah.
So, when you get a situation like that,
Yeah.
you use the tooth forceps to do your retraction there. The blue pedal and the yellow pedal has to be precisely under your control, because while you are using the blue pedal, that is the coagulation,
Yeah.
you need to be in the contact mode.
Yeah.
1, 2, 3, 4, 5. Yeah. Suction, please. While you are doing the yellow pedal,
Yeah.
you need to be in the near contact mode.
Okay.
So can you see the layer between the
Yes,
tonsil
yes, yes.
and the bed? Suction, please. Yeah. So you need to have a good retraction like this.
Yes.
And now I'm going towards the lower pole.
Yeah.
And if you see that even in the lower pole, the tonsil is extending laterally to the lingual tonsil area.
Yeah, yeah.
Usually it will not go that laterally.
Yeah. What is the advantage over conventional tonsillectomy?
Sir, your
Coblation.
question?
What is the advantage of coblation over the conventional tonsillectomy?
It is a tough question to answer, sir. For me, I can see the plane very clearly, and the chance of primary hemorrhage is very less. Nothing can beat Dr. Madhusudan sir's dissection, who has performed a wonderful local anesthesia with the classical dissection and snare technique. But for a sleep apnea patient especially,
Yeah.
I would need to see all the muscles to be preserved,
Yeah, yeah.
and it should not be violated if possible,
Yeah.
so that I can use that for reconstruction as needed.
Yeah, yeah.
And if you are really sticking on to your plane clearly, without entering into the muscle plane,
Yeah.
the dissection is cool, good,
Yeah.
and your pain also will be less.
Yeah.
But if you are going into the muscular plane, so can you see how the tonsils are removed?
Yeah,
This
yeah.
is a huge tonsil.
Yeah. Can we have a big applaud for the Sagar for excellent bloodless field demonstration?
Yes. So then, pillar
Sagar,
retractor, please.
Can you
Yes, sir.
take the, you can also see the monitor and show the muscles,
Yes, sir.
posterior pharyngeus.
I'll show them, sir. So after that, you can see
Yeah.
here,
Yes.
if there is any oozes like this,
Yeah,
you can go
touch
for the
mode.
complete contact mode,
Contact as a diathermy mode.
and you can go for the coagulation like this.
Coagulation.
Okay, sir?
Yeah.
Now I'll show you with the endoscope in my hand.
Yeah.
I'll see if I can show you clearly.
Yeah.
Can you see here, sir?
Yeah, we can
You
show
can
very
see
clearly.
even the
Yeah.
fascia is preserved here.
Yes, yes. So if the fascia is preserved, there will not be much pain
There
at
will
all.
not be much bleeding. But
Pain
here
also.
you can see that there is a little bit of muscle exposed.
Fibers.
Fibers.
Yeah, posterior pillar. That is
Yes. But otherwise it's all good.
yeah.
So it's a good dissection
Yeah.
all the way up to the inferior pole, sir.
Yeah, yeah, yeah.
So this patient may not have that much of pain because this area the plane was not violated.
Yeah, yeah, yeah.
Okay?
Yes.
Now I'll go to the opposite side.
Yeah.
Huh? Thank you. And tonsil loading. So for the left side, I'll use the left hand mode.
Okay.
I think it's the lunch time. I don't know how many delegates are there.
No, no. Most of the delegates are there. Only 5 to 10 people went for lunch.
Oh, okay, sir. So again, I'll show you. This is the bulge of the tonsil, sir.
Yes, that is means it is again endophyte.
Yes. So especially for endophytic tonsil,
Yeah.
I think coblated helps you better
Yeah.
because you can identify the plane properly.
Okay.
Can you see the plane here, sir? This is the tonsil.
Yeah, yeah. We need a little bit focusing. They can take the camera a little bit nearer. Thank you. Yeah. Yes.
You can see how it peels off.
Yeah.
Like an orange, we can peel it off,
Yeah.
sir.
Who is holding the scope?
Sripati is holding the scope.
Yeah, yeah.
Thank you.
Thank you, Sripati Naidu. Basha is holding the suction. Basha?
Rafi is holding the
Rafi,
suction,
Rafi.
sir.
Thank you, Rafi.
Thank you, sir.
Even while they are suctioning it,
Yeah.
they can injure the.
Yeah.
Why the saline is more? ज़्यादा था ही कट करो कम करो it was very good no before suction please suction लोपला
वो नहीं तुम्हें प्रेशर ज़्यादा करे तलका ज़्यादा पड़ता है
yeah
हाँ कम करो
suction I think the most important thing is the pump. You need to have the pump.
Yeah.
Without pump, you can see how your saline comes into your way.
Yeah, yeah.
On. Without saline, it will not work. Suction. So the ooze that you see is not from the area of dissection.
Yeah.
Sir, patient bucking, sir.
और एक 1 ml दे वाला dose
Tonsil is also, I think, friable.
Tonsil is also friable, you can see.
Yeah.
That's the first of the hand.
Yeah.
Can you give any advice or tip for the juniors how to catch?
So this is how I catch when there is a friable tonsil.
Okay.
I use a tooth forceps instead of.
Forceps. Okay.
Why you are doing that? Please don't do that.
ఏం చేయలేదు సార్
ఎంత సెలైన్ వస్తుంది బా సక్షన్ చేయండి ప్లీజ్ చాలా ఎక్కువ వస్తుందండి
తగ్గిస్తాను
He connected to the
ఇందాక
pressure
చాలా
pump.
బాగుండే కదా
ఇప్పుడు చూడండి సార్
ఎందుకు పంప్ పెట్టారు పంప్ తీసేయండి
పంప్ ఏం పెట్టలేదు సార్ తీసేసాం
లేదు బీపీ కఫ్ ఏదో పెట్టారు కదా తీయండి
తీసేసినాం సార్ తీసేసినాం
యా
ठीक है सर
యా సర్జరీ ఫీల్డ్ మీరు మధ్యలో రాకూడదు సో దిస్ ఇస్ ద fibril.
Yeah, yeah.
See how I am using my tooth forceps
Yes.
to hold it
Yeah.
and retract.
Yes.
So the holding side, you may have some oozes.
Yeah.
Yeah, now I will take the tonsil holder. You see how it is friable.
Yeah, yeah. What is the setting, Sagar, for the coagulation you are using now?
Sir.
Setting in the coagulation?
Settings, as of now I am using 7 and 3.
7 and 3, okay.
But if I am having a lot more dissection to do, then I will go even up to 8 and 4 or even sometimes 9 and 5.
Okay, okay.
But just remember, just because it is 9 and 5, don't think that it is going to work suction, please. Yeah. So if you have this pump